I'd like to welcome everybody to the fifth International MiECTS Conference. For those of you that aren't yet familiar with the society, this was initially founded in Thessaloniki a number of years ago, and I think it's a fairly unique consortium because it really is a multidisciplinary international society, including surgery, anesthesia, perfusion, and members of industry to try to come together to look at the most optimal way of managing cardiopulmonary bypass and ultimately improving patient outcomes. So, as I said, I think one of the unique aspects of this society is the fact that it is multidisciplinary and international. So we really get a very broad perspective. And having said that, we're going to be making a number of presentations and some scientific abstracts today. But very important is the participation. All of you here have an interest in this in these fields. So please don't hesitate. If you have any questions or things are unclear, the whole idea is to have a very interactive format. By way of background, Cyril Sarek and I are particularly pleased that this meeting is actually happening, since it was initially going to be held in 2019, and then of course very shortly the pandemic came along, and so here we are 3 years later. This is the long-awaited fifth International MiECTS Conference. We're being live streamed on CTSNet. And we're interacting with live media, the group currently in Greece, who are helping to coordinate the broadcast of this whole seminar. I'd like to particularly thank all of the sponsors that have helped make this possible. I think we have one last order of business. I'm the past president of the MiECTS Society, and I in fact have the official gold medal that has been handed on now for the last couple of seminars, and so it's my a real pleasure to hand this on now to the new president of MiECTS, which is Cyril Sarek. And if Cyril wants to come up here and make a couple of comments and actually gets to wear the medal. Now, here we go, bud.
Well, thank you.
There we are.
I have to bow to him.
There you go.
Well, thank you. Welcome, everyone. It's an honor and a privilege to serve as the president of the Minimally Invasive Extracorporeal Technologies International Society. Our society is dedicated to the investigation, support, and future development of physiologically based minimally invasive extracorporeal perfusion and related therapies. It's the only society that's truly multidisciplinary. Its membership is 30% cardiac surgeons, 30% anesthetists, and 30% perfusionists. And with equal representation on our steering committee and board of directors, with myself being the first perfusion president of the society. And has it been 10 years? The society's 10 years old now? Eight years old? 8 years old. I think for us to truly improve patient outcomes for cardiac surgery, we need all three disciplines, and they all need to work together in unison. What one does during the operation has a direct effect on the other. So you can't have minimally invasive cardiac surgery without a minimally invasive perfusion strategy or anesthesia strategy. So they all come hand in hand. Therefore, as a society, MiECTS is committed to the promotion of safe, effective, and innovative minimally invasive technologies and techniques for cardiac surgery with a scientific evidence-based rationale. So I want to thank the Canadian Society of Clinical Perfusion for joining us to help introduce and promote this concept into Canada. We do have, we have basically 2 centers in Canada that are doing MiECT surgeries. One is Trillium Health Center, which has been doing this for in Mississauga, Ontario, who's been doing this for almost 20 years now. And the other is Toronto General Hospital, where I'm from, in which we started doing this about 3 years ago, I guess. 4 years ago. Okay, 4 years ago. So I think it's very important for us to, to be able to get together and learn about this technology and how we can basically improve patient outcomes. That's what it's all about. So yeah, so we have a great program, I think, and we're going to introduce this technology to everybody. And please ask questions. Please, open your minds and and hopefully we'll have a good session. So as I said before, you can download your programs. Just go to cscp.ca and it comes right up. Niagara-on-the-Lake agenda. Let's hit it. So without further ado, I think we will start our next presenter, or our first presenter, I shouldn't say, not our next presenter. So our first presenter is Polychronis Antoniadis. He's an associate professor of cardiac surgery and for Aristotle University in Thessaloniki, the HEPA University Hospital in Thessaloniki, Greece, and he's also the secretary of MiECTS and a good friend. And he's going to talk about. He's just going to give you an introduction into MiECT strategy.
Good morning, and thank you, John. Thank you, Cyril, and thank you all for coming here and actually taking part in this multidisciplinary symposium, not only on perfusion, but also in cardiac surgery in general, and also to a strategy that we'll describe soon, and I hope that it will be adopted by all of you. So we move to the introduction of what we call a minimally invasive extracorporeal circulation, which by definition is not a single circuit, but it's a way of thinking. I would like to declare first that I'm a cardiac surgeon, but I'm a cardiac surgeon, let's say, committed not only to promoting cardiac surgery, but promoting cardiac surgery through promoting physiologic perfusion. So it's very, very important for cardiac surgery to promote technology, and this could only be made possible through the cooperation. So please, I will start my talk by inviting you all to register to MiECTS. It's www.miects.org. So please register. We will accept you immediately. It's complimentary. It's free of charge. So you will receive not many times, but not very, very frequently, so that you will get, let's say, annoyed. But you will receive news and the events that we're doing, and we will keep a very, very close communication. So actually, the minimally invasive corporeal circulation, in our perspective, is the future of cardiac surgery in general. So this is the future. And why is it the future? Because there has been, as described in this very, very nice book by Montero, there has been a lack of, let's say, adoption of new extracorporeal technologies in cardiac surgery, possibly because there was an economic issue, or there was a lack of an incentive, let's say, in adopting latest technology in doing cardiac surgery. And this is actually what minimally invasive extracorporeal circulation is doing. So the classical thinking, this is how the cardiothoracic team is working, is that The operative result is depending on the surgical technique. So the surgeon becomes a lot better. He is doing small incisions. He is doing an alternative approach. This is related to the optimal result after cardiac surgery. Okay, so by changing the incision, possibly we get a better outcome for the patient. But this is not the case. The operative result is definitely in cardiac surgery a combination of three major factors. It is, we start first from the anesthetist, who is scientist, who's a doctor, is not the anesthetizer. So it's not somebody that's only giving anesthesia. So we get from the program, let's say, from the rota, who's ever the anesthetist, and we are doing the operation. So the anesthesiologist is of utmost importance in the outcome of a cardiac surgical procedure. It's the surgeon that is the stapler. So it's not only stapling, but it's also guiding and coordinating the procedure. And it's also the technician, which is the perfusionist. This is not a technician. This is not how it should be. It should be a multidisciplinary team of scientists that actually work on the same path and aim for the same purpose. And which is the ultimate purpose of cardiac surgery? If we check the regular database that the STS is publishing every year, we can check that there is definitely an operative mortality after cardiac surgical procedure. So despite the advancement in cardiac surgical technique, there will always be mortality, and most importantly, there will always be major morbidity after cardiac surgery. And why is this major morbidity for? Is it because of the cardiac surgical technique? No, we can actually see that the morbidity is rising as the complexity of the procedure is rising, and the complexity of the procedure is related per se to the duration of extracorporeal circulation. So definitely extracorporeal circulation plays a major role in the outcome of a cardiac surgical procedures. And if we take a closer look, let's say on the most complex procedures like the mitral valve replacement combined with coronary artery bypass grafting, we will see that the rate of complications actually approaches 30 to 40%. And this is important in terms of healthcare outcomes and cost management. So we were asked once about to write an editorial, whether perfusion plays a role in cardiac surgery, and perfusion matters. The perfusion will definitely play a role in cardiac surgery. Extracorporeal circulation will definitely play a role in any type of cardiac surgery. Why? Because these are the recent images that we get from the microcirculation evaluation that we're performing in theater. So this is the sublingual microcirculation before cardiopulmonary bypass, and this is the same spot just after entering cardiopulmonary bypass. And we can clearly see that there is a difference, a significant difference in perfusion. And this difference in perfusion, this, let's say, reduction in perfusion, it's not abnormal, but it's a reduced perfusion, definitely will have an outcome in terms of end organ function. So what we aim for as a scientific society, as MIECTS, is a more physiologic cardiac surgery, which goes actually through a more physiologic perfusion, an extracorporeal circulation that will keep in the best possible degree body's homeostasis. So what was the situation before 2016? As John Merkin said, MIECTS was founded in 2014, and until 2016, there was, this is our friend and eminent perfusionist, Rob Baker, who actually developed guidelines. The guidelines were developed by perfusionists and were addressed to perfusionists. So it was, let's say, working as a separate part. So it was 100% perfusionist that provided guidelines for, let's say, having a normal or optimal course during surgery. But this kind of thinking, so the surgeons are providing surgical guidelines, the anesthesiologists have their own guidelines, and the perfusionists have their own guidelines, recirculates the same old thinking that produces the same results. So it doesn't allow people to work together. And the future in cardiac surgery is definitely to incorporate new technology. Of course, this goes to minimally invasive cardiac surgery. This goes to transcatheter therapies as well. Yes, but this also applies to extracorporeal circulation. So the clinical perfusionist turns from a technician to a scientist. And of course, the Canadian society and the American societies have clearly developed this view over the years, but this is not the case in other areas of the world. We come from Europe, and there are also other parts in Asia or in in other continents that the perfusionist is just a technician and not a scientist. So the perfusionist is a scientist that provides perfusion. So the whole thing started with minimally invasive extracorporeal circulation in 2002 in Paris and 2004 in Regensburg, who were the first to develop the concept of minimal invasive, of minimal extracorporeal circuits, of mini bypass. Okay, and then they have turned the first, let's say, concept by Gibbon to the circuit, to the type 1 MiECT circuit that Apostolos will soon explain. The circuit developed by the perfusionist Alois Philipp in Regensburg, who was a very, very simple circuit. It's like an ECMO circuit that was doing cardiac surgery. So if we consider the era of cardiac surgery, this was the turning from the conventional CPB. Then we went, when we actually evaluated the results of cardiopulmonary perfusion, if there is problem in perfusion, then why don't we take off the perfusion? It was the concept in OPCAP surgery that was developed in the late 80s, 90s, and early 2000 that we can do cardiac surgery, coronary surgery without extracorporeal circulation. We know that the results are not optimal in terms of long-term outcomes with off-pump surgery. So then came minimally invasive extracorporeal circulation to say that this is the future because it applies to all types of cardiac surgery. So we don't have to stick on the coronary cases. Coronary cases are 50% of the cardiac workload, but it goes less and less and less. So cardiac surgery should not stick on coronary surgery, and it should apply an extracorporeal circulation that fits and covers all areas. So the results coming from the research in terms of closed circuits, use of centrifugal pumps, biocompatible, not necessarily heparin bonding circuits, and minimizing the pump. That's the whole concept. Make it short, but the essence is not to make it short in dimension, it's to make it more physiologic in function. So this created the mini CPB systems in the 90s. And somewhere there came the MiECTs that actually provided a common place, a common language to discuss. So this is the type 1 MiECT. It's an ECMO, literally, circuit without a venous reservoir that you can do coronary cases. And this is the published experience in 2004 by Regensburg. This was actually the first publication that was multidisciplinary. So it was surgeons like Andreas Liebold, anesthesiologists like Christoph Wiesenack, and perfusionist Alois Philipp, who actually developed a new concept in performing coronary surgery. And the results, even from the early days, were even more than optimal. So they were optimal in terms of reducing the inflammatory response as the beating heart surgery is doing during the intraoperative and immediate postoperative period. It was clear from the beginning that this was a potent and effective blood conservation strategy. And blood conservation is very, very important in terms of improving patient outcomes and in terms of reducing healthcare costs. So this was most important there. This is our first published paper with the minimal invasive extracorporeal circulation that denotes that there is a great reduction even from the first cases, even from the first patients, to intraoperative need for blood transfusion, to the total need for blood transfusion as well, even in the ICU, and to the blood loss. An improvement in myocardial protection was shown, especially as an improved myocardial protection during the whole perioperative course, and not as a result of the cardioplegia per se. Reduction in the incidence of postoperative atrial fibrillation, we will have time to discuss it during the next presentation. Reduction in the number of embolic events that relates to the neurocognitive outcome that is always much more frequent, and I consider it possibly more important than the stroke. The rate of stroke is 1%, 2%, 3%, but the rate of neurocognitive outcome, the derangement, the neurocognitive function would approach 60%, and it is important after cardiac surgery, and it is actually the effect of perfusion to the function of the most, let's say, delicate organ, that is the brain. So here came the evolution. So actually, as the phone evolved from the classic one that you were turning this wheel to the new smartphones, then it took almost 50 years to have the new, let's say, sophisticated digital heart-lung machines, and then to turn from type 1 MiECT that Regensburg advocated to the contemporary type 4, the hybrid, the modular configuration that you will have the chance to to see in to see in function, and we'll have the time to discuss. And that actually creates the most versatile and the most advanced and the most complete form of minimally invasive extracorporeal circulation. So actually, the concept of minimizing the pump went to make it a device, a concept, a strategy that will actually cater for all cardiac surgical procedures and could accommodate every scenario that could happen during the case. So as a university, as a medical school, we consider that MIECT Type 4 is the state-of-the-art in perfusion and could actually replace any type of extracorporeal circulation. So this is actually the motto, the essence of the society. The first important achievement was in 2015 to create a common language. So all this terminology, miniaturized, mini, minimized, minimal, turned to minimal invasive because it's not a short circuit, but it's a more physiologic circuit. So we discuss about minimal invasive extracorporeal circulation that have main components, which are the closed CPV circuit, the biocompatible surfaces, reduced priming volume, the centrifugal pump, the membrane oxygenator, the venous bubble trap or the venous air removing device that actually handles the air, and the shed blood management system that is necessary, and it's the autotransfusion device. Additional components are the vents, a soft bag or soft cell reservoir, and the modular system accommodate the hard cell reservoir we will discuss. So this is the advancement, the circle of advancement in extracorporeal technologies. So all these advances have been incorporated in the circuits, not as a whole creating the minimally invasive extracorporeal circulation by many centers, but as creating the optimized ECC. So by taking some of these advancements could create an optimized extracorporeal circulation. But unless you develop the whole philosophy that actually has as a pillar, as a mainstay, the closed system and the elimination of cardiotomy suction. So definitely the physiology of the closed system, this creates the minimally invasive extracorporeal circulation. So the critical step is from introducing the compatible surfaces, using a centrifugal pump, using cell salvage, separating the shed blood, minimizing the circuit to advance further in having a closed circuit without a cardiotomy suction. And this relates only to the circuit. During our first meeting in 2014, we developed the concept that minimally invasive extracorporeal circulation is not a circuit, but it's a strategy that involves the cardiac surgeon, the anesthesiologist, and the perfusionist as a team. So we will have time, Apostolos will describe the circuit in a few minutes. So it's the system that is added. So it's the peripheral, like the cell saver device, and the advanced monitoring that creates a system. And when we talk about advanced monitoring, it's our pleasure, it's our honor to have John Merkin in our society, who developed advanced brain monitoring that is not a target organ only. It's an index organ. It's an indicator of global perfusion and global end organ function. And also we have the goal-directed perfusion, the inline metabolic monitoring that actually guides perfusion. So incorporation of monitoring into the circuit creates a system. And when the goal-directed perfusion and the point of care management by the anesthesiologist is performed in theater, real time. So this creates a whole strategy that becomes, let's say, the pillar of having a better result after cardiac surgery. Why it is important, the goal-directed perfusion? Because actually you create an environment of physiologic perfusion. If you do not have goal-directed perfusion and inline monitoring, you cannot perform optimal perfusion in terms of physiological monitoring of end organ function. What's the gain? If we discuss with only evidence-based data, the most important determinant of successful goal-directed perfusion is kidney function. So kidney is an organ that is easier than the brain to detect difference in function, to detect an abnormality in function. And as the GIFT trial by Ranucci suggested, the kidneys are the first organs to develop a postoperative dysfunction when the monitoring, when the perfusion is not goal-directed. And also I discussed about incorporating point of care management, and point of care management of coagulation is critical. And actually minimally invasive extracorporeal circulation promotes all these protocols of advanced coagulation monitoring during theater. So instead of monitoring the hematocrit, the platelet number, which is useless, PT and APTT, which is also useless, and fibrinogen, and ACT, that is actually, as Professor Georgiadou will discuss tomorrow, is very, very unreliable in terms of what is the element of the coagulation function, of the coagulation factor that is not working well. We have detailed contemporary monitoring, not only of heparin management, but also detailed monitoring of coagulation cascade with rotational thromboelastometry and platelet function with aggregometry. And this applied to the cardiac surgical procedure creates a physiologic procedure. So is this the case? Does this apply to all scenarios? If we take one of the most advanced areas and the most advanced societies like the MiECT, Robert Groom actually detected 6 years ago that only less than 30% of perfusionists monitor routinely SVO2, VCO2, almost none, and lactate measurement was performed in 20 to 30% routinely of procedures done in the States. So goal-directed perfusion, this is not the case in 2022, but this actually shows the path that the research and the advances in perfusion went through the last years, and I'm sure that nowadays this percentage has increased a lot. So actually, the main concept that the perfusionist is following during minimal invasive extracorporeal circulation is to prevent rather than correct, not find an abnormality that you could actually try to correct later. I mean, during conventional surgery, the patient goes to the ICU, you check the creatinine, you take blood sample after half an hour, you check the results after 5 hours, and then you see that the creatinine came up from 1 to 1.5, and then you say, I have a renal dysfunction. But there you need to prevent this rather than try to correct this, because then it's very, very light. So it turns action into a strategy. So MiECTS advocates a multidisciplinary strategy to obtain the maximal benefits from this technology. And this is what we follow in a HEPA hospital, and we have published our results, which are the results that should be after cardiac surgery. You cannot eliminate any complication, but you can have a smooth postoperative course in every cardiac surgical procedure. So not limited to coronary artery bypass grafting that is done in beating heart surgery, also in every cardiac procedure. The concept after 2016 is to create multidisciplinary guidelines. And this was the input of MiECTS into the other societies. So in 2016, we had this position paper that I advise you to just to take a look, and we will have an updated version soon, by 30 authors in 24 departments, an effort of surgeons, perfusionists with blue, surgeons with green, the anesthesiologist with red color, giving guidelines, evidence-based guidelines in terms of the describing the advantages of minimal invasive extracorporeal circulation. So reduced hemodilution, better blood conservation, reduced postoperative atrial fibrillation, class A, preservation of renal function and myocardial protection, and also reduction in inflammation in cerebral, gaseous macroembolies, and preservation of neurocognitive function and organ protection. That was the mainstay of the advantages of the minimal invasive extracorporeal circulation, which translated in meta-analysis, not in randomized studies adequately powered for this outcome, to a mortality benefit. And this actually meta-analysis involved 23,000 patients. So that if we try to classify standard convention in coronary surgery, beating heart surgery, and MiECT, minimal invasive extracorporeal circulation was better in all these parameters: mortality, infarction, stroke, atrial fibrillation, and renal dysfunction, compared to either the beating heart surgery and the conventional pulmonary bypass. What's the rationale? We will have time to discuss this a lot. It's a better perfusion in terms of having a better pressure and increased pressure with lower flows and lower actually need for vasopressors. And the difference is the microcirculation. As I've shown you before, there is definitely a derangement in microcirculation during any type of cardiac surgery, while this area here, the red the red square denotes the effect of cardiopulmonary bypass on the reduction of microcirculation. And this is the effect that you can have by providing a better and optimal perfusion during cardiac surgery. So actually, the peripheral tissue oxygenation with the minimal invasive cerebral circulation is a lot better preserved rather than the conventional CPB. And why is it? Why does this happen? Because of hemodilution is the primary factor that creates this. So by avoiding and limiting hemodilution, you have a better perfusion and better end organ function. And this is the case. This was actually publication from 2012, but we have recent data. We will publish recent data from our center of the effect of the perfusion and especially minimal invasive circulation to microcirculation and to the not only to reduction of hemodilution but also to the perfusion of separate organs. So we said that in 2016 we have common guidelines, and this actually was followed by major societies. So in 2017 we had the European societies, the Surgical Society, that is the ACTS, and the Anesthesiological Society, that is the ACTA, that actually said that an intraoperative strategy for maintaining blood, for conserving blood, is minimizing hemodilution with minimal invasive extracorporeal circulation, of course, with the other measures like retrograde autologous priming, but this is a point strategy. And then guidelines were developed by the European societies, the surgeons, the anesthesiologists, and the perfusionists this time. And we were very, very happy to have joint guidelines in Europe that actually acknowledge that MiECT should be considered to reduce blood loss and the need for transfusion. The class and the level of recommendation, it's not class A as we as society promoted, but it was a more conservative approach. So they actually gave a 2A level of evidence B, but I don't think that this changes the concept and the idea. So MiECT increases, of course, it's a biocompatible circuit, and this is this is one of the main elements of physiologic perfusion, and also that the MiECT components, coating, centrifugal pump, separation of cardiotomy suction blood, and closed configuration in extracorporeal circulation should be considered to improve conventional cardiopulmonary bypass. And of course, this is the expert opinion. That is level C, and the expert opinion is our society here that actually tries to promote the technology. And more recently, in 2021, all the American societies, the STS, the AMSEC, the Society of Anesthesiologists, and the Society of Blood Management made a significant publication and actually say that minimal invasive cerebral circulation is a potent strategy in reducing blood loss and transfusion, and this actually creates the environment for increased penetration of this technology in the States. It is there is a significant proportion of patients being operated with MiECT in Europe, but this is not the case in the States, and I hope that starting from Canada, this will spread from Canada to US and not the opposite way. And actually, this would be a very, 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 very good for Canada as well. Is it cost effective? If you ask, we've done a cost analysis in 4 European countries, let's say poorer and more wealthy: Greece, Germany, Switzerland, and the Netherlands. There's an E missing there. And we saw that it is cost effective because by reducing complication, you actually overcome the difference in the cost that may apply. And also, in order to have a better therapy nowadays, you need to have cost effectiveness and improved quality of life. This is very, very important. So the patients actually, as they get better, as they have a smoother postoperative course, they feel better from the first month. So quality of life improves, and this actually by combining cost effectiveness with a better quality of life gives minimal invasive circulation MiECT as a dominant therapy in cardiac surgery, and this is the way that it should be considered. Of course, you cannot change the way the world works. So cardiac surgery moves to minimal invasive cardiac surgery. That's correct. But when we say minimal invasive cardiac surgery, even we have the meeting of the International Society of Minimal Invasive Cardiac Surgery takes place right now. So they're discussing on minimal invasive cardiac surgery, but their mainly definition is minimal approach cardiac surgery. So we definitely believe that minimal invasive cardiac surgery cannot be done without incorporation of minimal invasive extracorporeal circulation. And this was acknowledged by Bob Chiai in many of our events. So it takes two to tango. So minimal invasive cardiac surgery that gives an optimal aesthetic and surgical outcome, that's true, needs to be combined with minimal invasive extracorporeal circulation, as extracorporeal circulation plays a significant role. The time of CPB and cross-clamp time is increased during minimal invasive cardiac surgery. So why not incorporate the advancement in this part in order to create the optimal outcome from the patients? And actually, Jean-Paul Remadi in France actually questioned in 2004, so it goes back 20 years almost, whether mean extracorporeal circulation is an evolution or a revolution. And the answer is that MiECT is a revolutionary evolution in perfusion. And actually, this creates for our society the future of cardiac surgery. So it's the minimal invasive extracorporeal circulation, the circuit, the system, and the strategy that creates a teamwork approach during surgery. And the minimal invasive cardiac surgery that creates minimal access, technology, and technique. So all together, they create a physiologic cardiac surgery. So this creates the future cardiac surgery. This is the response to Bruce Lytle and Michael Mack. Again, please take 1 or 2 minutes to register, and we will be happy to see you all in our future events. Thank you. Thank you very much for your attention.
Thanks very much for that.
Thank you. Thank you, John.
Introduction and overview.
Yes.
Questions or comments from the audience? Perhaps what we'll do is get the next session underway. And then we can have a bit of a discussion.
Because all sessions are grouped, so
very
that
good.
we will have the message.
So our next speaker now will be Apostolos Eliopoulos, also from the AHEPA University, Thessaloniki, Greece. Apostolos, again, a very dear friend, excellent clinician, and really one of the leading experts in this whole area. So we'll be talking about the different types of bypass circuitries.
Good morning. My name is Apostolos Deliopoulos. I'm the Chief Perfusionist of AHEPA University Hospital. First of all, I would like to thank the organizing committee for the invitation, and it's a great pleasure for me to be here. So my topic is type of MiECT systems. Due to the fact that most of the circuits that are custom-made, it comprises a lot of components. The minimal invasive extracorporeal society define which of those components should be integrated into the system, so as to be defined as a mini system. Otherwise, does not fulfill the criteria to be a MiECT system. So I want to go with the type of MiECT system because it's very important to understand the difference of these systems. Up there is type 1 MiECT system. As you can see here, it's an ECMO system and ESLS system, integrating a centrifugal pump and oxygenator and the tubes. As you can see there is a baby bubble trap which blocks air coming from the root vents. This air can be removed with the assistance of cell saver. Low volume warm blood cardioplegia according to Calafiore technique is applied. The cardioplegia was delivered directly from the oxygenator in combination with a high speed surge pump. There was a one-way valve in order to control the pressure, and this was type 1A. However, we had some problems with patients who had insufficient aortic valve, and that's why we were forced to add a roller pump in order to increase the cardioplegia pressure, and this is type 1B. And this is the type 1 from Alois Philip. Historically, it's not used anymore because it is not safe. safe is up there here. So the next step involved the integration of a bubble trap into the system. As you can see here, the safe became safer, and if air was inserted into the system, we could de-air the bubble trap with the assistance of cell saver. More specifically, there was a patch of a level sensor to the bubble trap, and each time that the air comes from the venous line and the sensor detects air, the sensor provide an order to the centrifugal pump to stop and give the opportunity to the perfusionist to de-air the bubble trap. It's not, it wasn't so comfort for the perfusionist. And this is type 2. And this type 2 from Medtronic, and this was our. However, we noticed that there were a problem regarding volume management, especially when the patient was overloaded. Hence, the heart could not be empty when open its chambers. Our concept is that the surgeon has to operate in a bloodless and arrested heart. That's why we add a soft bank into the system. This way, the volume management of the patient was easier. If the patient volume was extensive, we could extract volume from the circuit to the soft bank. If there was need of volume, we could give it back. And this is type 3. And this is type 3. However, a safety net for complex cases regarding massive air entrapment and accidental massive bleeding led us to create a hybrid system. That's why we create the type 4 a HEPA circuit, a modular system, adding cell in parallel. This enables us to convert the system from close to open. With this system, it's easy to perform any kind of cardiac case mix because we have the VART, the venous air removal device, and there is no problem regardless how much air the system will suction because the VART is able to de-air it. Moreover, as you can see there, there is a baby bubble trap to which we connect the two vents. This bubble trap is interconnected with a bridge through which the blood is transferred to the VART. If in any case air comes to the baby bubble trap, we could de-air with the assistance of cell saver. Even it slips our attention, it could be de-aired with the help of VART. And here we can see our system with the performance device. Is there any pointer here? The red one? Okay. No. Okay, okay, okay. Thank you. So if air coming through the venous line and the fluid level drops below the ultrasonic sensor level, the sensor will provide an order to the centrifugal, an order to the performance system. The system in turn will automatically open the pitch valve, releasing the de-airing tube and leading the air to the vacuum. The vacuum will de-air, will remove all the air until the ultrasonic sensor here detects only fluid, not air. Then the pitch valve will re-engage again, closing the de-airing tube, meaning that you can be assured that when the VAR detects air, this air can be removed with the negative pressure of a vacuum system. Here we have video. I want to show you how the air events. We take advantage of the pressure of the cell saver. The hard cell is literally the reservoir of cell saver in MiECT system. We take advantage of the negative pressure from the cell saver and with the air events. Up there is the pulmonary alter event, and this one is the aortic root vent. Apply negative pressure, and with the vents, it's very important to deliver the vents air free to the circuit. And in this video, we can see how we face the air coming from the vents. We can see here that we have the baby bubble trap. There's a bridge here. Shift the blood to the vart. So if air comes from the vents, we have the ability to the air by applying negative pressure from the cell reservoir. So we have a little air here. Now we have massive air, and it slips our rotation. The vart will be air. We can see here how effective is the VAR, how well remove the air. Close here, apply negative pressure to the baby bubble trap. The air defense. And deliver the vents air free to the circuit. And now, this is our circuit with the new heartland machine with the quantum. So if air coming through the venous line and the bubble sensor detects air, then the sensor will provide an order to the air perch pump, which in turn automatically is activated and will lead the air to the soft bank. The air perch pump will remain activated until both sensors, meaning this sensor before the VAT and that one on the top of the VAT detects only fluid, not air. Another safety issue that is being withdrawn from the quiver of quantum system is the venous occluder. The venous occluder is used in combination with a sensor and bubble sensor. So if the baby bubble trap gets a lot of air coming from the two vents, here and here, and the bubble detector detects air, then the bubble detector will provide a sign to the centrifugal pump to stop. The venous occluder will close manually or automatically, depending on your preference. Here, the perfusionist then will reactivate the centrifugal pump, the baby bubble trap with the help of the airing pump, open the occluder and deliver the two vents air-free back to the circuit. And here you can see what are we doing if we have massive air in the venous line. So a lot of air is coming in the venous line. The perch pump is very effective. Remove all the air. In this case, a tear in the right atrium was happened. And first we try to give time to the surgeon to fix it. And now we convert the system from close to open to give enough time to the surgeon to fix the problem. Now the blood, we shift the blood to the heart cell reservoir, it's open system, and then goes to the valve and then to the centrifugal pump. This was for a short time. It was about 3 minutes. The surgeon fixed the problem. We convert again the system from open to close. We check for air, there is no air, and we give the volume back to the patient. It's closed system now. Okay, let's go to the next video. Air handling from vents. So we see here air from the vents coming to the baby bubble trap. As you can see, we apply the occluder, close the line, and de-airing the baby bubble trap with the help of the airing pump. And then open again the occluder and the vents. Now here we have massive air coming from the vents. The sensor will detect the air, will provide an order to the centrifugal pump to stop. Close the occluder, shutting down the vents from the rest of the circuit, preventing of air coming to the rest of the circuit, de-airing the bubble trap. We have a lot of air. We still de-air the bubble trap. And now open the occluder here, and we deliver the vents air free back to the circuit. So as I said, during the MIECT procedure, the patient acts as his own reservoir. There is no reservoir. So the preload and the afterload of the centrifugal pump is mainly depending of the status filling of the patient. For this reason, the blood loss over the blood processor should be remain to the minimum level. A lot of blood loss will lead to high negative pressure, resulting in cavitation and decreasing in the flow of the centrifugal pump. As you can see here, Quantum dispose dispose a volume under pump to control, to manage the collected blood here to the heart cell reservoir. The pump is placed between the heart cell reservoir and the soft bank in the venous line. And if we have massive bleeding and we have a lot of blood in this heart cell reservoir, we can take advantage from the level sensors, which in turn give an order to the volume under pump to give this blood to the venous line. And the pump will remain activated until the blood reaches up to a point to the red sensor. And here we can see here what's going on if we have uncontrolled bleeding. So when the collected blood reaches up to a point from the yellow sensor, the pump is activated automatically and will give this blood to the soft bag, and then we can give this blood back to the circuit. This is the way to face the hypovolemic condition of the patient. And when the collected blood reaches up to a point to the red sensor, the pump will stop automatically. Okay. So maybe this technique is complex, demanding, but for me it's mandatory. And it's not only the circuit that makes the difference, but if you want to enhance your result, you need the MiECT strategy. And to achieve this, you should take into account that MiECT is not just a circuit. It has a lot of peripherals. It has the cellular saver, a lot of monitors, the quantum monitor to go for goal direct perfusion to monitor the metabolic parameters. And it is well known the relationship between DO2 index and VCO2 index. And if you disturb the optimal oxygen parameters, then you will jeopardize the physiologic status of the patient. Moreover, we have the NIRS, and if we challenge our perfusion with brain, then we have a very good tool, and we know every time that the patient is perfused well. So my message is that not just to adapt this technology, but try to have a more physiologic perfusion to the patient, work as a team, try to apply modularity for all cardiac case mix if you want to increase and to enhance your results. Thank you for your attention.
Thank you very much, Stolas. Is there any questions or comments about this type of circuitry from any of our region students? Have you guys become familiar with this type of circuit as yet? That's very good. It's a nice opportunity then to introduce you to this whole novel approach to bypass. Thank you very much.
Thank you.
And just to complete this first session, it's my very great pleasure to introduce Professor Kyriakos Anastasiadis, who is the founder of the society, one of the leading proponents and certainly another expert in this area. So I think this will help us to look at this from all aspects of this approach to bypass.
Well, thank you very much, both of you. John and Cyril, for your efforts throughout the years of establishing this society and bring it to America, which is something very important for disseminating the message. And so having this symposium in Canada, I believe, accomplishes this goal of expanding MiECTS to a very eminent society's environment as it is here. So for me, it's a really honor to give you this lecture in front of young students. That's exactly our audience, how we should start a MiECT program, because as previous speakers pointed out, actually what MiECT is about is a new technology that has to be implementing for advancing patient care and not just for the sake of the science. So why to establish, why to start a program on MiECT? I would say that the advancements in cardiac surgery lately can be described by these three major pillars. One is a very fine refinement in all techniques, which is actually what we are doing contemporary. The other one is the video assisted minimal invasive cardiac surgery, and the other third pillar is the upcoming robotic cardiac surgery, which is absolutely compatible nowadays with what we are doing. So if you see these three pictures, you see at the background the cardiopulmonary bypass. So no cardiac surgery can be implemented without the perfusion input, as you see here. So if we say cardiac surgery, we imply perfusion there as well. And what type of perfusion? Are we still in the Gibbons year, as has been demonstrated, that is actually 69 years old? Or we are discussing about the contemporary cardiopulmonary bypass. So let's see what happened throughout the years to this biggest registry of cardiac surgical patients existing in the literature, which comes from the STS database, and actually summarizes every year the performance on 300,000 patients in the United States. As you see here, actually morbidity, major morbidity that comes with cardiac surgery exceeds 5%. And if you go and see some of the parameters, you see here new onset of renal failure. So this is completely a perfusion related issue. Just imagine operating some of you and having a surgery, and you can have an onset of acute kidney injury with normal kidneys. If this is, let's say, acceptable nowadays with this explosion of technology, I would say something goes wrong here, and we need to do something to correct. So this is not a new issue, as you probably know. It's about 40 years now, from 1983, this landmark paper of the very big John Kirkland of Alabama introduced the side effects of using cardiopulmonary bypass in the literature. And from that moment onwards, what we said is there is definitely adverse outcome, which is coming inevitably with use of cardiopulmonary bypass in cardiac surgery. And it can be summarized with end organ dysfunction, as you see, which is an intraoperative insult coming from suboptimal perfusion throughout surgery. And who is responsible for this? It's definitely the extracorporeal circulation. So for this, some years ago, after this landmark paper, late 80s, with the efforts of some surgeons like the Buffalo and Calafiore and other people, OPCAP surgery, that is avoiding cardiopulmonary bypass, has been introduced as the best way of performing cardiac surgery, at least as far as the epicardiac surgery is concerned, like coronary artery bypass. So after a couple of decades of utilizing the OPCAP technique, what we found out is that not only is not as good as on-pump surgery, but as you see here, there is a problem regarding to excess mortality, not just immediately after surgery, but in the long term. And also there is a problem regarding the graft patency. So for this, as you see here, what is nowadays advocating is that OPCAP surgery is compatible only in the hands of experienced operators. So this is something admitted for the pioneers. And what actually has been left from all this situation is only these red territories, which you can appreciate. These are the less developed countries are still utilizing OPCAP in high numbers, though all Europe and North America has less than 15%. And this is something significant to take under account, that OPCAP is not popular anymore, and I would say is not safe to all hands. So what has been left is trying to advance your perfusion, our perfusion strategies, so as we have optimal results and improve patient outcome. You have heard from Professor Merkin earlier on that one of the first initiatives of this society back in 2014 was to start studying the literature and produce some recommendations about the uses on minimal invasive extracorporeal circulation. And this is our first landmark paper, which actually is about to be published. I think next month we'll have its sequence, the focused update in Perfusion Journal, which has been accepted. This is something that I can declare to the rest of the faculty which were here. So what we said, and it has been proved throughout the years because the focused update actually confirmed our recommendations, is that as far as an organ function is concerned, we have significantly benefit when we are utilizing the minimal invasive extracorporeal circulation. And this is something very important because remote organs matter for having improved outcomes. And this has been also confirmed by the biggest meta-analysis of conventional bypass compared to the minimal invasive extracorporeal circulation, when you see it's not just significant morbidity that comes with the use of MiECT, but also its mortality benefit that you can find when you analyze a big number of patients, like more than 3,000 patients. This is not what we only found as researchers, but if you go and review all the literature, and especially when you are studying meta-analysis, what you will see is that the results from MiECT actually are compatible from those describing the OPCAP use, which is something very significant. And this paper has been demonstrated to you by Professor Andonissis, where it says that if we take all these three pillars into one account and do the measurements, you see that MiECT actually has a better outcome to both mortality as well as major morbidity. And this is something significant. You have to know from the beginning, when you question yourself, why should we start a MiECT program? So I believe I was clear that you can give answers when someone questions you why you are trying to launch a program. So there is significant evidence in the literature why you should opt for this. And not only that, but all major societies have lately introduced the term MiECT and recognized that MiECT should be integrated into the clinical practice, because it's now in the guidelines, as you see. Sorry, this is the joint European Association of Cardiothoracic Surgery and European Association of Cardiothoracic Anesthesiologists. And MiECT is there as guideline, and this includes the European Board of Clinical Perfusionists. So joint guidelines for all major European bodies do appreciate that MiECT is a better perfusion technique. And lately, the American Society of Thoracic Surgery, Cardiac Anesthesiologists, the Cardiac Perfusionist, and the Patient Blood Management Societies, they also introduced the term MiECT for the first time 1 year ago. So this is something significant that even the American societies are moving towards introducing MiECT in their practice. So you also have another base, another rationale for what you would need to answer to someone who would question why to start a program. And of course, don't forget that this is a joint graph of the two biggest meta-analyses regarding MiECT and OPCAB and conventional, and MiECT and OPCAB here. What you would see is all the studies here and here are just out of this territory, which is the conventional and the OPCAB. That means when you're using MiECT, you have 100% studies backing up you that you are doing the best thing. And this is something very, very clear that has to be taken into account, that no study so far has confirmed that there is any kind of inferiority of MiECT to any other technique described in the literature. And this has been already demonstrated to you. What makes the matter is that MiECT should be used as a tool towards a more physiologic perfusion, which is actually the major initiative that you should have towards improved patient outcome. So why should we do is clear when you see what I have indicated to you numbers, and the numbers go mainly to major cardiac surgery, which is concomitant either AVR or CABG with another surgery at the same time. And as you see here, there is a problem. And to whom patients you should best apply? Well, absolutely to those patients, and also to high-risk patients has been demonstrated in the literature. And of course, when we say high risk, what we have identified is the patient that they do have a kind of preoperative high risk profile, which is combined procedures, elderly patients, low ejection fractions, some patients with high Euroscore due to other diseases. So if you operate on a young patient and you're doing it straightforward CABG, you will not find any difference whether you do it either if you do it on pump or off pump, or conventional or MiECT. But when you're doing a high-risk patient or an octogenarian, as Ashraf has pointed out, then you would need the best technology to produce the optimal result. So what I would say, especially for even for a young guy, when you want to shift towards fast-track cardiac surgery and try to be as modern as you can, then you would definitely need to have MiECT on board, because that creates conditions as an off-pump surgery. And finalizing the background, what you need to complement your minimal invasive cardiac surgery is, of course, minimal invasive perfusion. Otherwise, you just lead to opt to a cosmetic surgery rather than minimal invasiveness to all aspects of your surgical technique. So who will do this cardiac surgery? It has been demonstrated also that from the first beginning, what our society has brought up into the literature is that this is a strategy, and it's not just a circuit, and definitely it mandates a teamwork from all the stakeholders in the surgical OR. Otherwise, you would not be able to get the results. So what we said from the beginning is that MiECT is not a perfusion, just a perfusion tool, which refers to the perfusionist, but it's a multidisciplinary procedure that refers to all the major stakeholders of the cardiac OR, which actually has been demonstrated from the first beginning in this very first paper in the literature published, where you see that the blue guys are anesthesiologists, the red are surgeons, and the yellow is the perfusionist. So the senior surgeon and the first author here, senior author and the first author are anesthesiologists. So this technology didn't come from the perfusionist input only, but it mainly was embraced by anesthesiologists to shift it towards the clinical practice. And for this, what I would say is, if you want to succeed with your new program on MiECT, what you need is to have a team which has to be decisive. That means you need a skillful technology, a skillful perfusionist, as you would appreciate. I have Apostolos who is not just skillful, but he is also bright and also determined to go for it. So it's a kind of pioneering thinking when you are trying to a non-supportive environment to start doing MiECT. So what you need is first the motor, which is the perfusionist that has to be skillful. Also to have a surgeon who is meticulous. So if you have a very junior doctor who is now trying to establish his career, I don't believe this is the right guy to base your training on his practice. So you need a mature and skillful and meticulous surgeon who would lead the program, and also a bright anesthesiologist, which is absolutely important if you want to have good results. Because if you have an anesthesiologist who thinks that the MiECT program actually refers to less heparin and less protamine you give to the patient, then you would definitely fail, because he does not appreciate what is the physiology basics behind the MiECT procedure, and you will spoil your results when you're trying to minimize the hemodilution and he's giving a couple of liters of drip just for the induction of anesthesia, and you try then to handle the volume with your system, and it's not easy. So you need the anesthesiologist to be on board and also control all his parameters, like the perfusion parameters, also the coagulation parameters, physiology, and so on. So actually what I'm implying with all this is that you need a real teamwork, not a figure of speech, but you need people that they will start as a team from the first beginning to bring this program to the rest. But to start with, you need this teamwork that also would like to go through a stepwise training. So this is something that is not like a plug and play system. It needs a training, and it needs these three disciplines to come together and have a training, as I will introduce you here, and also employ technology, employ tools like inline monitoring, as has been demonstrated to you. So what I would say is, if you want to go for more physiologic cardiac surgery and start a MiECT program, what you need is to apply physiology, embrace innovation, employ tools, use a strategy, and don't forget, communicate throughout surgery. So it's not just these three people are operating themselves with their discipline, but it needs continuous interaction throughout surgery. And if you apply this type of surgery, as we have already introduced in the literature, I believe your results would be good, because Apostolos has introduced this. As you see, this anesthesiologist, this is me, this is Apostolos. What we are normally do is we are very close, not just physically, but mentally. And you need to, throughout surgery, start thinking of a new way of interacting intraoperatively. And of course, most of the senior guys here have been in my operating theater. We normally have a lot of jokes and a lot of other issues throughout the surgery, but this is a part of the game. If you want to communicate, you don't only ask questions or give orders. You need actually to be mentally with the other two that are operating with you. And if you're an anesthesiologist, when you go on bypass, he goes for a coffee and comes back at the end of your surgery, then you've lost it. There is no, mental contact, and this is a problem. So even the anesthesiologist should know the problems intraoperatively. If you had to open the system, if you had trouble, if you lost blood, how is the lactate? Was it a case straightforward, or you had perfusion issues and so on? So actually what I'm implying is that this teamwork should be a real teamwork, and you need to have people, not just innovators, but friends. So what knowledge should be your background to start with a program like this? First of all, it has been demonstrated that throughout the years, this conventional setup has changed. What was the major breakthrough for changing this? As you see here, it was the closed circuit, centrifugal pumps, the inert surfaces, and the short tubing for avoiding hemodilution. So actually what you need is all this technology to be, let's say, at least known, mostly to the perfusionist, but also to the other members of the team. That accounts for the surgeon and for the anesthesiologist. And what I would say is the major, let's say, clinical setup for this knowledge is actually the ECMO use. ECMO is a type 1 MiECT system without having the cardioplegia line that we have described. So actually, when you operate in this setup, look at this. This is a mirror image. So it's the same. So ECMO and type 1 is the same. This is the picture from Leopold's, the Wiesenach, the first paper, 2004. And it's an ECMO system. So when you operate an ECMO at your institution, you know the basics of closed system physiology, and also to deal with such a technology. And what makes it the difference here is the hemodynamic control, as has been described by Apostolos, the volume status, and the air management. And definitely what Cyril Serik keeps saying is the venting handle, the air that comes from the vents. And Apostolos has already demonstrated how we do with having the vents not to the system or to the to another hard shell reservoir, but we are connecting them through this mini bubble trap, having an extra safety issues before coming into the system. But don't forget that technology should be employed, because it's not just the system that will give you results, but the strategy has been already said. So to summarize, if you appreciate this technology here, then you would definitely be able to start with a training to mini bypass. But you need not just these technologies that is more referred to the optimized ECC, but you need also to go for this. That means closed systems and eliminate shed blood direction into your system. And then you have actually the minimal invasive extracorporeal circulation. So how to do it? So if you know this, how you should start doing it. This is Alex Wakba. Alexander was the former president of EBCP, the European Board of Clinical Perfusion. And during our first meeting, MiECT update meeting in Thessaloniki, he questioned himself, should all perfusionists have a training on MiECT as a mandatory strategy? So I would not say more, because I believe this is an open question for Cyril and other perfusionists that might be here. But I can tell you that some years ago, I had an invited keynote lecture to the AMSECT. And again, the American Society of Perfusion questioned the same. Should we have a mandatory MiECT training when we have the perfusionist schools with us? Now, what some years ago has been suggested to another meeting that we had in our society from these people. He is the new president of EBCP, Philippe de Sommer, is professor of perfusion. Christophe Beaufreton is a surgeon from Angers, France, who is also a pioneer in the closed systems. Frank Merkle was the former secretary of EBCP, and Adrian Bauer is now in the EBCP board. Ignacio Contello is from Italy, a perfusionist. What has been suggested is, should we have a MiECT Academia? And because Frank and Adrian are having a CPB program in Berlin, what we said is, should we have a MiECT program joined not just with Germany, with other countries like Greece, and having that under the auspices of EBCP, since our programs are EBCP accredited. But just take it under account if a MiECT Academia would help towards setting up programs. Also, you need to study before launch any kind of program and also having training. What we have produced is a book with tips and tricks about MiECT, but we have written a lot of chapters, as you see, to eminent perfusion books. And what I would say is go and review the chapters and see all the details regarding MiECT before having any kind of a program setting. Now, if societies will fail to play the role of teaching, I think industry plays a key role here. And as you have heard from Cyril Serik, we have embraced the industry from the first beginning in our society, because we believe that these guys are also stakeholders to what we are doing towards advancements of patient care. And what you need is, first of all, an introduction to this technology, including all the peripherals that has been introduced to you, like the goal-directed perfusion, point-of-care coagulation, heparin protein management, near-infrared spectroscopy, and so on. So what you need is actually a training, and what I will reveal is regarding MiECT, you need 4 steps. Actually, it's 8 steps training. So what are the first 3 steps, which are preclinical? Now, the first one, as you see here, is actually introducing the MiECT to you, which is mainly what we're doing today. But what we used to do is we used to have it trainings in person, but with the coronavirus, what we've done is starting online or virtual introductory courses, just to introduce to people who have already the background of knowledge that I have told you, the MiECT. So you need a team that would be your referral team to introduce you to the technology. Now, second pillar for your training is on-site training, which is an advanced training, and you should visit your referral team. So as you see the setup, you see live how the surgery is done, and also communicate with your teammates, the surgeons themselves, the perfusionists and the anesthesiologists, and all of them as a team. So the 2 steps should be followed by a hands-on course. Now, this is an advertisement for our courses, and it seems that 20th of December, we have regular courses every couple of months. We have another introductory course here. Now, the third course, the third step, preclinical, should be a hands-on course. And this has also 2 pillars. One is a dry lab with simulation, and the other one is an animal, a wet lab. What we normally do are both. In our perfusion school, back at home, we do have wet labs with pigs when the perfusion trainees are coming and play with the system and having all the scenarios, but it's much easier to have the Califia as we used to do, or any other simulation that you can before starting doing cases live. So introduce yourselves to the technology. Second, go and visit and see in an advanced course how is real life. And then before you start doing a lab, dry or wet, or whatever you think, it will give you the let's say the safety or the knowledge to start doing it into the human. So fourth step is the clinical, 3 preclinicals, and you start doing your cases, but not alone. You need to have a supervision from your referral team or a proctored case or whatever. And as soon as you do that and you start doing, as I will so later on, then you would need, we have proved that you need 50 cases for the whole team to familiarize themselves and have the best outcome has been described. So we found out from our learning curve that when you reach to the 50 cases, cabbage cases, simple, then you start having statistical significant difference between the outcomes of the conventional and the mini system. And this is because you need time to know yourselves and start utilizing your techniques easily. And that's why we have these 50 cases as a landmark for participating into multidisciplinary studies, as I will introduce later on. So let's go back to this, very busy scheme. What you see is you have the first preclinical 3 steps, and after that, this is the 4th step here when you start your own cases. Now you need the 50 cases to go to the other phase. So these 3 phases, then aortic valves, mitral valves, tricuspid valves, and then go for the whole cardiac case mix. You need, these are steps. You need first to mature yourself, to open the heart and do intracardiac cardiac surgery, also to go for mitral valves, open the mitral valve and open the right heart, and then do circulatory arrest here. So throughout the case, what I would say is start with type 2. Type 1 is not safe. So type 1 is good for maintaining extracorporeal circulation to an ECMO patient, but not operate with a type 1 without a bubble trap is not safe. So start with type 2 if you want to do simple surgery. But if you want to go for AVR, you would need blood volume management. So you would need type 3. And if you want to open the left and right heart, then you would need to have a hybrid system, like a modular one, and don't go for this without having a modular on board. But the way that we teach in Thessaloniki, what we believe is start with the modular from the first beginning. Even though you would say, why should I employ an extra heart shell from the beginning and give another 50 euros or dollars from the beginning, I would say you can have it mounted with smart connectors and don't use it, but have the modularity in your system from the beginning. So if you do the same circuit, same design from the first beginning, is easy instead of start and escalating your systems. And this is actually the strategy that comes with all the teams. So don't forget 3 preclinicals. This is the starting phase, and the other 3 are the steps for completing your training. So that has been introduced to you, and what I would say is, I've told you type 1 is just for ECMO. Cabbage is type 2, but if you want to go further, I would say at least type 3, but don't forget that full spectrum is compatible only with modular systems, because with modular systems, you can have both volume management and air handling in any kind of unexpected scenario. As Apostolos has pointed out, you just convert to open and come back to the closed system. And that has been also, as you see, presented with other experts like Ashraf and his team. And what I would say is safety comes with the modular, because modularity gives you the safety net you need. And these actually are all the reported cases of unexpected scenario when using MiECT. When you actually divide them into two groups, when you don't use the modular systems, what you find is the problem is air entrapment and low circulatory flow. And when you go to modular systems, when you don't have the blood loss and low circulatory flow, or you don't have the problem with air handling, what you see here presenting always is conversion to open. So there's no problem when you're having the modular system to convert, because actually the modular is a type 3 system with this extra standby component, as I've told you. And Apostolos has pointed out from our results, which is a big number when we started, is that it's only 40% of the actual CPB time that needs to convert. So even in a case when we say conversion, it's not throughout the case, but it's only a limited period, you need to correct your problem and go back to the closed MiECT system. And for finalizing the prerequisites for the program, don't forget the societies. And I would just mention our society and the work that it is doing throughout the years, as John Merkin has pointed out. The very impressive is that we have increasing numbers despite the COVID situation. We still have numbers that are coming up, and we have now roughly 50 countries from 5 continents. And this is something significant because it's your input. It's not mandatory. So all these people that are registered are actually very much motivated and are from all disciplines, as has been said already. And look, the major centers and the 2 centers that Cyril has already mentioned from Canada. What I would say is that these centers should be the referral centers for a training program, because these should lead all the teams that need to launch a program, or they want to launch a program. And we shouldn't forget that for launch a program, you need the data, and the robust data comes from big multi-center studies. As we have started some years ago, the COMEX trial, as you see, from 16 centers, but actually due to a lot of issues, that stopped to 1,067 patients. And I believe the organizers will lead us through the first results ever that will be presented tomorrow, from what I know. So that will be even something significant for me, because people would know if we had a result with these first cases or not. But what I would say to you is that we immediately started our new multi-center trial with a more realistic protocol. And we have already launched this trial some weeks ago, just because we didn't want to have any bias by the results that will be presented tomorrow. So MiECTS trial has been already started, and I believe with MiECTS we will have definite result to justify your opting for a program. And don't forget, all these symposia and meetings and congresses have been organized by MiECTS and have been live broadcasting by CTSNet. So if you want to launch a program, don't forget to stay tuned with the society. But definitely what we need is disseminate the message in congresses. And I would say that that's the case, as you see in Europe. What we normally do every some months, I'm invited and other people are invited to major congresses to give lectures and bring up the message to the Europeans. And that's why the Americans are accusing us that this is a European technique, which is completely wrong. Because some years ago, I was invited in the AMSECT, and actually we had a discussion with Olaf Schund and Sean Baker, Kenneth Sean, the former president of AMSEC, to start the program in Mass General, Harvard. But the problem is, after that, when we were trying to do that, COVID and other situation didn't allow us to start doing a MIECT program in the United States. And I believe it's now your term here in Canada to start bringing this message here. But I would say that even journal input is significant. And this is Thierry Carrel, one of the former presidents of MIECTS, and he produced a special issue on MIECT with all the major steering committee members that are here, which also actually had a lot of impact on people who wanted to have knowledge on this. So to conclude, what I would say is to starting a MIECT program, you need to overcome the hesitation from the team, all the three stakeholders. So to do that, you need to answer the question, this hesitation comes from evidence or from concern? And if it's from evidence, I would say, is it the lack of existing data, or is minimal information that you have? And also the concern is an unwillingness to discomfort or difficulty that comes from complexity of the system. So if you answer this, then you would go for what I'm presenting here, that in Europe, we have about 22 to 25% of MIECT use, while in the United States and Canada, it's less than 2%. That means it's 10 times less here. So I would go and ask these questions and find answers. Why is this hesitation? What I can tell you is Rob Baker from Adelaide, who actually announced me today that they're about to launch a program in Australia next week. So I'm very pleased that a member of AMSEC and a very senior professor of perfusion will start in Australia, a MIECT program, has said some years ago, here, that when you have the innovators and the early adopters, normally your penetration is low. What you need is the early majority here to start having the MIECT as a contemporary practice. And for this, you need to launch programs. So we are now in this phase, trying to go to the slope and go up and see if we can convince people to come on board, having training, and then test themselves about the results. But what I would say is cardiac surgery comes with technology. So perfusion is a part of this technology, and it shouldn't be abandoned or neglected, because when you want to have the major impact of your surgery, you need to have physiologic perfusion as we have presented in the literature. And for me, what is the best way of having the major advancement in cardiac surgery is to have the state-of-the-art of perfusion, which is the MIECT systems. And don't forget, this accounts for roughly 850,000 of patients per year worldwide. So it's a huge number if we would be able to launch MIECT programs and ultimately go for advancements of patient care. So thank you very much, and I hope this would be, let's say, a starting point for most of you if you want to launch a program. And I believe that being here in Canada is a new era for our society, trying to have the base in America as well as Europe. Thank you.
Thank you very much, Gary. That was really important overview from all three speakers about the importance of this this really unique approach now to cardiopulmonary bypass. Once again, making it a much more integrated and team-based approach. And I can't help but think back, as you mentioned, Kyriakos, to the early days of beating heart surgery, OPCAV. And there it was really all about the interaction between the surgeon and the anesthesiologist. And all the surgeons admitted that you really have to be a team now, as opposed to formerly almost being in relative silos. Anesthesia goes off for coffee when you're on bypass. surgeon's doing his thing, perfusion's complaining about venous return, and everybody's ignoring everybody. And so this is really a step in that same direction, that this really is a team approach. And I think your comments are very well taken, that to be successful, all three have to be really invested in the case and the management of that patient. And I think that was an excellent overview. I just have a question. It seems to be, we have a limited inroads into clinical practice, as you mentioned, 25% in Europe, 2% in North America. And I think it seems part of the challenge is this is a push and a pull. In other words, we need to have usually the surgeon to really champion this, to say, look, this is really an excellent idea. And at the same time, perfusion has to have expertise and interest in participating in that. And I know a number of centers where one or the other has been absent, and it's been very, very challenging to really get this off the ground. So I wonder, in Europe, what is the status then in training programs of MiECTS, being taught as an approach to bypass? Do you have any insights into that currently, or? Yeah, please.
So the major difference from America and Europe is that the companies, that the industry that is producing sets for this technology actually have referral centers. And for this, they are attracting customers, they are attracting people that they want to, first of all, see and maybe later on apply this technology, and that helps. As I've told you, there should be a kind of exposure to this technology. And what I believe is that the industry in America is not interested. And since this is a more private-oriented healthcare system, the contracts are not including the MiECT as a prerequisite, because if the major insurance healthcare providers have data demonstrating that when you are operating on MiECT, you have less morbidity, then they would push, or the major, hospitals and institutions to opt to MiECT program. So it's a kind of different approach. That's why I'm saying for Europe, it's mainly industry now that is pushing, and also our society that has already integrated the major people that are leaders in the field. But here in the United States, they want data. And for this, what I believe is MiECT trial or COMICS or any kind of big trial that will produce class 1A level of evidence data will ultimately give the way for a lot of centers to start programs.
Yeah, very, very important. As you say, both the opportunity to go and work at an expert center to see how it's done for the team, but also, as you say, critical the data. And as you announced, we'll be hearing the results of the preliminary results, at least, of the first COMICS trial. I think that'll be done tomorrow. I think that's the presentation tomorrow at noon, and that should give us some real insights in a prospective randomized fashion as to the actual differences between conventional and MiECT as far as patient outcomes and important results. Good, thank you. And any other questions or comments from the Sarah?
Excellent presentation. I think, what do you think? I know there's a lot in there, but what do you think? You were just to summarize, what was your biggest hurdle that you had to adopt this technology?
Actually, at the beginning was air handling. But for me, as a philosophy, my biggest problem was to convince the team.
Yeah.
So even though the technical from your side is, let's say, how I will deal with events, what will happen if I'll have a problem with blood and so on. I believe everything is already described. And if you go and see, how we operate in other centers, you'll find that there is no problem actually. What you need is to convince the rest of people. Even in my department, there are still some people saying, why shouldn't we go to the more comfortable early days that we were doing, a case with a lot of sensors and alarms, and I could also drink a coffee and text with my smartphone. The anesthesiology department was next door, and the surgeon was just teaching. Okay, fine. So if this is the case, you can go to the old days of everything, of the telephone sets, as Polychronis has said, with the typewriters instead of the computers, or with old style of life. That's good. I mean, it's classic. But if you want technology to be part of your life, and if you want the best result, just imagine the president of Canada who had an operation, heart surgery, and has neurocognitive decline for a couple of days. I mean, is it good for the country to have someone who would have, the minimum insult from cardiac surgery? And I would say this is the major hurdle, trying to convince people, nursing staff, the administration, everything, to invest in this technology, and not saying, look, this is more expensive, this is more demanding, this is not necessary, this is, something new, and every novel has, the hesitation or the fear of unknown. But to me, it's good to discuss. I mean, the more you've been exposed to, the easiest you absorb and you overcome any hurdle.
When they start seeing the results, when people start hurting, or
Well, I would say what happened in my department when we have the comics trial started. So we had to randomize our patients after many years, more than 10, 15 years on the mini bypass. We had to do conventional surgery. So the ICU nurses didn't know to which stratum the patient was randomized. But after a couple of weeks, when I was out, they were telling me, oh, she was a conventional system patient. I said, how do you know? I mean, it was obvious, because from the first beginning, when you start the program, you find that the patient which goes to the ICU, he's warm, low lactate, passing urine, he's very stable, he's very easily extubatable in the first couple of hours. While you have, when you have the conventional system, he's a bit anemic, he's a bit edematous, he's a bit, when you wake him up, a bit drowsy. So you understand from the first beginning what's going on here. So I would say here is the issue, trying to test yourself. I mean, come and do it, and when you will do it, you will find that it is better. Forget the numbers and all the literature. Try it yourself and see patient blood management. We're having 1 out of 4 patients being transfused cumulatively, all kinds of surgery, 1 out of 4. But when I'm saying transfused, I mean throughout the in-hospital stay, not throughout the interruptive period, because what Marco Nagliucci has found in this GIFT trial is people that are restrict transfusion intraoperatively, they had huge transfusion in the ICU and later in the ward. So when you say transfusion, don't game.
Yeah.
Try and review your results throughout the in-hospital period and see what's the problem. And I would say when you have the mini bypass, patient blood management inevitably comes with the MiECT system. You don't need to do any kind of trick to have PBM. So an answer is an overview of all this.
Well, again, thank you. And I think I was very pleased to hear that Rob Baker in Australia, I think that's huge as far as making
Correct.
inroads and spreading the message. We'll be very, very interested to hear his experiences coming up. Yeah, thank you. Well, I'd like to thank all our speakers so far this morning. I think we have a half an hour coffee break. We'll be back at 10:30. Please be back sharp because we're integrating this with the European side as well. So yeah, coffee time in the exhibit hall, I think. Yep.
Thank you.
We're going to be hearing from Dr. Mark Bennett at the Morrison Hospital in Swansea in the UK. And he'll be starting off, there's Mark, talking about to us about MiECT from an anesthesia perspective. So welcome, Mark, and carry on.
John, thank you very much. And I'm very grateful to you and to Cyril for inviting me to speak. I'm very sorry that I can't join you in person in Canada. Instead, as you say, I am joining you from South Wales in the United Kingdom. And if you will permit me, I'm going to share my screen. So I'm going to talk for a few minutes on the anesthesia perspective, on the safe conduct and introduction of MiECT into your service. If this is yours or your anesthesiologist perspective on their role when it comes to cardiopulmonary bypass, perhaps I can try and persuade you that the involvement of the anaesthetist is not only essential, but is also very good for your patients and also good for your anesthesiologist. During these couple of days, you will hear plenty of comment about the importance of communication. And of course, communication is vital in any cardiothoracic surgery, but is absolutely essential for the safe and effective introduction of MiECT, both with open loop communication and closed loop communication. Everyone in the room absolutely needs to understand what everyone else is doing during a MiECT case. But what is it that is particularly pertains to the role of the anesthesiologist? What role does the anesthesiologist play in particular for the safe delivery of MiECT? The first, and this morning's talks have been an absolutely excellent introduction to the MiECT circuit, not only in terms of its types, but also in the safety procedures. But the knowledge by the anesthesiologist of a MiECT circuit in all its complexity, or rather in its simplicity, is absolutely essential for the safe delivery of MiECT. This is a type 2 circuit, which in addition has a flexible reservoir at the bottom, potentially making it a type 3 circuit. And on the left, a modular hard shell reservoir, each of which has its own uses. A type 2 circuit by itself is able to handle air in small volumes, but the anaesthetist needs to be very clear on what are the safety aspects of each of these circuits, what are the potential hazards, what are the get out clauses when you're dealing with any of these safety features, because they will form a part of that plan. Of course, by definition, a MiECT circuit has no reservoir. And the important physiology that the anaesthetist plays a very important part in is the direct link between the planned arterial inflow from the circuit and the venous return into the circuit. In essence, and as was put maybe 15 years ago by the team from Bern, the patient is the reservoir. 70% of the patient's circulating volume in life and when on bypass is contained within the venous capacitance vessels. And the venous capacitance vessels themselves are surrounded by smooth muscle And these are under autonomic control with alpha-1, alpha-2, and beta receptors maintaining the tone within the venous circulation. And this is really important because this is all under manipulation, not only, as it were, when our patient is awake or in intensive care, but also when our patient is on a MiECT circuit. The tone of the venous volume is generates what is called the mean systemic filling pressure. And this forms the upstream pressure for the gradient of venous return, normally into the right atrium, which is the downstream pressure. But in our case, it is the gradient which brings blood from that venous capacitance into the MiECT circuit. And against this gradient is what is called the resistance to venous return. And this also is under autonomic control. So why is this important? You will have heard already the reasons why MiECT is good for you, but just to remind you, and you will see this in all major trials that have been published in the last decade, including the Titer 2 trial here, that 2/3 of our patients have a relatively uncomplicated course after cardiac surgery. But 1/3 of our patients have a range of morbidity, which can even result in death after standard adult cardiac surgery. And many of these are linked either to inflammation or to oxygen delivery or to both as a major cause of all of these morbidities. In fact, it was nearly 20 years ago that Habib and his group described the nadir hematocrit on bypass as being fundamental to almost this whole range of morbid outcomes. So we've known this for an awful long time, that the lowest hematocrit on bypass is of vital importance. But there has been a bit of finesse added to this when the hematocrit or hemoglobin is combined with the planned pump flow to give us the oxygen delivery. We can see that there is a threshold for most of these morbid outcomes, above which the incidence of the morbid outcomes is reduced. And although this isn't an absolute one-size-fits-all, it forms a fundamental principle that we should be aiming for with target-controlled oxygen delivery. The third component, other than hemoglobin and flow, is the achieved blood pressure and the difference between the preoperative map and the map that we achieved during bypass, with a cutoff in this paper of more than 26 millimeters of mercury below the preoperative map, which is associated with poor outcomes, in this case with acute injury, but probably also with other of the morbid outcomes. So now we have pressure, flow, and hematocrit as 3 of 4 key factors in what is called optimal perfusion. And Glenn Murphy and his group describe this, where the 4th factor is temperature control. So can MiECTS, with our involvement, deliver these at their best without increasing the elephant in the room, that is the duration of bypass? Well, the European and American societies have not only recommended MiECT for good blood patient management, but the American Society last year recommended, in addition to that, for the recognition of the importance of autologous priming of the circuit. And for any of you who have tried to autologous prime or been involved as an anesthesiologist while the perfusionist has autologous primed a conventional circuit, You will know that autologous priming a conventional circuit is incomplete. It still results in quite marked hemodilution, and there is a reasonably long period of instability before you go on bypass. In difference, your anesthesiologist will appreciate how quick a MiECT circuit can be autologous primed. And in addition to what is called RAP or retrograde autologous prime, is also anterograde autologous priming. And both of these can be done fairly rapidly until the blood actually meets in the middle, therefore extinguishing almost the whole of the perhaps up to 800 ml crystalloid volume into a reserve bag. What I would just stress at this point for the anaesthetist is that at the slight drop in blood pressure that you get during this process, you don't give any phenylephrine or metaraminol or whatever your pressor is, because it will just enter the circuit. And what will result is then quite marked hypertension, not just a normal blood pressure. And the reason for that is that having achieved a good RAP and anterograde priming, the viscosity of the circulating volume is now significantly higher with a MiECT circuit. And with this improved rheology, the MAP achieved during bypass with a MiECT circuit is higher. And this is achieved almost without any pressors. And finally, the other factor is that without a bolus of crystalloid straight into the circulation, at least in the first several minutes of bypass, the SVRI is significantly higher because there is no vasoplegic response in the patient. So your patient has an immediate, very good mean arterial blood pressure, at least at your target. And you've seen this slide before, but this is really the crux of it, is that whilst we know that CPB significantly affects the microcirculation with a decrease in the functional capillary density, with a MiECT circuit, the functional capillary density is much improved, and this is maintained during the whole of the bypass. And it is this improvement in the microcirculation, at least as evidenced here in the sublingual space, that is probably existent in most organ systems and results in the good outcomes. Now, with vasovenoplagia that even exists with a MiECT circuit, you will see that there is one factor that is of crucial importance, and that is that if the mean systemic filling pressure falls, despite the perfusionist increasing the pump speed, as shown on the right here, that if the mean systemic filling pressure is low, then the pump flow doesn't increase, and there is no further venous return, and so therefore the arterial inflow does fall. And in fact, this results in vena cava collapse. And on the left, you can see that just proximal to the tip of the venous cannula, shown here in the liver, you do get intermittent IVC closure if the mean systemic filling pressure is low. And this is seen by the perfusionist as chatter. And with that, there is variability of the flow, as shown here with color flow Doppler. And in some cases, the flow is lower with a MiECT circuit, but at a higher hemoglobin concentration, the oxygen delivery is at least as good, if not higher. So we found this many years ago, and in our group in Plymouth, we decided that we needed to maintain the tone of the mean systemic filling pressure throughout bypass, and not with a bolus of metaraminol, which is an unopposed alpha agonist. And what it does without beta agonist activity is it also increases the resistance to venous return. So norepinephrine, in contrast, has both alpha and small amount of beta agonist activity. So it not only maintains the tone in the mean systemic filling pressure, but also has a reduction, or at least an increase in the resistance to venous return. And we found that with 0.03 mics per kilo per minute of norepinephrine running, then the flow was higher in the pressor group compared to standard MiECT circuit without an infusion of pressor. And with that, we were able to achieve a significantly higher oxygen delivery compared to what we'd found in that earlier study. Now, there is a mechanical feature of venous return that is worthy of mention, because this may be your role as the anesthesiologist, and that is the well and good placement of the venous cannula. On the right, as we swing the probe round, you can see that this venous cannula has been advanced too far into the liver and is now significantly beyond the junction of the great hepatic vein with the IVC. And this may be a mechanical function which reduces venous return. So this is another of the anesthesiologist's roles. And in conjunction with that, you may be using a long venous pipe, especially for minimal access surgery. And of course, TOE is essential for the safe passage of the wire from the IVC into the SVC, and then the safe and appropriate distance of the cannula across the right atrium into the SVC. I haven't got a slide for this, but there are two other features of TOE which are important as you begin to introduce a MiECT system. First of all, is to make sure there are no surprises. And these two surprises are an undiagnosed PFO, because you don't want a significant shunt from left to right or right to left when you start using MiECT circuits, especially with a type 2, because you may have more air than your bubble trap is happy to deal with. And the second thing you don't want to find at the start of a case on MiECT is that you have undiagnosed mitral regurgitation, because this can increase the volume that is being returned if the patient has actually been more overloaded than you knew about. So TOE again plays a role in making sure that there are no surprises at the start of your MiECT practice. So we now know why this will be good for your patients. Why will it be good for you? Well, I can assure you that you will spend considerably less time checking blood if you operate in a system that uses MiECT. And not only that, you will also have better point of care coagulation testing, as demonstrated by the group in Greece. So you will be giving far less products to your patient intraoperatively and postoperatively. And thirdly, if in addition to be the anesthesiologist, you're also the intensivist, you will have fewer patients with AKI and a reduction in the number of patients with atrial fibrillation. If all of this seems to be quite a big hurdle for you and your team, I would just like to reiterate what the professor has said, and you, along with your team, I would strongly recommend attending one of these high quality, and these are just two examples of the high quality academies that are on offer from our industry partners. And together with simulation, as shown on the right here, you can share in the knowledge and the knowledge increase before you introduce it and be a full participant in the team. And with that, I'd like to thank you again for your attention. And I will, of course, be here to answer any questions.
Heard some of the discussion from the previous presentations, but it certainly, to me, is analogous to the role between anesthesia and surgery during beating hearts. Anesthesia has a critical role to interact with the surgeon, and similarly, that's what we were discussing earlier. Anesthesia, perfusion, and surgery all have to be on the same page throughout the bypass run with the MiECT circuit. So I think your comments are very well taken in that regard. Any other issues or comments from the audience at all?
Great presentation, Mark.
It's coming on here.
Great presentation, Mark. Can you hear me now?
Yeah, very much.
So one thing that we notice at our center, and I don't know if you see this at your center or not, is every time we go on at the beginning of the case for MIECT cases, we see hypertension instead of the phenomena A that we see with cardiopulmonary bypass, conventional cardiopulmonary bypass, is the hypotension.
Yeah.
So we're seeing. So what do you think is the mechanism of that? Because I always blame it on the anesthetists that they're given too much phenylephrine, but.
Well, it's absolutely true. If they react badly to the slight drop in blood pressure that you get with the wrap and don't appreciate how quick that 30-40 seconds is, and they give any pressor, it goes directly into the pump, not to the patient. So it doesn't restore their blood pressure, but it returns to the circulation the very moment that you go on bypass. And that, together with the two other factors, which are the viscosity and the vasoplegia that normally a bolus of crystalloid generates, in addition to that viscosity, you have now three significant factors that normally maintain blood pressure, but in fact has a massive overshoot. So it comes down to the education and their knowledge of what is happening, and also accepting, a small decrease in blood pressure for 40 seconds, 60 seconds is of really no consequence with a standard wrap on a MiECT circuit.
So you would suggest that we just do a quick wrap without them trying to adjust and then go on bypass?
Well, there is a role for the surgeon and the perfusionist here. If the blood pressure is slightly low before you do the wrap, allow them to correct the blood pressure a little bit and then start your wrap. But don't wrap without their knowledge that you are wrapping while they potentially give some pressor agent.
Okay, thank you.
Yeah, I think that's a very important point, and often we'll give almost a preemptive low dose infusion of phenylephrine or some such prior to the wrap. That's exactly the point, to try to prevent that hypertensive response if it's given as you finish the wrap and start the perfusion. So yeah, again, it's all about the integration and the communication. Yeah. I think that's really the message that's coming across.
Yeah, absolutely.
Yep. Well, thanks very much, Mark. I think we'll carry on now, and the next speaker will be Dr. Ashraf El-Sawi from Göttingen in Germany. Going to talk about MiECT from a surgeon's perspective. Well,
one of the problems doctors speaking about after all those is they leave little to say. So I'm concentrating on my own results, research results, because these are naturally those things that they don't mention so much. Otherwise, they've mentioned any literature that I usually mention in such a presentation. And I'll try to catch up with some of the things that have been said. We've just seen the importance of physiology and the elephant in the room, the duration of cardiopulmonary bypass. We've seen from Apostolus how to deal with massive air entering into the system in a hybrid circuit. We've heard from Kyriakos that it's not a plug and play. We've heard from John that we need the surgeon to champion this. And we've heard from Polychronos that with more complex surgeries, we're expecting more morbidity, which can go as high as 30%, or if we go into mitral valve procedures. So these are my disclosures. The reason why we aim for minimal invasive approaches in surgery is that we have a learning curve in the beginning of our training. And once we reach this plateau, we see no real gains that we can get from doing everything as we usually do them every day. And we hope that with going into minimal invasive approaches, that we will improve our results further. And it's quite easy for a surgeon to comprehend if he goes from full sternotomy on bypass CABG into upcap surgery, or into minimal invasive approaches for aortic valve replacement or mitral valve reconstruction, that there are quite challenges that he will meet. And these challenges are all taking place in his operative field. What his binoculars are seeing the whole time. He's not taking real attention to the perfusion circuit. He's sometimes communicating with the perfusionist or the anesthesiologist, but his main perspective is his surgical field. And as such, and it is definitely something that is challenging for a surgeon. So he accepts the challenges that come with it, the adaptations that he has to undertake. And it's quite clear from the beginning that he has to adapt in order to manage these challenges. But when it comes to another minimal invasive approach, how do I go back? Okay, when it comes to another minimal invasive approach, a MiECT, for the surgeon, from his perspective, I've been doing CABG on pump, and now I'm going on a MiECT. From my operative side, there is very little change. He's expecting to go on a plug and place scenario where everything is managed by the perfusionist and his role is limited. And if he doesn't go into a knowledge of the circuit that he's going to work with, it is quite irritating at the beginning because he's expecting everything to go as usual. And it's quite easy to comprehend when a change from a conventional system to an ECMO setup, that this has to get benefits because the longevity of this setup is days. You can keep a patient on ECLS or an ECMO for 7 days, and before you start worrying about the drawbacks of the system. But after exceeding a cardiopulmonary bypass of 3 or 4 hours, you usually get a bit irritated. But it's quite easy to comprehend that this difference comes from the respecting of the physiology. So it's no wonder that the simplest form of cardiopulmonary bypass is an ECMO setup. You have your lines, your oxygenator, and your centrifugal pump. And this was the first system introduced by Regensburg and Paris in the 90s. But keep in mind, the reason why this was introduced was not the wish of a surgeon to improve his performance. The main drive for this was OPCAP surgery. They were reluctant to adapt OPCAP, and they wanted to improve the system in order to be an alternative to OPCAP. And this is one of the challenges that most people up to now, even more than 30 years later, they still see MiECT simply as an alternative to OPCAP. And it is quite easy to comprehend that these goals are similar to those which make an ECMO better than a heart-lung machine. We have a reduction in forest surface area. We have a reduction in inflammation, coagulopathy, air-blood contact. But it's not only a matter of getting rid of your cardiotomy suction or your reservoir. So why are surgeons so reluctant to adapt to this and prefer to adapt to that? Because here they see difference, here they have to be convinced. But at the end of the day, Mark said the elephant in the room is the duration of your operation. And the advantage of this is irrelevant from the duration of your operation. If your total operation time is 2 hours, 3 hours, 4 hours, the advantage is from the start, and you're not gaining more advantage. But when you're on a MiECT, time makes a real difference. So it's a preservation of homeostasis. And again, preservation of homeostasis is a team approach. We've heard a lot about communication. And the quality of a team's performance is dependent on the quality of its interaction, of its communication. We saw that closed loop communication in the previous presentation. And these are examples from the internet of the teamwork. And it's obvious that the communication isn't working right in all these 4 instances. And this is how it should work. Everyone has his own role, but the goal is clear for everyone. And the next problem is common goals. Of course, we all aim to improve the quality of patient outcome, but we define this quality differently. A surgeon concentrates on the surgical technique. I want to have 90% mitral valve reconstructions, 10% replacements, then I'm a good surgeon. I want graft patency. The perfusionist is concentrating on goal-directed perfusion, kidney injury, and the anesthesiologist may be concentrating on blood patient management. But if not all those are not working together in order to achieve the same goals, which is an optimum outcome for the patient, then we're losing. We're not having the utmost from that synergy. And at the end of the day, this optimum outcome is the best guarantee for improvement in quality of life, which is at the end of the day what the patient is looking for. So from a surgeon's perspective, from this communication, from this teamwork, and from adopting a MiECT, it comes down to three basic questions. What are we doing? Why are we doing it? And how can I help? How can I be a part of that team? So we'll start with what are we doing? And we will not start here. We'll start with our position paper published in 2016, also pre-mentioned, which defined the types of systems. This is a type 1 system. You add it to an ECMO cardioplegia, and you can do some volume management with a soft bag, and this could be suitable. This could work for CABG, but still there is an additional risk. And the main drawbacks are a drawback of volume handling, of air management, and blood management. Einstein once said, everything should be made as simple as possible, but not too simple. And as such, there had to be an evolution of the systems. They had this introduction of type 2 systems, made the system safe. It introduced a utility of micro air handling, where air is detected by air bubbles are detected by a bubble trap. They give a signal to the centrifugal pump, which ramps down. An electronic venous occluder occludes the venous line, so these air bubbles are trapped in the bubble trap. You can get rid of the air bubbles, then signalize to the system everything is okay, and it ramps up again. This type 2 system is safe for CABG surgery, but if it's really suitable for valve surgery, you can do a valve surgery with a type 2 system, but you still lack a few accessories. And this is the soft bag that we have seen in Mark's presentation. Here it works as a plug and play system, where you can introduce it in the system, even on a running system in case of need. But if you're planning valve surgery from the beginning, you'd introduce it through a line. The vent is driven by a roller pump into that soft bag. Gross de-airing takes place in that soft bag, and then when you give the volume back, it goes into the venous line, and micro air bubbles are again removed from the system. So this is quite suitable for valve surgery because you have a solution for venting. And in case of major air getting into the system, you can integrate through connectors, which are large. You see them here of the venous line. They're disconnected. You have a venous reservoir, which has reconnected lines, and you just open with a click this one, click those in, and you go into a conventional system. And of course, you can go back from a conventional system back to a type 3 system by just bypassing this reservoir. So this is a type 4 system. It is a universal extracorporeal circuit that can be used for all types of cardiac surgery. The two philosophies here, the hybrid philosophy, where you have these accessories integrated and you clamp them out and just open a clamp in time of need, or you have the accessories as standbys which are pre-connected, which you can integrate into the system at any time. Of course, this has the advantage that you're sparing the money that you're paying for these accessories. For mitral, it is very seldom that we need these accessories. And you can see this is a study done by Patel et al. In which they challenged the system, a conventional system, to a type 2 system. and they looked at microembolic signals and transcranial Doppler, and found no difference if you're using a conventional or mini bypass, but they had a significant difference in gaseous microemboli in the arterial line, which were significantly higher in the conventional system. So obviously, at least in a transcranial Doppler, there weren't differences, but why challenge an Achilles heel? So what can I, as a surgeon, do to help? First of all, we can use a double ligation around the venous cannula to prevent air from getting into the system, even if my sutures have torn up the atrium. By applying a ligature below my sutures, this would prevent air from getting into the system. The proper choice of cannulation site and cannulas. When I began doing mitral valve surgery, I noticed that I often got air past the cannula that was inserted in the superior vena cava. So I thought that one of the problems is that the cannula going into the inferior vena cava is you're always cannulating the atrium. So this is the better tissue for cannulation. The superior vena cava is very thin, so I introduced these straight cannulas, which are wire enforced. And after introducing the inferior cannula, I go on bypass. And once the atrium is drained, I introduce the cannula over through the appendage right up into the superior vena cava before applying my snare. And this solved the problem. At the beginning, I had maybe 20% of cases where I had to integrate a reservoir. After adapting to and using this technique, it is very seldom that I use a reservoir nowadays. You have a proper communication is a must, especially when you're inserting or removing your cannulas and vents. If you're removing a vent and you're not telling the perfusionist that I'm removing the vent from the superior, from the aorta, he will get air, and this can be avoided. And in case of worst case scenario, I have a tear in the atrium or something, I can, for just a rescue solution, introduce flood the operative field with saline by some time before the perfusionist can integrate a venous reservoir. What about bleeding management? You have to have a concept for dealing with shed blood. The main concept is a cell saver. Some centers prefer a smart suction. Smart suction has the possibility to differentiate when the sucker is immersed into the blood, and when air comes, it stops the suction. However, it is not only a matter of avoiding air-blood contact. There is a lot of inflammatory mediators in that blood. There is a fat globuli from the sternum and from subcutaneous tissue. I don't want to get them into my machine, so I prefer a cell saver. And you have a modular system where through this soft bag, you can introduce a cardiotomy suction in case of major bleeding. But at the end of the day, the most effective means of reducing transfusion requirements still remains avoiding blood losses, and no one can do that except the surgeon. So if the perfusionist and then a surgologist are trying patient blood management and the patient and the surgeon doesn't care, it will be very tedious. So the surgeon is the gatekeeper. Again, why challenge an Achilles heel? Proper choice of cannula sites and technique. Ever since I started doing redos with mini bypass, or MiECT, I started using a OPA cannula. I inserted in the Seldinger technique, so I punctured the cannulation site, introduce a wire, and then Seldinger the cannula over the wire. And ever since I started doing that, I very seldomly have to apply a second tourniquet, second purse string suture around the cannulation site, which of course, once you're doing a redo, you want to avoid any blood losses. So this worked very fine, at least with me. Diligent, meticulous hemostasis during all the steps of the operation is important. Timely communication in case of greater blood losses, timely integration of a cardiotomy suction. If you have the accessories, use them. Keeping track of your blood losses. I avoid irrigating the whole time when I'm knotting my stitches, because I want with one look at the cell saver to know how much blood have I lost till that point. Also in order to define when will I introduce my cardiotomy suction if I need it. Timely processing of the cell saver blood. You don't have to wait till the end of the operation, and then you're after 2 hours on bypass, you realize that there is so much blood in the cell saver that you're having hemodynamic problems, and you're starting to give saline just for volume management. So they can do that in the middle of the operation and recirculate your blood. Retrograde autologous priming. It has not only the advantage of increasing viscosity and so on, perfusing the higher hemoglobin. From a perspective of goal-directed perfusion, perfusing a patient with a higher hemoglobin can't be the worst thing that you're doing. Low volume blood cardioplegia. In case of double cannulation, you can use Brettschneider custodiol, but please drain it through the right atrium. A hemoconcentrator is not equivalent, because this will take time in order to get your hemoglobin higher. You can avoid that from the start. Minimize intraoperative blood losses. If you're doing a combined procedure, try doing your bypass before opening up the aorta for aortic valve replacement. There will be some blood that you will lose there. Assure proper positioning of your vent before aortotomy. Just put your hand behind the heart, palpate the tip of your vent, and be sure that it lies where you want to have it. Close the left atrial appendage before resecting it to avoid any air getting into the, too much air getting into your vent. And it works. You have a reduction. This is before the COMEX trial. The COMEX trial hasn't produced results yet. We hope tomorrow we'll see the first indications of such results, but up till now, this is the largest prospective randomized multi-center study conducted in the field. We introduced 500 patients into that study, elective CABG, AVR, or combined procedures in 6 centers in Europe. And we saw that we had a significant reduction in transfusion requirements and transfusion rates, not only for packed red blood cells, but also for fresh frozen plasma. We saw that in 30% of MIECT patients, we were actually retransfusing the cardiotomy suction blood, but in 70% of cases, there was so little blood that it wouldn't justify washing it and reintroducing it into the patient. And the mean volume that was retransfused was around 300 milliliters. Looking at blood losses within the first 12 hours, we didn't see any differences between the groups, but we saw differences in the reoperations for bleeding, which were statistically significant. So obviously, if you adopt all these techniques, it works. However, in 10 patients, we had to introduce the cardiotomy suction, the accessory, because of massive intraoperative bleeding. This was mainly in centers that were not so experienced with the technology. And in one patient, we had, it was missed. A colleague of mine was performing aortic valve replacement with an annuloplasty. And while going off bypass, there was some bleeding at the root, aortic root. He was very concentrated on solving that problem. The perfusionist was getting some air into the system. He was very eager to avoid integrating a reservoir, although he had one. And the anesthesiologist just didn't pick up how much blood they were getting into the cell saver. At the end of the day, the patient, the transfusion requirements amount were significant. He got 8 packs of red blood cells, 6 packs of fresh frozen plasma, and 1 unit of platelets, and they retransfused after salvage 2,300 milliliters, which is obviously too much. But the problem is They had their accessories. They didn't introduce the accessories because communication failed. So is this a system failure? No, obviously this isn't a system. It isn't a system failure. It's a team failure. Is this transfusion requirement of significance? There is plenty of research on the significance of blood transfusions, and there is research about liberal transfusion strategies, restrictive transfusion strategies. But if you look at this publication with, I think, over 10,000 CABG patients, 50% were transfused. And I don't want you to concentrate on the difference in mortality with the transfusion of 6 units of red blood cells or 3 to 5. I want you to concentrate on the first 3. Those are the patients who didn't get any transfusion. Those are the patients who got 1 unit of red blood cells, and those are the patients who got 2. So here, even here, they saw differences, and they said that these differences were significant and they were dose dependent. So this is definitely avoidable with the MiECT system. Further, we can see that this is a publication where they just differentiated. These were all patients who were transfused, and they just differentiated the age of the stored red blood cells. And they saw that those that were fresher had a better transfused with fresher red blood cells had a better prognosis than those who were transfused with older red blood cells. So this should mean something. Further, we saw a significant difference in freedom of major adverse events, cumulative of death, myocardial infarction, cerebrovascular accidents, or reoperation, which were in favor of the MiECT system. And in the multivariate analysis, it was the only independent, the type of system was the only independent risk factor for freedom of major adverse events, with an odd ratio of 1.8 and a statistical significance of 0.04. The others being age and gender and type of operation, but those are things that we're confronted with, which we can't change. But you can definitely change the type of system that you're operating with. And this even works with more complex cases. This was my first attempt in doing all comers with a mini MiECT system. It was in 2012 on 13. And in that time frame, I operated 38 patients, complexer surgeries. And for me, complexer surgeries are all that goes beyond CABG, AVR, or combined procedures, because we had proven in that study that works. And we had 15 redos, we had composites, we had mitral valve reconstructions, and so on. And we had to retransfuse what we gained from the cell saver in 76% of patients. That means 24% of patients. Again, the amount of blood was too little to retransfuse. With the amount retransfused was significantly higher, around 750 milliliters. We had to introduce cardiotomy suction in 3 patients and a reservoir in a single patient. And transfusion requirements were low, and even need for coagulation factors were low. These are the 38 patients. This is the patients at risk and their logistic Euro score. So we had 9 patients with a logistic Euro score of under 5, 13 with 5 to 15, 5 with 30 to 40, and 3 with over 40. At the end of the day, only a single patient of those died with a mortality of 2.6%. And if you add all those logistic Euro scores together, you come up with a score of over 600 if you use Euro score 1, or over 400 if you use Euro score 2, meaning a prediction is that 4 to 6 patients would have died, but only a single patient died. We've spoken of the surgeon to champion this thing and about a team approach, but which type of surgeon is suitable for such a team approach? This is Snow White's stepmother, who's the fairest of them all. This surgeon doesn't need a team approach. He doesn't need a MiECT. He can achieve everything on his own. This one might realize that it's important, but who wants to work with him? He's not suitable in his communication for a team approach. And this one, he will try to get the best out of every team member to get in a collective result with an optimum outcome. But he's difficult to find. So it opens up new perspectives with higher goals. If this isn't convincing enough for a surgeon to adapt this technology, I hope the next slides are. So we're going beyond surgical performance to an optimum outcome, because that is what I want for my patient. And what is this optimum outcome? It is for freedom of any adverse event, of any blood transfusion, because even if you don't think that blood transfusions are reducing the quality of your performance, reducing the patient outcome, at least you have to acknowledge this is a potential risk. And a normal person would want to avoid potential risks. So we have no adverse events, we have no blood transfusion, and we have no atrial fibrillation. And then in this multi-center study with 250 patients in each arm, we found that the rate of achieving this optimal outcome was 52% in MiECT and 41% when we use the conventional system with the statistical significance. And again, it was the only modifiable risk factor for such an outcome. And if you look just at the results of Braunschweig, this was the lead center where I worked in the past, and we had contributed to this study with almost 80 patients in each arm. We were the most experienced center. 75% of our patients were cabbages. But if you look at the more complex cases, you will find that 14% were combined procedures in comparison to 6% in the conventional system. So these were the patients with a higher risk. Nevertheless, we achieved an optimal outcome in 71% of these patients, with a conventional system only in 52%. The same surgeons, the same perfusionists. And this was statistically significant even in this group size. And if you look at those complex cases that I showed you, the redos and so on, optimum outcome was achieved in 41%. Now you can presume that most of these factors can be influenced by your surgical technique, by your surgical experience, and so on. But to be honest, I don't know what kind of surgical technique should I adopt in order to avoid an atrial fibrillation. However, we see that the incidence of atrial fibrillation in that multi-center study was significantly reduced through the use of a MiECT. Again, age was significant, and the type of circuit was the only modifiable risk factor for, and it was statistically significant in the multivariate analysis. This is validated by results of meta-analysis of 41 randomized studies, and we see that the difference is 1/3, and the difference is 1/3. So this seems to be quite correct. But this only reflects what happens during the in-hospital stay. So what we asked ourselves is, what happens in the long term? How many of these patients go home, go into long-term follow-up, long-term results with an atrial fibrillation? So we had 763 patients, survivors of elective CABG with a preoperative sinus rhythm. In Germany, we have the unique situation that most of these patients, almost all of these patients, go post-operative to rehab. So 90% of those patients went to the same rehab center. And we did a propensity score matching for those patients. And we could see that the incidence of atrial fibrillation on discharge was significantly higher. But on rehab, all got Holter ECG at least once, maybe even twice. And we saw that going into long-term, the incidence was 4% for the conventional and 0.4% And on multivariate analysis, we could see that the type of circuit was again relevant for that. This is the last patient I'm going to show, because Polychronis said with more complex surgeries, we're expecting more morbidity, up to 30% if we include mitral valve surgery. So this is a patient that I did back in 2015. I mentioned her several times before in other conferences, but I find it's a quite interesting case. 77 years old, female, elective surgery, had a severe mitral insufficiency. And here you can see calcification in the mitral valve annulus, which is quite a risk for the operation. We had moderate mitral stenosis, moderate aortic stenosis, and severe tricuspid insufficiency. She presented with dyspnea on mild effort, chronic atrial fibrillation, previous cerebral insult 4 years earlier with no residues, preserved left ventricular function, no ischemic heart disease. She had a body mass index of 38, which is quite remarkable because even some experienced MiECT surgeons would say that this is a contraindication for MiECT, a pre-operative hemoglobin of 11, thrombocytes of 200,000, and a normal creatinine and normal ENR. Normothermic cardiopulmonary bypass, RAP, Brett Schneider cardioplegia, but a snare around the and puncture in the right atrium when on full bypass to drain that cardioplegia. So it's not adding to your hemodilution, but you have a longer time where you don't have to readmit cardioplegia. An OPA cannula inserted in Zeldinger technique, two cannulas, straight wire enforced in for the inferior vena cava and the superior vena cava. So following extensive decalcification of the mitral annulus, we had to reinforce it with pericardial patch, BU glue, and we could even see the epicardial fat. So we actually had a rupture there, and we reinforced it with a pericardial patch. It was quite extensive, getting rid of this calcium. We did a mitral valve replacement, an aortic valve replacement, a tricuspid valve reconstruction, resected the left atrial appendage, and had a total clamping time that exceeded 3.5 hours, a bypass time that exceeded 4.5 hours. We didn't need any accessories, no cardiotomy suction, no reservoir, and the amount of cell salvage that was retransfused was 1,200 milliliters. That was going on during the operation and not at the end. We started washing the blood, and she did receive no blood transfusion. On getting to ICU, she had a hemoglobin of 9, starting 11, a quick of 40%, and thrombocytes of almost 70,000. So we did a ROTEM because these weren't so encouraging, and we saw that she just had the prolongation in the clotting time on INTEM, so she got some protamine, she wasn't bleeding, so we didn't do anything else. She was in need of low-dose dobutamine and noradrenaline. On arrival at ICU, postoperative blood loss up to the 16th hour postoperative was 200 milliliters. So obviously that was the right decision not to transfuse her. The patient was extubated after 15 hours postoperatively and remained on ICU for 4 days. She was discharged to rehab on the 11th postoperative day following an uneventful postoperative course, having received only 1 unit of packed red cells on the 4th postoperative day at a hemoglobin level of 7.5. So obviously this is no optimum outcome, but I don't think that this would have been achievable without a team approach, and it would not have been achievable without a MiECT. This is a case where no surgeon can stand here and say, this is only because I'm so good. Thank you very much.
Comments? Yeah. Get the floor mic, please.
Great presentation. When you look at your complication rates, have you looked at just like perfusion specific complications compared conventional to MIECT?
No, actually, we haven't done that because we would have expected that from my daily feeling, I don't think that we had any significant ones. So we didn't have a situation where we had a problem to introduce these accessories and thought that this was jeopardizing the patient. That I haven't seen that in over more than 2 decades now. Yeah, I've been doing MiECT for 2 decades. I cannot remember a single patient where I had the feeling we were jeopardizing this patient's life. He was at risk because we were using MiECT. I've shown you there are team failures, of course, but we didn't analyze that. But these are seldom because in that center, with time, everybody was acquainted with the technology. And from 2012 to 2020, beginning of 2020, when I was still in Braunschweig, I was doing all my cases with MiECT, with exception of circulatory arrest. And I was doing it with all perfusionists, 7 different perfusionists, day or night time, emergency or no emergency. I was doing it with all assistants. I was doing it with all scrub nurses, with all anesthesiologists. And what's essential is you have to give them feedback. Almost yearly, I had a presentation in the anesthesiology department where I showed them the last results. I compared it to the literature. I was showing them we are really doing good work here.
Yeah, I guess as a perfusionist, I guess the biggest thing you look at this, like there's a big change. I would probably argue a bigger change for the perfusionist than it is for you as the surgeon or the anesthetist. And just technically.
Yeah, but the problem is if the surgeon goes into that just because he's not elevating the heart for an op cap and he's not utilizing any new machines or new techniques, he's not looking at the valve through a keyhole. He is expecting that everything is fine. This is your problem. You will do everything so that I can perform surgery like I'm used to do. But if you have problems with the venous return because the cannula is not sitting well in the inferior vena cava, we've seen that in the TEEs that Mark has shown us. You will not be able to handle that if the surgeon refuses to cooperate. And if it's in the middle of his anastomosis and he has to, for a coronary bypass, and he has to change his whole setup, this is irritating. And it's not adding to the quality of your communication because you didn't communicate that pre-hand.
Yeah.
He has to know, although the main changes on your side, I have to adapt to these changes.
So what did your perfusion group do to adapt to a new technology? Like what was their process?
We were taking it step by step. And the point is, when in 2000, the main reason why in 2012 I said now I want to do everything with MIA bypass is because I was at a meeting of the German Society, and there was a session which and someone introduced a study on MiECT. Actually, the person doing that study, they were comparing MiECT to conventional system on cabbage. They had 2 different MiECT systems, and she was using the same system that we are using. And she mentioned that one of the drawbacks of MiECT is that you don't have accessories. Well, we had these accessories. She didn't know. And then the whole auditorium started discussing why isn't the system picking up? And they were all agreeing. We all used it. To do some studies 30 versus 30, but once we go out of a study, no one wants to do it anymore. because the quality of the communication didn't pick up. When I started in 2012 or 13 saying I do everything, I discussed it with my perfusionists at first. And they told me, do you think you will be able to do a triple valve with a cell saver? So I told them, we have an accessory, let's try it and see. And another advantage was that for Jehovah's Witnesses, we had declared MiECT as the circuit of choice, regardless of the type of operation that you were performing. And we saw it works very well. And from that experience and from a communication that everybody realized that was improving and catching up and standing up to the moment, we said we can take a step further. But the setup has to be, you have to take it step by step. You have to realize that you have to change, you have to adapt, and you have to improve on your communication. And once the perfusionists see the third type of surgeon in you, they will come aboard. But if they keep looking for him and only see the other two, I don't mean that I'm the third surgeon. I believe that every surgeon has those three characters inside him. Yeah. But I have to get rid of some of those characters in order to be able to lead a team. I won't champion a team if I'm Napoleon.
Great. Very good. Great work, Gosh. Great work.
Ashraf, I think that's really, really important. What, again, we're talking about the same theme all the time, communication. And I find it quite interesting. Again, venous return has become an issue. And for years, we've been talking about cerebral perfusion on bypass. And often, again, even with conventional bypass, you can have problems with the venous cannula. And I've heard many a surgeon say, well, can you deal with it to the perfusionist? Just cope with it, because I don't want to stop my operation until I point out that the brain sats are going down. You might have a mean arterial pressure here, but if your venous pressure is here, there's no perfusion to the brain. So these type of communication issues are basically endemic in many different settings. And again, this is an instance where trying to address these interprofessional relationships, communication is fundamental.
If you have a cannula that's just fixed around the right atrial appendage and you start manipulating the heart, you're moving the cannula all the time. So once you come into a position where you're comfortable with that, you just secure the drapes with a clamp around the cannula. So we have a second fixation outside the heart, so that when you manipulate the heart, the risk of dislodgement, even if it's a few millimeters, because sometimes the only thing that you have to do is pulling on it for a few millimeters or introducing it further in for a few millimeters. And if that solves the problem, this is time worth investing.
Yeah. Again, you don't look, you don't see. So,
But-
well, very good. I think this is exactly what we're interested in, this type of a Q&A, and I think we'll carry on now with, I think it's Professor Serix. Oh, he gets a round of applause.
All right, well, I'd like to thank the organizers for inviting me here today to speak. So I just wanted to just talk about a perfusion's perspective for MiECT. And to be quite honest with you, I want to put it into the perspective of what would you do on conventional bypass anyway. So so there's a lot of conventional wisdoms out there, and we talked about this a lot today. You know, I think the number one safety concern as a perfusionist is the air handling capability of a MiECT system. I think the premise out there is, well, you know what, you can't handle air, you know, and it kind of scares the perfusionist to death. There's no, besides a type 1 system, I mean, every MiECT system out there has a venous bubble trap that actually takes care of the air. So if you actually, so our system is no different than anybody else's system out there. So if air comes into the venous, air gets introduced into the venous line. There's a bubble sensor on our circuit. We have a bubble sensor in the venous line, plus a bubble sensor after the trap. And anytime this sees air, automatically turns on an air purge pump. It's just basically, so we just pump the air out of the venous line. If this actually gets overwhelmed, then there's another sensor here, which will basically shut the pump down and clamp your clamp your line. So that's a way to actually take care of that air. Now, there are bailout systems that the HEPA group uses and Astras group uses in Germany. So there's other ways to accomplish that. But if actually you look at it, like if you just look at a venous air algorithm for conventional versus a MiECT, venous air gets introduced into the system. What are you going to do? Conventional system, you're going to decrease your flow. MiECT, it's not going to be any different. You decrease your flow. You have to walk out the air for a conventional system. Actually, you can actually actively remove the air for MiECT. So it's actually a little bit simpler. At the end of the day, you still have to fix the problem and recommence bypass. So technically, there's really no difference in MiECT versus conventional cardiopulmonary bypass in the way air is handled and how you would interact with that. The bigger the cannula, the better the flow. Well, not necessarily, especially for venous cannula in MiECT. And we actually have touched on cannulation, right? Usually you see problems with cannulation at the beginning of a case, right? So if the cannula is not placed properly, you'll see that right off, which is much the same with conventional, actually. Hey, my venous return is down. I'm not getting a good flow. No different with MiECT. So the thing is, with MiECT, you're going to have to deal with it. You just can't add volume, because adding volume is just, which we would technically do for conventional bypass. Adding volume is not going to solve your problem. You're going to actually have to make sure that the cannulation is properly placed. Cavitation is a big problem, and usually that has to do with volume. So if you have a big venous cannula in the atrium, say, if that's taking up a lot of that atrium, then you're going to see a lot more cavitation. So in these cases, smaller cannulas are probably better. And it's not uncommon for us to use, we use 3-stage cannulas, triple 29s, 29, 37, 37, a dual stage 34 or 32, 40. For AVRs and the MVRs, we're using even smaller cannulas. Maintenance of bypass. So once you actually go on and you've got that figured out, I mean, maintenance is usually a piece of cake. However, when they start positioning the heart, especially if they're doing, if it's just a cabbage procedure, the position of the heart certainly can block your venous return. And again, communication is essential. All the surgeon has to do is just drop the heart and reposition in a slightly different manner, or they can just loosen their grip on the heart, and actually your venous return will actually increase. But really, that's no different than conventional bypass. We're seeing the same, you're going to see the exact same thing. But as to John's point, usually surgeon says, well, can't you live with it? Well, you know what? Yeah, I can probably live with it. I don't know if the patient can live with this. Do we need to maintain a flow of 2.4 liters per minute? Well, I think early in our experience with mini bypass, MEAC, we did notice that seemed like we were flowing a lot lower flows with patients compared to our conventional, because we always received, our conventional, we always maintained calculated flow, whereas MEAC, we're down flowing around an index of 2 as opposed to 2.4. But if you actually look at, if you actually do a calculation looking at the oxygen content and carrying capacity and oxygen delivery, and just to give you a scenario, if it's a 170 centimeter standard patient, 170 centimeters, 70 kilos, VSA 1.8, calculated flow is about 4.3 based on an index of 2.4. But if you compare the priming volume of a conventional versus MEAC, let's say 1,500 for conventional, which is fairly standard. MEAC 500, I could argue that is probably even less for MEAC, especially with wrapping. But we can go into that a bit later. And patient's total blood volume is about 5 liters. And if you actually, the hemoglobin on bypass right now, as soon as you go on, for conventional, you're hemodiluting patient to 90 grams per liter, but for a MEAC, it's only 107 grams per liter. So again, if you do all the calculations, you're delivering at an index of 525. Your oxygen delivery is 525 mils of oxygen per liter of blood, versus a MEAC, you have almost 100 mils of oxygen more per liter of blood. You actually do a reverse calculation. So a flow index of 2, you're actually delivering, if you're flowing at an index of 2 for MEAC versus 2.4 for conventional, you're actually delivering the exact same amount of oxygen to a patient. There's other things that we have as well. We're actually able now to measure oxygen delivery and see exactly how much oxygen we're delivering, what the exact hematocrit is of a patient real time. And obviously we're always measuring venous saturations and your cardiac index. And I think, early in our practice, we found that, yeah, we were flowing at lower flows. Basically, you're flowing to what the patient needs, right? But now I think, as you get more and more, experience, you find that that's probably not the case anymore. We just flow to what the patient needs. I wrap, so my prime volume is low anyway. Well, prime volume is one thing, but your prime is actually divided into 2. You have a static prime, and you actually have your dynamic prime. So your static prime is just a prime volume of, you're not flowing to the patient, is just whatever's sitting there in your reservoir, right? So you can easily get your static prime down. So for a conventional bypass, static prime is about 1,200. MEAC around 900, could be a little less, maybe 50 or more. You can, if you wrap both, just take out 500 cc's from both patients, because you can actually wrap more for MEAC because there's a less volume to replace compared to conventional. But this is where, this is the Achilles heel right here. Your dynamic priming volume is still 1,500 for a conventional bypass. So either the patient has to be volume overloaded, or the patient has to make up for that volume, basically. So either if they have it, great. If they don't have it, then you're actually adding volume to maintain this dynamic priming volume. Whereas for MEAC, your static volume and your dynamic prime is totally the same. And, so this is where your level sensor cuts in. It's like, you're not going to flow anything under that. So because of this, if you actually look at the volume management, the patient, as was said earlier today, the patient is the reservoir. And the flow, your flow is very sensitive to the volume status of the patient. So you're constantly watching the ins and outs of your patient. So whether that be urine output, blood loss in the surgical field, or blood loss to the cell saver, or it doesn't matter. The patient becomes very sensitive, and you have to replace that volume somehow. So the conventional, you're giving large aliquots of volume, but for MiECT, small, very small 50 cc aliquots of blood will return you back to normal flow. And versus conventional, we're normally used to, I don't know if you can see that well, but for a conventional circuit, you're normally used to giving large volumes. So we'll give, a couple hundred cc's of blood at a time for conventional circuit, whereas MiECT, you're just giving like 50 cc's at a time. So at the end of the day, what happens is, you find, this is prime comparisons that we did. Basically, this is when I was at Trillium. Our standard priming volume was about 2 liters, but with wrapping and that, our volume with wrap was 1,500. But if you look at, our MiECT systems at the time, the lower the volume of the MiECT system, the lower the prime volume. But look at this, the balance. So not only is your prime lower, but you're giving a lot less fluid on bypass. So now conventional, yeah, we got our prime down to 1,500, but we're still giving over 1 liter of fluid on bypass, right? Whereas, this one, okay, we're only giving a 350 mils of fluid on bypass, and this one less than 200. So as you decrease the surface area of your circuit and the prime volume, you're definitely, that actually translates into the actual pump balances at the end of the case. One thing that we that's nice about our setup is we have a volume add pump. So we talked about vent blood and trying to keep up with vent and the issues of pulling taking volume blood off a patient. So with venting, we do get a lot of air. So basically we capture that instead of a soft shell, we capture that into a hard shell. And we have a actual a volume adder pump, which is kind of, so basically we have a pump directly hooked up to the venous line. So we're able to give volume, dial in the volume. So if our vent is, say, set at 200 mils a minute, we can give that volume back at 200 mils a minute back into the venous line to maintain a constant flow. Also, if there's like a level sensor here, so we're able to, once this level sensor is triggered, the pump will actually, triggered the pump to actually start. And so it'll automatically give that volume back into the venous cannula, and obviously back to the patient. Venous cannula is actually over here. This is the arterial cannula. And it also has, you see this red level sensor. If the blood goes down to that red level sensor, it'll actually turn this pump off. So you avoid pumping any air into the venous line. And we have a clamp here that we can actually manually add volume if we need to as well. If this was a closed reservoir, you could set it up to be to equal negative pressure. So as you're seeing a large negative pressure in your venous line, you could have a electronic clamp here to open up and actually give volume based on negative pressures. And what we all talked about, just another circuit. Well, unfortunately, no, it's not. This is not just another circuit. Circuit is one part of this whole strategy, as Polychronis mentioned this morning. we all have to, it's just not a plug and play system. We all have to work together. It's something that, you're not going to be successful unless you actually work together as a team to adapt this technology. And you do have to do this gradually. So you're sequestering suction blood, you're retrograde priming, you're using coated circuits, centrifugal pumps, and you certainly have to do a lot of emergency training too. So there's no way you're going to be able to adapt this system, this technology, until you actually start doing these. So you can do these in increments before you basically dive right in. So I just basically put to it, conventional wisdom no longer applies. I think it's still cardiopulmonary bypass. MIECT is still cardiopulmonary bypass. You were still doing things that you would normally do, or you should be doing during conventional bypass. And if you look at the STS guidelines in 2011, it said MIECT was actually class 1A recommendation, which means there was sufficient evidence that from multiple randomized trials or meta-analysis that this technology should be adapted. And in the 2021, the STS coming with the Society of Cardiac Anesthesia, AMSEC, the Perfusion Society, and Blood Management Society, they all came up and basically said this would be a class 2A, still a recommendation, and is reasonable to reduce blood loss. But what also you see is here is what we talked about, the whole thing: retrograde priming, continuous routine use of cell salvage, all these things. I mean, this is the MIECT strategy, not just the circuit. But regardless, and I don't think there's going to be one person that's going to get up here today to do a talk and not say that teamwork is essential. It is. We all need to communicate, and it doesn't matter if we do MIECT. I mean, it will make life even a lot better if we could communicate during conventional bypass as well. But teamwork is essential. It doesn't matter what operation you're doing. Thank you very much. Any questions?
So should we bypass older perfusionists and look into the future and start training them from the beginning with a MIECT?
Absolutely.
Would that be a solution?
I don't know. I don't know if it's I don't know if it's a solution. I think I think it would be a shame if we don't do it. I mean, obviously we have to look at the younger generation and train them and teach them.
I want them to start with a MIECT.
Start with a MIECT. Yes. And you know what? We've when I worked at Trillium Health Center, and new grads that we brought in, they actually started with mini bypass because that's all we did, right? And they didn't really know what conventional bypass was, right? They saw it in their clinics, but when they came to actually work in our institution, they were always using mini bypass. So so once you start from the beginning, it becomes very easy to adapt, and you don't even think twice. But I do believe, you guys are the future, and you really have to think about, we do have it in the curriculums, mini bypass. I don't think there's enough of it in the curriculum. We do have, we dedicate one day to mini bypass, but I think obviously there should be a lot more. And hopefully by the students not having, 3 days of, or at least 2 days of mini bypass talks, and hopefully they'll be able to at least think in the back of their minds the things that they want to be doing in their careers.
On that same theme, Cyril, is it possible that the students would go to centers? Yourself particularly, just to get a couple of days experience during that crucial, initial.
Yeah, I mean, it's,
Learning the skills. Yeah.
they have, I know in the past they've done it. I know Trillium Health Center is, we've had students come to us and look at, observe mini bypass. You still have observation days, right? Do you have students? Do you guys get students? So you don't have students actually operating mini bypass? I mean, we did in the day. I mean, that was something that the school stopped because they didn't need as many clinical sites anymore. But I do think that's something that, I mean, it's the future, and I believe that we still need to, we need to start with the school and say, yeah, this is the future. Everybody should get some exposure to this.
Well, I think the good news is that, Graham's here, and obviously, your role in this society, this meeting, and leadership in perfusion in general would be a nice opportunity to, make these kinds of recommendations. Because as you say, if this is what you're introduced to, this is what you learn.
This is what you learn. This is how you know.
Since it seems to have a more, you're integrating more complex facets. And if you start off with that, then everything else becomes, relatively straightforward. Whereas if you increment up to it, you're working up to some big thing. If you start off that way, you just accept it as this is.
Yeah, and I mean, don't get me wrong. I don't think an older perfusionist can't learn this technology, right? But there is, let's face it, as you get, as you start getting when you're in your career, once you start getting comfortable with things, it becomes very, very hard to change. And we had to really twist Amanda's arm to start doing mini bypass, but no, we didn't actually. But I was just saying, just joking. But no, but you have, but it's all in the training, right? In the training aspect of it. So you just have to take the proper approach. And the proper approach is, as Asha has said, you do it in slow increments. Yes.
I have kind of a follow-up question to that. Now that you are comfortable with both conventional and the mini circuit, do you find it difficult to switch between them, or now that you're comfortable, it's like pretty smooth transition?
Difficult to switch between them? Yeah, because to be honest with you, I kind of feel like we should be doing all of our cases on mini bypass. So it's more, the difficulty is not technical difficulty for me. It's more, really what we should be doing what's best for the patient, right? And I still don't believe that conventional bypass is what's best for the patient. But again, to Ashraf's point, depending on the surgeon, yeah, it probably is what's best for the patient, conventional. I'm not going with, at this particular time. So
You can do both then.
Good.
All right.
Well, thank you very much,
Thank you.
Cyril. That was excellent.
we've got, so lunch is at the exhibit hall, and yeah, go mingle, grab some food, and we're back here.
1:30
1:30.
promptly, ideally, because we have a lot of virtual coming over from Europe. So 1:30, please, back if you can. We've just been notified the group in Europe is now available. So we're going to start this afternoon session. Now we're going to go through some aspects of technical aspects of MiECT circuitry. So we're going to start with Dr. Markus Honecker from the Clinical University in Ulm, Germany. And he's going to be talking about a novel positive displacement pump to improve pulsatile perfusion. I'm very interested to hear this, Marcus. Pulsatility has been one of my underlying themes for a long time. So with no further ado, Dr. Honecker.
Thank you, Mr. Chairman. I would like to thank the organizers for having us here, also on behalf of Professor Liebold. And I'll be happy to provide the data from a recent study. So I'll try to share my screen. Okay, it's live, so we're good to go. First of all, some disclosures. We initiated the study, but we obtained the prototype of a pulsatile pump from the manufacturer free of charge, although we paid for the transportation back and forth. The manufacturer did not have any control in terms of conduct of the study or presentation of the results, though. Otherwise, there were no conflicts of interest. Now, first of all, why are we looking at pulsatile perfusion and extracorporeal circulation? The reason is mainly that the human heart by default provides pulsatile perfusion. As you can see in these standard images of aortic pressure over a cardiac cycle. There's also always been discussion of whether this is necessary during extracorporeal circulations. The first models of pumps, the conventional roller pumps, they are slightly pulsatile by default, although the pulse pressure is fairly low, and some of them have additional settings to modulate the rotational speed in order to improve the pulsation, though. Problem with these pumps is that the pulse frequency depends on the flow rate, so you can't control both parameters independently. And these pumps are usually used in an occlusive fashion. The more recent pumps, the diagonal or centrifugal pumps, they're more popular in MIECT applications. These pumps are non-occlusive. They're also non-pulsatile by default. But again, in many of these systems, you can modulate the rotational speed within each cycle to obtain a pulsatile flow. What are the benefits that would be expected from pulsatile perfusion during cardiac surgery? The main point is organ perfusion or organ protection, so to speak. Especially kidney and the brain are very sensitive to low oxygen values. And there have been recent studies that actually demonstrate that pulsatile flow improves the microcirculation, even post-operatively. So you could expect organ protection by pulsation. The regulatory mechanisms seem to be mostly endothelium-based because this organ can sense like shear forces, wall tension, hydrostatic pressure, pulsation, and can generate paracrine substances which regulate the blood vessel tone, especially in the capillaries. There have been a couple of clinical and preclinical trials with opposite results. Some claim that pulse does have an effect, some claim it doesn't. So we actually performed our own trial at Ulm University, which has been published 3 years ago. This was a prospective randomized trial using low-risk CABG patients with MIECT, and we used the Medos DP3 pump in a non-pulsatile versus a pulsatile mode. Much to our surprise, there was no change in renal or neuronal markers. during the study, although pulsation improved urinary excretion and reduced postoperative and intraoperative bleeding. There was also no effect on the pi1 TPA ratio, which had previously been published in pediatric patients. So we were asking ourselves the question, does pulsation actually have no effect, as these data would suggest? Or did we simply run that MIECT circuits under conditions which do not provide sufficient pulsatile energy to the patients? And in order to discuss that, I would like to give a very brief primer about how we can actually measure the effect of pulsation. There's this unit energy equivalent pressure, which describes the hemodynamic work required to transport a unit volume of blood. This is given by this formula. It's essentially a quotient of two integrals over time. First one, pressure times flow, the other one, the flow itself. And it's pretty obvious if you look at continuous flow, which we see on the right-hand side, those two flow terms cancel out. So in case of continuous flow, the energy equivalent pressure is simply equivalent to the mean arterial pressure. Otherwise, there's a surplus, which can be computed as the surplus hemodynamic energy, which is simply the energy that you gain by adding pulsation over a continuous flow. And we usually normalize that to the mean arterial pressure, so it's a percentage value, and it's also quite evident if you have no pulsation, the SHE simply is 0. Now, after our trial, we went back to the lab using a mock circulation and tried to optimize the circulation in terms of obtaining maximum surplus hemodynamic energy. I'll refer only to these two images, which is a very short summary of these trials. The main thing is we checked that the tubing is important. You need rigid tubing, not compliant tubing. Some oxygenators are better than the others, and you need a large enough cannula. This is, in terms of components, the most interesting result. But the main effect was with these console settings shown in these images. We compared the settings used by our perfusionists, which is this red curve, which is simply empirically obtained in the operating theater, and compared that with the results after optimizing that in our mock circulation. And you can see that by tweaking the console settings, you can achieve a huge increase in SHE and also in pulse pressure. But the problem is this effect is most dramatic at fairly low flow rates, at like 1 or 1.5 liters per minute, which isn't the flow rate that we would use during most of cardiac surgery. At 3.5 liters, the difference is significant but small, and you end up at an SHE of about 5%, whereas the human heart generates roughly like 10%. So this, I think we simply hit some physics limits of how you can tweak this DP3 pumps. So we looked out for alternative pumps, and this brings us to the pump used in the present study. This is a pump, actually a prototype. It's not what they have today, but the prototype manufactured roughly 2 years ago by Triphase Cardiac Pump, a small startup company near Perth in Australia. This is a positive displacement pump. It's this unit on the left. There's a stepper motor in this lower compartment which drives this shaft, and this simply presses this pressure plate against silicone tube, which is seen here. We'll see it better in the next slide. But that's the basic idea. There's a check valve, this brass thing down here, and another one at the end of this green outlet tubing. to provide this unidirectional flow. This blue unit is a custom-made reservoir connected by 1-inch tubing, which is required to transport this the medium rapidly enough. And this is just our heater-cooler unit, which doubles as the stand for this reservoir. The pump itself is controlled by a Raspberry Pi computer with a touch screen, which is visible up here. And it runs a Python program, which at least the company can modify to whatever you need to investigate. Now, this is a schematic view on the pump mechanism along the shaft, as basically seen from above. What happens is that the stepper motor presses this plate against the back plate and squeezes this piece of tubing. Owing to the check valve, you get a unidirectional flow when the tube is squeezed. This is an image from the left side. You look at the pressure plate with the tubing right here, and this is an image from the right side, or from the bottom side. You look at the narrow edge of this pressure plate, and this is this 1-inch tubing which is pressed here. Now we asked the company to implement controls like the DP3 pumps, so you can adjust the frequency or the heart rate. You can adjust the stroke volume, which is essentially the angle that this pressure plate travels. At a low angle, you have a low flow. At a high angle, there's a larger flow, obviously. Then the systolic percentage, which is basically the time spent in the closed position or spent outside of the open position, to be precise. And we also asked them to implement parameter which allows us to change the speed at which this pressure plate closes. So this is different from this setting, and it's a little counterintuitive, as a low percentage means that this plate travels real fast. So this requires a little bit thinking, but I'll try to explain this as good as possible. Now, the perfusion model that we used in this study has been presented here last year, and it's also published. I'll keep this very brief. We have a silicone model of a human aorta based on a wax cast made from a real human aorta. And the wall thickness has been fiddled until you reach the compliance of a real human aorta. We have lots of probes, like pressure probes out here, and flow meters to control what happens in these outgoing vessels, and to monitor the pressure, SHE, and all the data that you'll see afterwards. The experimental procedures were as follows. We started the circuit with the roller pump because the flow is mostly non-pulsatile and easier to deal with. We adjusted the peripheral resistance according to literature values. So you have the flow rates and pressure that you would expect in a human body. And we repeated these adjustments independently 6 times, resulting in 6 slightly different patients. And each of these patients received the entire set of experiments, which we did, of course, with the TriLab pump attached as a MIECT circuit. And we ran 2-factor experiments. That is, we varied the stroke volume in all cases. And one of these 3 parameters, heart rate, systolic percentage, systolic acceleration percentage, while we kept the remaining parameters at reasonable defaults. There were 2 lines of experiments. The first one used this Quadrox I oxygenator, which is an oxygenator that you would use in during cardiac surgery. It has a heat exchanger, so we ran these experiments at 37 degrees. The second set of experiments used an ILA membrane ventilator, which is a low resistance ventilator, usually run by the patient's own circulation as a lung assist device. You will see later on why we use that, but the main thing is it has a lower resistance. Downside is it does not have heat exchangers, so we had to run these experiments at room temperature. But we checked with this setup, 37 degrees versus room temperature. It does have an effect, but the magnitude is small. So these experiments are still valid. So we'll first focus on this setup using the Quadrox oxygenator. And this is quite busy, so I'll have to walk you through that. We have the stroke volume on the abscissa down here. And color-coded is the heart rate, the first parameter that we optimized. So it's fairly simple. The larger the stroke volume, the more flow, the more pressure you get. Pulse pressure increases up to a point, up to about 50% of stroke volume, and then levels out. The SHE, which is the most interesting parameter for us, it decreases with increasing stroke volume and thus with increasing flow rate. But if you look at the magnitudes, we obtain up to 50% of SHE, which is really a lot. On the other hand, the flow rate is fairly limited. We just got beyond 2.5 liters per minute, which is not sufficient for regular cardiac surgery. Also, the pressure was limited to, well, not quite 30 millimeters of mercury. So this still requires some work. Now, in order to make this more palatable, we'll focus on the data obtained with a stroke volume of 80%, which was the highest that we measured with this setup. Which is also the highest flow rate, which is most relevant for cardiac surgery. So if we now plot the flow and other parameters against the heart rate, you'll see that increasing the heart rate increases the flow, increases the pressure. It decreases the pulse pressure, which indicates that with increasing heart rate, the filling of the pump is not the best, and also the SHE decreases with the heart rate. So for the SHE, using a low heart rate would be best. Now the second parameter is the systolic percentage. We again look only at the data of the highest flow rate. Systolic percentage increases the flow, it increases the pressure. Pulse pressure is not affected until about halfway, and then it decreases. SHE again decreases with the systolic percentage. So you would like to have a short systole in order to obtain the best surplus hemodynamic energy. Now, the last parameter of this series is the systolic acceleration percentage. We have a similar pattern. Increasing the systolic acceleration percentage decreases flow, but as said previously, you have to think inverse. A low percentage indicates a rapid closing of this pressor plate. That is, if you move the pressor plate very rapidly, you get high flow, you get high pressure. Pulse pressure is barely affected here, but the SHE is very low if you move rapidly, which is for us quite surprising, but there seems to be appropriate physics behind that. Okay, now I would like to move to the other set of experiments. As you had seen, the flow and pressure data were not convincing for us, and we suspected that the pump was not quite designed to pump against a regular oxygenator, which we had used in the previous series. Now in this series, we used a low resistance membrane ventilator. So basically we reduced the flow resistance of the entire system. We also use this data presentation focusing at the highest flow rate. We were able to run this circulation with membrane ventilator at a stroke volume of 90%. And you can see from these data, the flow rate was just shy of 4 liters per minute, the maximum with the highest heart rate. So definitely the pump did have a problem with the resistance. The pressure actually increased to levels which are more convenient for surgery, somewhere between 50 and 60% at decent heart rates. Pulse pressure was fairly high, reaching up to 60 millimeters of mercury at the lowest heart rate. And the SHE was lower at with this membrane ventilator compared to the other type, but still around 10% at the most at the worst settings of the heart rate in this set of experiments. Now the second parameter, systolic percentage, again only showing the data at the highest flow rate. Increasing the systolic percentage as seen previously increases the flow rate, increases mean arterial pressure. It changes the pulse pressure, it decreases it with increasing systolic percentage. And the SHE again is reduced from like 28% to 10% if you increase the systolic percentage. Systolic acceleration percentage again has a similar shape as seen with the Quadrox oxygenator. Flow is highest at a rapid movement, which corresponds to this low setting, so the slow percentage. Mean arterial pressure is also fairly high at the lowest settings. Pulse pressure is decreasing with increasing percentages. Again, it's highest when the plate moves rapidly. But as we can see here, the surplus hemodynamic energy is also lowest when the plate moves rapidly. Now, I'd like to present the flow profiles of this pump. As said previously, the design was optimized for pulsatile flow. The flow patterns and pressure patterns do not look physiologic. They look more or less like sine waves. Maximum flow with the Quadrox oxygenator is around 4 liters per minute. Maximum pressure about 40 millimeters of mercury. If we use the low resistance membrane ventilator, the shape of the flow curves changes slightly. It's no longer symmetric, although the pressure curve is more or less still like a sine wave. And in the bottom two images, we compared the flow and pressure at two different settings of this fairly conspicuous systolic acceleration percentage setting. Again, 80 means plate moving slowly, 20 means plate moving rapidly. And as you can see, the setting can be used to increase the flow during during systole, and it increases the pressure more or less over the entire cycle, but most prominently again at the start of systole. Although it does not help to increase the SHE. Now to sum up these results, might that triphasic pump actually help to improve pulsatile perfusion? The pros, the pump is freely programmable, so you could do whatever you want with that. And the SHE is exceptionally high. I repeated that so you don't miss that point. On the con side, the flow and pressure patterns are slightly different from what we would like to achieve. And we could achieve the flow and pressure values that you would expect during surgery only with a low resistance or oxygenator. We have several indications that the pump tube filling is suboptimal at high flows and high frequencies. So this might be a good point to optimize this pump. And again, if you wish to have a different flow and pressure profile, you might be able to program that pump to obtain that within the limitations of the mechanics. Now, the conclusion is we think that the principle of this pump has quite some potential, but it clearly needs some more work. I would like to thank our MD student, Elena Weber, who ran most of these experiments for her thesis. And I would also like to thank our perfusionists, Günther Albrecht, Fatma Aydoktu, for their help in conducting these experiments and to set up the circuits. Thank you for listening.
Good. Well, thanks very much, Dr. Honecker. I wonder, this is an experimental setup. Have you actually used blood in your circuit? I may have missed that, or is this a physiologic solution, or what is your actual liquid in the circuit? I'm sorry, I didn't point that out. It was mentioned in one of the these images. We used a dextrane solution, 12% dextrane solution, which has the viscosity of blood. So we avoided the mess of using real blood, but the viscosity was kind of natural. Okay, yeah, thanks. I just wonder, one of the issues that has plagued pulsatility in the past has been a degree of hemolysis, and that may be one of the things you wanted to look at with your various pressure waveforms. Yeah, I was also wondering, especially when you have like two check valves in the system and this squeezing of the silicone tubing. We did not check that ourselves because we did not use blood as mentioned previously. I will ask the manufacturer if he has any data about that. We're also very interested to see that. Yeah, very good. Well, thank you very much, Dr. Honecker. You might just want to unshare your screen. I will do. Thank you. There you go. So we just wanted to say thank you very much for your input. Again, I have a particular interest in pulsatile perfusion, so I look forward to further results from your group. So thanks very much. Thank you for having us. Yeah. So I'd like to carry on now. And I believe we're having a complete virtual presentation. I don't think Dr. Gunajan is actually available, but this is, again, a very dear friend, one of the founding members of the society, Dr. Serdar Gunajan from Ankara City Hospital in Ankara, Turkey, who I believe is currently at the ISMICS conference. Again, spreading the word about MIECT, but I think he's got a presentation for us that will be made available imminently.
Hello, this is Dr. Gunajan from Turkey. First of all, I would like to take this opportunity to thank the organization of this excellent meeting. Mainly John Merkin and Sir Sarik, my dear friends. And it's my great pleasure to be here with the MIECTS friends. And today I'm going to talk about our recent experiences of using MIECT systems under minimally invasive CABG surgery. So let me share my screen and start. Yes. So, when we're talking about the patient-centered care, it's becoming more and more popular and more important, as you know, because now we're trying to build a new type of healthcare that can compete with the cardiological interventions and anybody else. So, because patients are asking more. So in this sense, we need some much more multidisciplinary team approach to incorporate these new techniques and to use as much technology as we can to improve patient clinical outcome and just compete with the ongoing intervention procedures. These are even cited in our recent guidelines, like the coronary artery revascularization guideline that really caused a lot of trouble and discussions. But in this guideline, also this patient-centered approach was outlined. So as you can imagine, according to the latest databases, of course, the number of cardiac surgeries in every set, like CABG, valve, or whatever, is really decreasing down as a number because interventional procedures are becoming more and more popular. And indeed, when the numbers are decreasing, the patient's risks are increasing, but all of them means nothing because the mortality and morbidity rates are also decreasing. So we need to create some more successful results, including this very high risk patients. And that brings us to use all novel technologies. So that really produced the idea of minimally invasive cardiac surgery, and it's becoming more and more popular in every type of cardiac surgery. So when we talk about valves, let's say 4 or 5 years ago, and then it's becoming more and more popular to use now in every type of cardiac surgery. And when we talk about invasive cardiac surgery, you need to use some more additional technologies because this really needs some different approaches for percutaneous cannulation, canulations, venous returns, vacuum assist, and anything else. And so, and the span of this minimally invasive surgery is becoming more and more to cover every type of cardiac surgery. So we used to start with the minimally invasive cardiac surgery, let's say 6-7 years ago, with valve surgery, mainly the aortic valve surgery. So we increased our experience for mitral valve surgery, of course, ASD, VSD, in high-risk patients, and now we come to an end to use this type of surgery in even CABG surgery up to 3 vessels. And of course, they are very much comfortable to do and redo cardiac surgery after some level of experience, reoperations, and of course, if possible, in a hybrid way. So as you can see here, we can also just play video. It's a very small incision. You just have to harvest within the small incision. But of course, the aim is not the aesthetics, but also the clinical outcome, because you can extubate patients earlier, and you can just mobilize patients earlier, and you can achieve very good results. Of course, there are many different studies comparing minimally invasive CABG versus PCI, and then even minimally invasive surgery is much better in target vessel revascularization and this prevention of the major adverse coronary events. So of course, when we talk about minimally invasive cardiac coronary artery bypass surgery, this should preferably include the endoscopic saphenous vein harvesting. We're talking about the patient-centered care, so this just goes up to 1 level more. And of course, now we come to the point. When we are talking about minimally invasive techniques, so why don't we use minimally invasive techniques in cardiopulmonary bypass? So we also started using cardiopulmonary bypass in conventional CABG surgery, mainly as a start, let's say 10, maybe 12 years ago. And then we go up to aortic valve surgery and some combined surgery. And now in minimally invasive cardiac surgery, but of course, there are many tips and tricks that we should be much more careful. So this is our minimally invasive design. So also we just come out to the ERAS recovery after cardiac surgery program in our clinic, targeting patient-centered approach and minimally invasive techniques, certain techniques, and minimally invasive cardiopulmonary bypass is one of the main factors, one of the main recommendations. Of course, monitorization is also important because when you're dealing with minimal incisions and minimally invasive cardiopulmonary bypass, you need to monitor much more parameters, just take care of much more parameters. So we have tried to use as much technology as we can to control, to target patient-centered results. And of course, these are all the procedures we are just gathering in. From the ERAX approach, we are doing rehabilitation before surgery. So as much as we can do for mid-cap, if they're suitable, endoscopic vein harvesting using MiECT, of course, with the ICU stay is much lower. And of course, nutrition is another part of the ERAX. And of course, the overall hospital stay decreases to have a target of patient optimized outcome. So let's see, I just document our experiences in the recent patients. So I am working in Ankara City Hospital, is one of the largest hospitals in Turkey. We are doing any type of surgery, including transplantation. And this is the program we are dealing with. So as I've told you, I've started minimally invasive techniques with the valve surgery 6-7 years ago, starting with the aortic valve surgery, with RAT incisions, and then minimally endoscopic surgery for mitral valve and so on. And then we published those results because we also incorporated MiECT systems in minimally invasive valve surgery, and we published our results just much better. It's going beyond aesthetics because we also bring positive advantages of, let's say, less hemodilution, less inflammatory response, less atrial fibrillation incidents to minimally invasive surgical techniques. So potentiate the results. So in this case, after we have some kind of experience with the minimally invasive CABG surgery, of course, our next aim was to incorporate MiECT technique. So of course, we did only a small number of patients, but of course, this might give an idea, and this might give the suitability of these results that you can use this technique, combine these two techniques in even CABG surgery. So we have only 15 patients in each group to compare until now. So the first group is MIECT plus MiECT. So, and the second group is on MiECT only, and the third group is a conventional group with no MiECT and no invasive techniques. So we are mainly doing like 1 vessel, 2 vessel disease, rarely 2-3 cases of 3 vessel disease. So we are increasing our experience. And the duration of cross-clamp time is about 50 minutes, 45-50 minutes. Respiratory support time is much less in the MiECT group. We cannot achieve significant, statistically significant results because the patient population is unfortunately too low right now. But it's a promising difference, at least we can say. So the hemorrhage, post-operative hemorrhage is, of course, less because of the less hemodilution by MiECT, and of course, less surgical trauma by minimally invasive techniques. So, but patients with no transfusion is important because it's even significantly different in this small number of patients. So in MiECT group, only 13 patients out of 15 received no transfusion. And even in the MiECT group, 10 out of 15, and the conventional group, 7 out of 15. And we are really obeying very strict rules of patient management in our current practice in any type of patient groups, including the control group. So ICU stay is of course much less in this modified group, I can say, and hospital stay is much less in this modified group, which we were expecting with. So this is the MiECT features of our group. So it's mainly design of our previous works with the kind of diagram of the setup, let's say, we created by our US colleagues years ago. It's called the clinical system. So we can incorporate this clinical system in any type of extracorporeal circuit. So the idea is to very close to the table, you can use the integrated arterial filter oxygenators, and of course coating systems, and every circuit is very much short as possible. And so of course we incorporate nurse and cell saver system with this system also. And of course just we collect all the data, and right now within this limited experience I can say it's going a very much promising result. So from the MiECT side of view, let's just try to wrap up now. We can say the MiECT is a complete physiologically based strategy, not just a circuit. We always underline this because the aim is not to make the circuit shorter. The aim is to make the most friendly design of cardiopulmonary bypass system to the patient. So the idea is to expand the indications of MiECT as much as possible to hopefully use in any type of cardiac surgery. So this is also a challenging setup for minimally invasive CABG surgery. So incorporating MiECT into this system is again, I believe it's an improvement. And of course, its main object, as I've told you before, we are really obeying all the rules of ERACS and patient management. So it's one of the major factors in this sense. How about MIECT? So as I've documented on the meta-analysis before, so there are equivalent early and late clinical outcomes. Of course, for minimally invasive advantages like less pain, less transfusion, wound infection, and when you incorporate with the MiECT system, that hemodilution and transfusion becomes much less. Of course, with the minimal surgical trauma, minimal inflammatory response, so you have shorter length of stay in the ICU or in the hospital. And of course, not the primary aim, but as a secondary, so better, much better cosmetics. And if you're dealing with high-risk patients, especially reoperations or some kind of complicated surgery, so it's becoming more and more easier after gaining some kind of experience in the reoperations. And so when you're dealing from the economical side of view, when you incorporate this, when you have better clinical outcomes, of course, in the overall sense, you can have some economic benefit and cost-sensitive outcomes. But later. So this is a very, let's say, pioneering study, not a study, it's just a wrap up of our initial experience. And of course, there's no clear scientific evidence right now, but the results are promising for our future and encouraging us to go on this combination. So of course, the strong interest will be in higher risk patients in the follow-up, because as I've told you, the aim is to reach patient optimization, patient-centered approach. So this means to do your best for the patient. So this is a very good mixture, very good combination. And of course, this is a very small group of patients. So we need new, large, randomized control trials that will clarify the interview aspect of this type of surgery. So this is a bright combination. This is a strong combination for us. And this is a formula that we believe in too much. And hopefully we will have a much more better results when we increase the patient population in the near future. Thank you very much for your interest, and hopefully we will present later much more clear differences, much more clear results at the end. Thank you.
As you could tell, that was a pre-recorded presentation, and Serdar is not currently available. As I say, he's at the ISMICS meeting, but we're very pleased he was able to share that with us. So I guess we'll carry on with the next talk, which is by Dr. Charles Kutrara from the Trillium Health Center in Mississauga. And he'll be talking about the importance of evaluating graft patency during mid-cab procedures. Once again, I think a very important step to ensure that we're doing what we actually think we're doing when we're putting these grafts on the heart.
Everybody can hear me fine? Oh, 1 minute time. Okay. So thank you very much, everybody. So I'm Dr. Charles Kutrara. I'm one of the heart surgeons from the Trillium Health Partners in Mississauga, Ontario, just up the road. And I've been asked to talk about evaluating graft patency during mid-cap procedures. Basically, this is a talk about intraoperative assessment of graft patency in general. And full disclosure, I received honoraria from Medtronic for this work. So what drives minimally invasive cardiac surgery and mid-cab in general? Well, obviously there's competition with endovascular technologies, whether it be TAVR or whether it be angioplasty. Patients obviously with significant comorbidities have been shown to do a little bit better with minimally invasive approaches. There are economic pressures to shorten hospital stays, ICU stays, et cetera. And last but not least, patient preferences. So I just want to go through some of the definitions. So most people, when they're talking about mid-cab, are talking about a small thoracotomy approach with a Lima graft to the LAD. And we've been doing those since around 1994. Thoracab was something that we bandied around for a while, which was multi-vessel coronary bypass through a small anterior thoracotomy. I think mixed cabbage is the more useful term these days. And then, of course, there's TCAB, which is totally endoscopic, direct coronary bypass, which is, of course, mostly robotically driven. Can be done without, but it's mostly robotically driven. So my experience is mostly with the first two procedures. This is obviously a Medtronic slide, but it shows our approach through the oftentimes the fourth intercostal space, a little bit more laterally than the traditional mid-cab approach, using various stabilizers, et cetera, and a direct coronary anastomosis. This is the size of the incision. It usually ends up being 10 to 15 centimeters, a bit in contrast to the last talk, which looked a little bit more aggressive than that. And obviously, there's a lot of equipment in the field, and this is facilitated basically using beating heart techniques. We do not use circulatory support for these operations by and large. They're obviously in very selected patients, usually with good vessels, et cetera. But if you're going to do this operation and you're going to compete with angioplasty, or the cardiologist sent you a patient because the patient didn't want angioplasty or was not a candidate for angioplasty because of the osteal nature of the LAD disease or something, or distal left main or something of that nature, then you better be sure that you're going to do it right and the patient's going to get a good long-term outcome. So this surgery is not for everybody, but it could be for everybody. And beating heart surgery is not for everybody, but it could be for everybody. So this is the Trillium Health Partners in Mississauga, Ontario, and you can see there's a little arrow pointing to a small suburb of Mississauga that's often called Toronto. So why do we want to use transit time flow measurement or other evaluations of graft patency? Well, number one is my area of expertise, which is quality assurance. Number two, I always stress to assess newer conduits and grafting strategies, whether you're going to T grafting strategies, whether you're going to all your grafts off the lima, whether or not you're going to use novel connectors, whatever. Assessing new techniques of cabbage if you're switching from on pump to off pump, if you're switching from traditional sternotomy to minimally invasive, you want to verify your quality. And in the end, I'll show you that it actually can reduce morbidity and mortality. And then the emerging aspect of whether or not this is medical legally necessary. So in the early 2000s at Trillium Health Partners, we started a program to switch from on-pump coronary bypass to off-pump coronary bypass. And in the course of 1 year, we went from 80% on-pump to about 70% plus off-pump, which was really quite an aggressive progression. And now 4 of the 5 surgeons do about 95% of their surgery of coronary surgery without using cardiopulmonary bypass. So we thought it was very important to have quality assurance, certainly during this. And now 16,000 patients later, we're still using transit time flow measurement routinely in coronary bypass surgeries of any type. So this is now the MiECT device. We started out with the traditional MediStim device and then went to the VeriQ device. This is the latest iteration, which has both transit time flow measurement, ultrasound capabilities to locate or interrogate anastomosis, and epiaortic scanning as well. So this is perfusion-driven technology at our center. All of the work with this machine and these waveforms are all performed by the perfusion group. So once again, this is the technology, transit time flow measurement. I'll go over that for the students in the room, what TTFM is. We generate these kind of curves that you'll see so many of them in the next couple of minutes. You'll wish you hadn't. And then there are the available probes. Okay, so the transit time flow principle, for anybody who doesn't know, picture a river, let's say a fast flowing river, and 2 kayakers, one at one side of the river and one at the other side of the river, and they're both going to diagonally traverse the river to get to the other side. So one of them will obviously be coming with the current, and we'll get to the other side of the river probably faster, right? Because it'll be partially with the current. The other one going diagonally against the current will take longer to get to the other side. So that difference, the transit time difference, is proportional to the flow. So if you take in the width of the river and the depth of the river, you know exactly what the volume of water that flowed through the river over that period of time. That's the transit time principle. Just think of the kayakers forever. Cross-sectional diameter is deemed as not being important, but it actually is pretty important. So, if you want to know the exact volume of flow, you have to have the direct cross section. And I'll talk about probe size later. So these are the first iteration of available probes. They've changed a lot since, but I just want to show. So the rule of thumb is you want to match the probe to the conduit. If you have a probe that's too small, it will pinch the conduit, change the flow that you'll measure. If you use a probe that's too big, then you will not get proper acoustic coupling and you won't get good readings. So it's for IMAs, it's a 2 or 3 millimeter probe. Now, thank God, we have a 1.5 millimeter probe for those little tiny IMAs. And bigger conduits is usually a 4 or 5 millimeter probe. But just using one size fits all doesn't work out. So this is now we have 1.5 millimeter probes. They're designed so that you can manipulate them better through a small incision and get good coupling. So each one you can use about 50 times. I don't know what our finances are, but I think it works out to about $50 a probe per time. So if you use 2 probes, about $100 per case. Maybe more than that now. I haven't looked at the numbers. So obviously you'll generate a curve like this. You'll get sick of seeing these, but so a well-functioning Lima curve here, we have mostly diastolic flow. Most of the flow is in one direction. We generate these other readings that I'll go through. And it's coupled to an ECG. So we know what phase of the cardiac cycle the flow is occurring in. Here you have an example of a saphenous vein graft of the circumflex, where the numbers are all messed up and the flow looks bad, which led to revision of the graft. And then you get something that looks much more acceptable. So flow curve interpretation, we always talk about this triangle of graft patency. So we're looking at several parameters. So there's the diastolic filling, which is basically the percentage of flow that occurs through the graft during diastole, which we know is the phase of the cardiac cycle where most of the cardiac perfusion takes place, coronary perfusion. Sorry. There's the, did it again. There's the mean flow value, which we talked about earlier. That's what the transit time flow measurement will give you, which is in millimeters per minute. And then there's something called the pulsatility index, which basically is the maximum flow minus the minimum flow over the mean flow. Okay. And that all does mean something. But you have to look at all 3 of those to make a proper interpretation of what to do with this data. Okay, so here's an old example that I have of a Lima to the LAD. This is a case of mine. I'm a perfect surgeon. I don't make mistakes, right? So I get to the end of my case. Patient's depending on his Lima to the LAD for prognostic value, probably the most important graft by and large. We all agree on that. And basically there's almost no flow in it. And there's certainly, there's certainly no flow happening in diastole where 80% of the flow is supposed to take place. So we go back and redid this graft. And although the mean flow is not impressive, now doing it again. Now we see that the majority of the flow is in diastole, coupled with the ECG. Pulsatile index is an acceptable level, and we thought this was reasonable. This is another example of a REMA graft that was put to an intermediate marginal, probably through the transverse sinus in my practice. And we've got basically no flow here at all. And then we revise it. And, we've got a very nice diastolic flow curve and all the numbers look good. So, for surgeons who believe that they're infallible, we are fallible. We do make mistakes. There are intangible things that occur during coronary surgery. And by being open to redoing grafts and having data to tell you when to redo grafts, you can improve your patient outcomes. All right, so it's simple and reproducible. It's less dependent on exact probe size, but you want to have the probe size in the ballpark. It gives you a clear depiction of the diastolic flow curve. It can detect competitive flow, and that's been shown again and again as being something that can really affect arterial grafts more than venous grafts. You create a permanent chart for your medical record. It's widely available. It's fast. It takes about 15 minutes at the end of the case. It's relatively low cost. I usually tell people to do your transit time flow measurements before you give the protamine, whether you've done it on or off pump. It's been shown that the flow differences are not much different before and after protamine. But I think that people, after they've given the protamine and things like that, and they're starting to wind down their case, they're much less open to the possibility of redoing an anastomosis. Oh, I have to reheparinize. Oh, I don't want to do that, blah, blah, blah. So I usually tell people to do it before they give the protamine. All right, so this is other technology you can get with the MiECT. So ultrasound of vessels or an anastomosis. So if you have a bad graft by TTFM, you're not sure what's wrong with it. You're not sure if it's the proximal. You're not sure if it's the distal. You can't find an artery. Then you can break out this technology, and you know, it can show you where your anastomotic difficulty is. You know, right here, this looks much better. I don't have a lot of experience with this technology, and I find it's mostly utilized on the anterior surface of the heart. Getting it around to the posterior surface of the heart, to posterolateral wall, inferior wall is a little more difficult. So the limitations of transit time flow measurement, it only identifies flow limiting lesions. So there maybe is a type B kind of anastomosis going on, but you don't know it because the flow and all the other parameters are normal. So it doesn't take away the fact that you could have a slightly abnormal coronary anastomosis and still have good numbers. It doesn't tell you if it's competitive flow, well, it kind of does. It doesn't tell you if it's poor runoff in the coronary that you've just grafted. It doesn't tell you if it's the proximal or the distal. And I can tell you a number of times I've redone the distal and things didn't get any better. And then I go and redo the proximal and things don't go any better. And then you don't know what to do after that. Most accurate analysis requires proximal snares. So if you can have a perfectly good anastomosis, perfectly good flow, but have a complete occlusion at the toe, and all of your flow is going retrograde into the proximal vessel. So if you put a proximal snare on it and the flow goes down to zero, you know you have a problem at the toe of the anastomosis. We don't do that all the time, only if you kind of have a suspicion, but probably should. So the further limitations is there's no clearly defined criteria for revision. Okay, you've got to know what parameters you're looking for, right? I think we've made some inroads over the past 10 years to really give some clearly defined criteria, but sometimes you get a graft that just doesn't fit the criteria, but you want to redo it anyway. So this is what I talk about a lot of times, is the observed versus expected. So in order to know what is expected, you have to have used this technology for a period of time, or you have to have listened to this talk and know what to expect out of grafts. So if you see something that doesn't fit the expected in your observed, then it's probably time to reevaluate the graft or probably redo the graft. And getting access to posterior grafts in the appropriate location. So these probes are supposed to be placed on the graft within a centimeter or two of the distal anastomosis to get the proper flow curve and the proper reading. Well, that's not always as logistically possible, and you end up being more near the aorta, more near the proximal anastomosis, and you have to take that into account. Mean graft flow, we see tends to increase with the severity of the proximal stenosis. People put FFR there. I'm not really keen on FFR, guided coronary bypass. I've been fooled more times than I would like to say, but certainly the more severe proximal anastomosis is percentage-wise, and the more resistance to flow at that level, the better mean flow you're going to get. An increase in flow is associated with better patency and decreased mortality. That is clear, and I'll show you that. And the mean graft flow is multifactorial. And you have to have a good anastomosis. Depends on the size and the type of conduit. Depends on the outflow of the vascular bed you're dealing with, and the condition of the distal vascular bed. And I'll show you some data to support that. The relationship between mean graft flow and long-term graft patency remains questionable, but I think there is some data suggesting that the better the mean flow, the better the flow through your graft early, the better the late results. All right, so clinical evidence. So let's look at some of the basically case control studies that have been done. There's very few randomized trials. This group with Giuseppe D'Ancona took 409 patients. 376 of the patients did not need any graft revisions, but 8% or 33 patients did require a revision of at least one graft. And they found basically what you expect. So 6 had thrombosis of the anastomosis, 8 had stenosis of the heel or toe of the anastomosis. This is the one that really always surprises you, an intimal flap or a little dissection in the native vessel that can totally occlude your anastomosis. And I think that earlier case I showed you with the ligament of the LAD, that was the case. They found some dissections of the IMA, kinking of the graft, a flap under the proximal anastomosis, coronary stenosis distal of the graft, or this is the one that vexes me the most when you don't find anything, right? So they used flow curves. They used a pulsatile index of less than 5, and mean flow were all evaluated together. As I said, it's that triad, right? So this is a very interesting study that was done in Japan. And what they did was they did cardiac CT scans, and they took coronary targets for bypass surgery and calculated the volume of myocardium that was supplied by that vessel. Okay, so we all know that the bigger the vessel that supplies the larger volume of myocardium, you're going to get better flow, right? If you're doing a little diagonal that supplies a volume of myocardium the size of a nickel, and it's a 1 millimeter vessel, you're not going to get good flow. But they actually put this to the scientific test. So mean graft flow, significantly positive correlation with the perfused left ventricular mass volume. So the more myocardium you're dealing with, the more mean flow you got. The percentage of stenosis, so the tighter the stenosis, the better the flow, and the diameter of the coronary artery. So tiny little coronary arteries got less mean flow than big coronary arteries, right? The pulsatile index had a negative correlation with the percentage of stenosis and the diameter of the coronary artery. Abnormal graft flows where the PI was greater than 5 or the mean graft flow was later than 20 mils per minute. This is becoming a fairly acceptable cutoff in an arterial graft, or less than 40 mils per minute in a vein graft. I would probably factor that down to 30. Was found in 9 grafts. And the internal diameter of the coronary artery distal to the anastomosis site was significantly smaller in the abnormal grafts, and the vessels were kind of worse. So I'll just show you this in. So you have to know what you're looking for, right? So left-sided arterial grafts have, more flow than by and large than right-sided grafts. Left-sided vein grafts tend to have more flow than right-sided vein grafts. If you look at the pulsatile index, left-sided arterial grafts tend to have lower, so that cutoff of 5 for left-sided arterial grafts may be a bit aggressive. Maybe it should be 4 or 3. Right-sided vein grafts tend to have a higher PI on average, so a cutoff of 5 is probably not reasonable. You might be able to push that up to 6 or 7.5. And left-sided vein grafts tend to kind of be in the middle. Diastolic fraction, right here, you got to look at right-sided vein grafts. Diastolic fraction between 50 and 65%, that's fine, right? The right-sided ventricular myocardium, the right ventricular myocardium has less wall tension and systole, so you're going to get more flow in systole. So less diastolic flow. But in an arterial graft to the left side, you want to see that number over 70. Left-sided vein grafts about in the middle. So, they actually did the data to support. So if they looked at the percentage, the difference between abnormal and normal grafts, as you can see, they do kind of all overlap. So there is a little bit of judgment. There's no absolute numbers you can use. You do have to interpret the data. But obviously, bigger coronaries had more flow, lower calcium score had, better graft performance, etc. So this is the GRIP trial. This was done at the Sunnybrook by my colleague Steve Singh. And this is one of the only randomized trials using both SPY technology and TTFM versus control. And basically they looked at long-term angiographic outcome. And basically in long-term angiographic patency at 1 year, they really found no difference. So they said transit-time flow measurements by technology is not worthwhile. Unfortunately, a large proportion of the, well, a proportion of the control group actually had TTFM. And their revision rate, graph revision rate was very low. I think it was 1.5%. So, you know, I look at this study and I say, you know, it was a decent attempt, but I think they needed to be more strict as to, they had good criteria for graph revision, but people didn't use it. It was up to surgeon discretion. So I think the main difference with that is those two things. So that brings in Terry Keyser and David Taggart, who have been working together. Terry's in Calgary and David Taggart, of course, is at Oxford. And they've been working very closely together to look at TTFM and evaluating coronaries and coronary bypass surgery as quality. And so this is Terry's first study. So it's a little bit different than most people's practice, and that 95% of the grafts were arterial. And she did a few more sequential grafts than many people, but it was a single surgeon experience, 336 patients. She revised 20 grafts in 14 patients. So that's not a high revision rate, but it's reasonable. It's never going to be, you know, over 5 or 8%. It's the highest number I've ever seen in any study. She revised some of the grafts because of abnormal wall motion abnormality on TE, which some people say should use in every case. One patient had VFib. 8 out of 14, all 3 of the transit time flow measurement parameters were abnormal. And in 3 out of the 14, she had suspicions based on the transit time flow measurement. But basically what she showed was that patients, the 59 patients had pulsatile index and at least one graft of over 5, the major adverse cardiac events was higher, statistically significant, and the mortality was higher. So she said the postoperative major adverse cardiac events, including death, are significantly higher if your PI is more than 5. So she set the PI of 5 as a good guide for a cutoff for revision of grafts to avoid these kind of complications. So Bauer and Associates did a case-controlled study. The controls were all before TTFM, and then the cases were all after TTFM. They had fairly strict criteria for revision, graft flow less than 12 millimeters per minute, high pulsatile index, and insufficient diastolic flow pattern. And basically they showed that patients who had TTFM and they revised based on these parameters had less postoperative AFib, less perioperative MI, less VFib postop, about equivalent overall mortality. And obviously they revised 3.2% of the grafts versus almost none of the grafts in the prior group. So he thought that routine use of this actually did decrease perioperative morbidity, but not necessarily mortality. The group from Turkey, again, using a DF of less than 50 or PI of greater than 5, suggested poor flow and suggested revision based on those. Mean flow was evaluated together with the other 2 parameters, and I think that's very reasonable. So 100 patients in each group, obviously 9 revised grafts in the TTFM group, none in the control group. Overall morbidity was significantly less in the TTFM group. Postoperative myocardial infarction was significantly less, and they did show a lesser mortality. Although 100 patients in each group was not impressive, it's still a reasonable jumping off point. So he thought that intraoperative flow detected graft dysfunction, improved surgical results, and CABG should be supported with intraoperative flow measurements. So same group, decreased mortality, perioperative myocardial infarction, and requirement for intra-aortic balloon pump. So now they're saying that the use of this device improves outcome of heart surgery And they were suggesting that it be put in the guidelines in Europe. I'll just zip by that one. Okay, so 2010 European Society of Cardiology and Cardiothoracic Surgery guidelines, graft flow measurement related to graft type, vessel size, degree of stenosis, quality of anastomosis, and outflow area is useful at the end of surgery. It's a lot of parameters to look at. Flow less than 20 mils per minute and pulsatile index greater than 5 predict technically inadequate grafts, mandating graft revision before leaving the operating theater. I agree with that to a certain extent. Sometimes you're grafting the ungraftable, and you're not going to make it any better with revision. So sometimes you have to take what you're given. But in all other things being equal, if you find those parameters, then revision is probably worthwhile. So Terry did a retrospective review of all the studies, and there was 7,930 grafts with a revision rate of about 2.71%. Not impressive, but it fits with the literature. 53% of the revisions were due to anastomotic problems, 23% due to conduit problems, all fixable, 18% due to competitive flow. That's, where do you go from there? 32%, 3.2% only were due to native artery problems, and one from subclavian stenosis. And some of them, no problem was found. All right. So I told you you're going to see a whole bunch of waveforms. So this is the ideal waveform for a lima to the LED, whether it's done through a limited access approach or through a median sternotomy. If you have, reasonable acoustic coupling here, we've got 49 mils per minute, which is well above 20. We've got a pulsatile index, which is well below 3, and a diastolic fraction, which is greater than 70%. And this is the flow curve that you should see all the time, where the blue is in diastole and the pink is in systole. And this is using a 2 millimeter probe, which is fairly standard for a lima to the LED. Another lima to the LED, still acceptable. Not as great, but still acceptable. So 31 mils per minute, certainly over the 20 mil per minute cutoff. PI 1.1, diastolic fraction 66%. Most of the blue is happening in diastole. Good acoustic coupling, reasonable acoustic coupling, and a 2 millimeter probe. A radial artery, which is used in this case as an aortocoronary graft. Again, a 2 millimeter probe, so probably not the biggest radial, probably 2.5 millimeters. 29 mils per minute, PI is low, diastolic fraction is in keeping with the left-sided graft, so that's all good. Rima to the diagonal, so somewhat lesser flow. You're grafting a diagonal, but still acceptable. PI is still good, and diastolic fraction is still good. So any arterial graft to a left-sided target, that's kind of what you should see. Here we're using a 3 millimeter probe, so it's probably a pretty good size Rima. So this is a pretty noisy saphenous vein waveform, but you see that the mean flow is great. Pulsatile index is less than 5. Like I said, you might want to push that to 6 or 6.5. And the diastolic fraction is good. Anything over 50 is good. 61 is good to the PIV. And the likelihood is, given this systolic spike that you see, is that this measurement was done closer to the proximal anastomosis, where you could get access to the vessel. If you move the probe down to the inferior wall within maybe 2 centimeters of the distal, this spike in systole would go away, and this PI would come down to about 2.5. So anytime I see a high PI and a spike in systole, I say, okay, let's move the probe downstream and see if we can smooth this out. The closer you are to the proximal anastomosis off the aorta, the more of a systolic spike you get. So here's a lima to the LAD, and we see this backward flow percentage. And if the backward flow percentage here, it's a call, but if it's more than 4%, you've got some degree of competitive flow. So flow's coming down the IMA in diastole, and in systole, it's actually going backwards to the IMA, coming down the native coronary. And that can really only happen with competitive flow. So that's always a warning sign, but then, you know, you throw, and you've got a low mean flow as well, right? So you throw a snare on the LED, which maybe you should do every time. And lo and behold, that negative deflection, the backward flow percentage goes away. You have a totally upright curve with a diastolic fraction of 72%, PI of 1.5, and a decent flow. So the question is here, what do? You know, you go, oh, well, you know, let's see what happens. You're not going to ligate the proximal LAD, right? Because if the graph goes down, then you're in trouble. But at least you know, right? At least you know. It could be sometimes if you put a diagonal, saphenous vein graph on a diagonal, you'll get competitive flow from that. And so you clamp the diagonal and not even snare, and you get the same result, which says to you should probably shouldn't have put a saphenous vein graph to that diagonal. All right, so this is a little bit of my data. So this was early, 133 patients, 2.8 grafts per patient, and 95% of them we tested. 73% were done off pump, and 300 of the 315 and 374 grafts, or 84% of the grafts were measured. So this was in that early curve of converting from on to off pump, but this is basically tells you what you should be seeing. So any Lima to any LAD, the mean is about 29.6, pulsatile index 2.8. Any radial to OM, again, we're seeing around 30, pulsatile index 2.2. A radial to the RCA, it's the same. Maybe higher PI, slightly higher PI. REMA to any target, usually less because it's a non-LED target. Pulsatile index still low. Saphenous vein graft to the RCA tends to have higher flow. And pulsatile index can be higher, but the mean is usually low. And a saphenous vein graft to the OM, kind of the same. So if you look at, you know, Lima's grafted to diffusely diseased LADs or not diffusely diseased LADs, early graft flow doesn't seem to make a difference. Okay, so this is, although it was shown in the Japanese study to have an impact on mean graft flow, in our experience, it really didn't show much. So a 2 millimeter Lima to a 2 millimeter LAD, you should see, you know, the traditional kind of flow, 30 and 29. A LAD that's 2 millimeters done on pump, you see a fractionally higher flow than off pump, and we see this again and again. It's not because you did it off pump, it's because the post clamp myocardium is hyperemic, and you tend to get more flow through arterial grafts when you come off pump on a fully done on pump clamped aorta. And we've seen that again and again. The other thing we've seen that I didn't show here is if in the rare event you have to take an off pump patient or any patient back to the OR, did it again, back to the OR for bleeding or something of that nature, 4 or 5 hours post-op, and you re-interrogate this mean flow almost always doubles over the first 4 or 5 hours post-op. Okay, almost always. So a Lima to any LAD, here we go again. A REMA to the LAD, REMAs are slightly bigger, slightly more flow on average. A REMA to any left-sided vessel, slightly lesser flow than the LAD, okay? So conduit issues versus target issues, right? So this all speaks to what I was saying earlier. You have to know what to expect to understand what you're observing and whether or not you're observing is wrong, right? What you're observing is wrong. A Lima to any LAD, again, we saw that. A Lima, 2 millimeter Lima to a 2 millimeter LAD, slightly more. When the LAD is smaller, slightly less flow on average. When the stenosis in the LAD is at least 70% or more, slightly more flow. So this is all reiterating what I said earlier about flow dynamics. So I'm not going to go through all this, but I would recommend this is a review article done by David Taggart's fellow at Oxford. And she basically looks at all the studies, right? And basically whether or not there was an association with transit time, flow and graft patency in the long term. And there's a number of different things that these studies show. One is that, for every incremental increase in mean graft flow, you get better graft patency in the long term. So although mean graft flow isn't the be all and end all, it is definitely helpful. Anyway, I would refer to this. So cutoffs for assessing graft patency with transit time flow according to vessel type. So everybody basically keeps coming back to this for the IMA, mean flow greater than 20, PI less than 3, this percent backward flow less than 3% or 4%, right? So these have all been found to be risk. So I don't mind this greater than 15 mils per minute, less than 3% backflow. So, there's no current agreement on what should be your value for revision. And it is kind of a personal thing. Sometimes it's a field thing. So the recommendations in the European guidelines is that routine operative measurement should be considered. Class 2A data, level B evidence. Minimization of aortic manipulation is recommended. That's good for the mid-cap people. And epi-aortic ultrasound probably should be used as well. I think that's starting to invade our collective consciousness. And overall, 2 to 4% of grafts that you do are going to require revision. I think if you're revising less than 2% of grafts, you're probably not being aggressive enough, or you don't understand the technology and what it's showing you, because nobody's perfect. Okay, so this is a case. So that's video number 1. So this is just a random case that I did this week. It was a multi-vessel coronary bypass done through a median sternotomy off pump. So we've completed all the grafting and we're getting to this phase now of doing the transit time flow measurements. This patient, by the way, had a in-stent stenosis in an LAD that was proven to be hemodynamically significant by IFR. Okay. Can we play that first video? Yeah. You've got it on another screen there. Yeah, so you don't have it there. You've loaded it on another playlist, if you remember. That's not where it is. Yeah. So go to your media player that you had loaded this on. Instead of that, please. There you go. All right, so this is, as I've showed, this is a 2mm probe. This is a semi-skeletonized lima to the LAD. Okay, we don't have any sound there, that's fine. So you see, we've got good acoustic coupling. Okay, you can stop that video and thanks. We'll go back to the presentation, please. So this was the result. So the mean flow was 27 mils per minute. The DF was actually 72%. This is the other curve above. It was 72% and the PI was 22. But this bothered me was that we had this backward flow percentage So we decided to snare it. So can we go to the next video, please? There you go. Yep, thanks. No, not that one. That's not the one. Just go to the third one there. You're out of order now. So just go to the second to last one. Second to last one. There you go. Thank you. All right, so this is very easy to do. You want to rule out competitive flow. So we're just putting the silastic snare back on. We're putting it probably in a similar position to where it was before, not exactly. And then we'll, excuse my head moving. So, so we've got the vessel fairly tightly snared. And we go back with our flow probe again in a similar place. Make sure we get good acoustic coupling. I'm pulling on it, make sure I get good occlusion proximally. You can go around and around if you want. Okay, that's fine. So let's stop that video and go back to the presentation. Okay. So this is the lemur of the LED with a snare on it, and nothing really changed, right? So, you know, where that negative, that deflection is coming from, I'm not really sure. So this is a radial which was done to the right coronary just before the crux, and so now it's linking up okay. So the drawbacks with arteriographs is you have to skeletonize a little bit to get the flow probe on, and this leaves you open. If you're not very careful, you can damage your arterial conduit. So this has to be done with a great deal of care, which I am trying to exhibit here. And here, once it's skeletonized a little bit, we can again put the 2mm probe on. So a little bit of acoustic gel there just to make sure that we get good coupling. And so there's our reading. So I won't show you any more of that. I won't bore you with any more video because we're short for time. But there's a saphenous vein graft to the diagonal and a saphenous vein graft to the second obtuse marginal. So I really didn't have to redo anything here, and I, wouldn't expect to. But in the, 2 to 4% chance that I had made a significant technical error, we could have detected that. So once again, this is adding ultrasound. If you're concerned about a problem or you want further quality assurance, you can add the ultrasound. So the three things that we can see with the MiECT, obviously, I've talked most about transit time flow measurement. I don't know much about the ultrasound, but it can be useful. And epiaortic scanning is something that's entering our collective consciousness as a way to reduce perioperative neurologic morbidity. All right, so why TTFM? I said this before. So quality assurance, absolutely. Assessing newer conduits or graft strategies, we did that. Assessing new techniques of CABG, we certainly do that all the time. Reduce morbidity and mortality. I think that there's emerging evidence that that's the case, and the specter of medical legal. All right, so thank you very much. Any burning questions? Burning questions?
No.
All right.
Well, thank you very much,
Yep.
Charles. I think your comments, regarding the necessity to do this in all the procedures is really the take-home message. And certainly in our own institution, more and more, a couple of our guys are doing it, whether they're on pump, off pump, or whatever their approach is. So, and I fully support the epiaortic scanning. That's a real message. Good. Thank you very much. I think now we're going to go back to our international faculty, and I believe we have Dr. Gabor Erdoes from the University Hospital in Bern, Switzerland, who will be talking to us on the use of MiECT to warm hypothermic avalanche patients. And of course, those of us in Canada here have warmed a few frozen patients, not from avalanches, but as a consequence of our climate.
Thank you, John. Can you hear me? Can you hear me?
Very good.
Thank you, John. So thank you for this nice introduction. My name is Gabriel Edosch. I'm from the University Hospital in Bern, Switzerland. I'm a cardiac anesthetist, and I would like to share my experiences in the use of minimal invasive extracorporeal technologies to warm hypothermic avalanche victims. I have only few disclosures, mostly as a speaker at different congresses or related to activities in societies. Last year, more than 300 people were caught in avalanches in the Swiss Alps, and 32 of them died. If avalanche victims survived burial and can be rescued, they are often hypothermic with core body temperatures below 32 degrees. In this situation, the usual resuscitation measures, such as defibrillation in the context of advanced cardiac life support, are not effective or helpful. The current guidelines from the European Resuscitation Council, therefore, recommend not spending much time at the scene, but transporting these patients to a hospital with extracorporeal life support facilities to stabilize the circulation and to rewarm effectively. A score that has been implemented in recent years is the HOPE score. It includes details on age, sex, hypothermia with or without asphyxia, CPR duration, serum potassium level, and actual temperature. Based on this data, HOPE provides a prediction of the survival probability in hypothermic cardiac arrest patients undergoing extracorporeal life support rewarming. The survival probabilities range from 0 to 100% chance of survival to hospital discharge, a cutoff of 10% to decide which hypothermic patients in cardiac arrest would benefit or not from ECLS rewarming was evaluated in an external study. The negative predictive value of a HOPE probability of less than 10% was 97%, and the area under the curve was 0.8, which suggests excellent discrimination. When facing 100 patients, 27 ECLS unsuccessful rewarming could be avoided without losing a single additional patient using the HOPE score rather than potassium alone, which was used as a rewarming criterion in the past. Patients who experience additional accidental hypothermia and are under cardiopulmonary resuscitation should be transported to an ECLS center and rewarmed. It is recommended to perform the rewarming with ECMO, in contrast to the past when CPB was recommended. In this small review of active rewarming strategies in recent years, you can see different technologies involving also hemofiltration and hemodialysis, and also venous ECMO, which is no longer recommended because of the lack of cardiac support. In this overview, you also see VA ECMO and CPB, which still stand side by side as equally valid alternatives. This review also mentions some complications such as hemorrhage, thrombosis, and hemodialysis and hemolysis. Active internal rewarming is, however, not only for hypothermia class 4, which means no vital signs and circulatory arrest, but also for hypothermia class 3, when temperature cannot be improved with external or minimal invasive methods. In the case of life-threatening arrhythmia, when hypotension exists, in case of respiratory failure or refractory acidosis, or in risk of cardiac arrest. Almost 40 years ago, in 1982, CPB was the first therapy option to rewarm patients. It offered an efficient assisted circulation and had also the advantage of rapidity and of rewarming the core before increasing metabolic requirements. ECMO has become more preferred over CPP in recent years, and you can see the reasons on the left side. It is the rapid availability of VA ECMO, the possibility for a lower heparinization, and the possibility to prolong the cardiopulmonary support after rewarming. So what role plays MIECT in this context? We have investigated the role of MIECT in a small study. And in this study, we could include 17 patients. You see more of the majority of the patients were male and with a median age of 42 and a median core temperature of 25, a serum potassium level of 4.3, and a median duration of cardiopulmonary resuscitation of 90 minutes. The majority of these patients were asystolic or had ventricular fibrillation. We have had a very short door-to-perfusion time of only 28 minutes, and we could establish in most of the cases peripheral vascular access via the femoral route. The MIECT duration was a little bit more than 160 minutes, and 6 patients had to be switched to ECMO after rewarming due to the pathology. They could not be weaned off MIECT and left the OR via intensive care unit. You see also the hope score in most of the patients were very good, so a high probability of survival. The length of hospital stay was 11 days, and 14 of patients could be discharged at home. So if one patient is coming to our hospital, we have a dedicated hypothermia algorithm, and you see this algorithm on the right side. The title is ECLS for accidental hypothermic circulatory arrest. Most of the patients have a very low temperature, core temperature lower than 28 degrees, and they are, as I already mentioned, under cardiopulmonary resuscitation. The core team is meeting in the OR, and the team includes the cardiac surgeon, the cardiac anesthetist, and also a consultant from the emergency department. In case of a good prediction for survival based on the HOPE score, and if a major trauma is excluded, MIECT is connected in the OR. For this purpose, the cannulas are inserted percutaneously in the femoral vessels, and the position of this cannula is checked by TEE. And also with T, we are keen to check other pathologies as well. So we are looking after blood in pleural, pericardial, or peritoneal space. We are assessing the LV function, the presence of aortic regurg or PFO, and also we are looking after atheromatosis in the aorta. And with these procedures, we are reforming the patient. If the patient reaches 30 degrees or a little bit above, we can defibrillate the patients. We start on continuous positive pressure ventilation, and in most of the cases, we are then going for a CT scan. As I mentioned before, if the patient cannot be weaned, we from MiECT, we are switching to VA ECMO, to cardio help system, and transferring the patient to the ICU. So we have also some logistics established in our OR. They are available 24 hours and 7 days per week. And this includes an anesthesia workplace, defibrillator, pacer, vascular ultrasound, TE, EFAST, point of care, laboratory tests, wires, introducers, and also an ECLS percutaneous cannulation set. And last but not least, we have a dedicated MiECT system, which is a pre-connected mobile system with small priming volume and requiring also a low anticoagulation level. The system includes also a heat exchanger, PA venting option, and also the possibility for volume transfusion via venous large volume access. If we compare both systems, so you see on the right side, the VA ECMO circuit, and on the right side, the MiECT type 2 circuit, I can say that the conventional ECMO circuit is a more simple circuit, including a centrifugal pump and an oxygenator. In contrast, the MiECT circuit has a stopcock system for drug injection, a soft infusion bag, hard shell suction reservoir, and a venous bubble trap to eliminate air. Why MiECT for hypothermic arrest? So as I mentioned before, most of the patients are without any lines, and many patients has had also a trauma before. So we need a high flow access for fluids, drugs, and transfusion. The patients are volume depleted, which is pre-existing or due to the trauma. They have a prolonged immersion time, and also a vasodilation due to the rewarming. If you use the MiECT circuit, you have the benefit to preventing suck down and low flow events, air embolism, and also air purging problems. The heparin coating is a good thing as well, but you know, ECMO has the same possibility. What is really beneficial that there is no violation of circuit certification. So we are using the MiECT circuit, which is coming directly from the company. There is no modification on the original MiECT circuit. When we compare again both systems, you see with MiECT, you have the possibility for a volume therapy via circuit, the possibility for drug administration. We can upgrade the system with rigid suction reservoir. The priming volume is more or less the same. Both systems are heparin coated. With MiECT system, We can use also volatiles to anesthetize the patient. This is not possible with the ECMO system. And what is very important, I think, these are the cost. And as you can see, with MiECT, a quarter of costs exist in comparison to the ECMO system. Our study concluded that the use of MiECT for ECPR and active rewarming from severe hypothermia is a feasible alternative to ECLS with ECMO with comparable survival rates. And at the end of my presentation, I would like to share a case. This was a 59-year-old patient, avalanche victim. On the left side, you see the heart, which is not ejecting. The heart is ejecting due to cardiopulmonary resuscitation. So this is a TE picture before connecting the MiECT circuit. On the right side, you see the venous cannula in position in the right atrium. The patient is still not ejecting. The movements are coming from the cardiopulmonary resuscitation. And this picture shows a heart which is ejecting already. The patient has been weaned or is just before weaning from the MiECT circuit. And this is very interesting. At the end of the surgery, we are always looking after aortic dissection, so after membranes in the ascending aorta, and we could not see any membrane dead using transesophageal echo. But we went with this patient to the CT scan, and as you see there, the radiologist on call found signs for an acute type A dissection in the ascending aorta. But I can tell you there were no dissection in this patient, and this was only an artifact which was caused by two oppositely directed flows in the aorta, suggesting aortic dissection. So this is our patient. Now he is 65, and this was his fourth summer. He suffered from multiple trauma, out of hospital cardiac arrest, very low temperature, asystole, a CPR duration of 100 minutes, MiECT more than 400 minutes, and 4 surgeries. And as you see, the patient is been doing well and survived, of course, and continues to be an active alpinist. Thank you very much for your attendance. Are there any questions?
Yeah, thanks very much, Gabor. Perhaps release your screen top so we can see you and see if there's any questions from the audience. There we go. Well, I just have to make a comment. We haven't actually treated any avalanche victims, but when I was in Winnipeg, where we have -30, we certainly treated a few hypothermic patients that got pulled out of a snowbank somewhere. So I can certainly empathize, and I think it just demonstrates again the utility of these mini bypass circuits. And I think again, in these patients in extremis, I think the aspects of the MiECT that we've been talking about, the reduction in inflammatory responses and preservation of hematocrit, all of these aspects. And I think you get better preservation of the microcirculation. And certainly when we're trying to rewarm patients where their microcirculation is severely disruptive, this is probably another beneficial aspect with this type of circuitry. How many patients in total have you done now?
I don't, it was something between 25 or 30.
Really? Yeah.
Yeah, it's not, the numbers are not very high because many patients could not be transferred to the hospital. So we
Right.
we had a good selection of these patients, as I showed also with the HOPE score. So
Yeah.
there were a very good survival probability.
Yeah. Yeah.
And therefore are good results.
Cyril has a question. Use the mic, Cyril.
Nice presentation, Gabor. Do you have a, what's your anticoagulation protocol?
Ask that. Yeah.
Yeah, is it as lower anticoagulation with the MiECT circuit?
Very good question. Thank you very much, Cyril. In these avalanche patients, we don't use any anticoagulation at the beginning because the circuit is heparin coated, and these victims have already a coagulopathy due to hypothermia. So during rewarming, during the early stage of rewarming, we not use any anticoagulation, but during rewarming, we are measuring ACT, of course. And if the ACT is coming to rather lower values, then we administer, of course, heparin. We have also the possibility to measure the heparin level directly with the HepCon device from Medtronic. So we can very good guide the anticoagulation during extracorporeal circulation.
What do you consider low? What do you consider low ACT levels?
Low
Like
ACT.
at what point do you actually start giving heparin? 200, 400, 480?
250. Yeah.
250?
In this range.
Yeah, so that was exactly. I mean, I think these are really important questions, as you say, because they have an underlying coagulopathy, which you can exacerbate with massive anticoagulation. So, do you find most of the patients are coming in with an elevated ACT? Is that when you first get them into the OR? Yeah.
Yes.
And as long as the ACT is over 200, then as you say, you'll just monitor it closely and await. Which again is so critically important because the microcirculation is all shut down, particularly in the extremities. And you have a lot of. It's a very, very dynamic situation.
Yeah.
Well, thank you very
John.
much.
Exactly.
Yeah. Yeah. And any other questions or comments from the audience? Yeah, well, Gabor, thank you so much for joining us. And
thank you very much.
Appreciate that.
Have a nice time.
Yeah, lovely. Do we know if Adrian, there he is. Yeah, so following on with this discussion about the critical importance of anticoagulation, we're now very fortunate to have Adrian Bauer. Again, another a good friend and one of the founders of the MiECTS Society, the chief of perfusion at the Mediclinic Heart Center in Koswig, Germany. Adrian will be talking about low ACT protocols and anticoagulation during MiECT. So welcome, Adrian. Thank you.
Yeah, thank you. Thank you for the invitation and the possibility to present our data there. I hope you have a good time with your congress. It's good to be on the screen. It's better to be there, of course, but unfortunately I can't come. So yeah, thank you. So we come directly from the talk before anticoagulation strategies with MiECT systems to my topic using that reduced anticoagulation strategy. I will start my presentation. You should see it and it should work. Yes. Okay. Yeah, this study was part of a bigger project, and it was financed by a third-party fund and granted by my clinic and different companies, Mackay Pulmonary and Haemonetics and Medela give us materials and also money to do that studies. The anticoagulation strategy is from Bullet et al. And I was 3 years old, and I can tell you this is 47 years ago, and that's a long time that this strategy was investigated and is still used in our daily routine, even with a conventional cardiopulmonary bypass. And but the situation 50 years ago was quite different, of course. There was different hot lung machines. The colleagues used bubble oxygenators with large surfaces, uncoated surfaces, and so on. And a lot of things changed, but what doesn't change is the strategy to use or to perform anticoagulation with cardiopulmonary bypass. And the most currently recommendation is now 4 years old, and it's still the recommendation to have ACT above 480 seconds and a therapeutic level of 400 seconds. And that's with a conventional bypass, of course, probably necessary. We can discuss that, but the problem is you use an open venous reservoir, the blood comes in contact with air, with all the filters, with all the deformers and so on, and the risk of coagulation, of embolization with a conventional bypass is higher in comparison to MiECT system. Why? We don't have the venous reservoir. It's a closed system. It's more like an ECMO system. And we hear that a MiECT system could replace an ECMO system, what we see in the last talk. And the same is almost the same as also during cardiac surgery. The blood comes not in contact with air. You have no stagnating blood areas, and you have the completely coated systems. And therefore, we decide to investigate or to looking for that reduced strategy with a target value of 300 seconds. For best clinical practice, we do that with 300 seconds and not 250. What's perhaps also possible, I will show that later on. But what's the reality in using the MiECT systems 5 years ago? Perhaps something has changed meanwhile, but what you can see is that not all the colleagues or not all the MiECT users or have reduced anticoagulation strategies, and that not all of them see reduced bleeding amounts. Which can be one of the positive effects of a MiECT system, and perhaps it's together with the anticoagulation strategy. So that low-level anticoagulation intensity means that we going for a 300-second ACT value, and we hope to see reduced post-operative blood loss. That's the hypothesis, and we are looking at in our studies. So we are doing around 500 MiECT procedures per year, and then we randomize the patients, of course, in a low-dose group and in a full-dose group, and then we measured our study endpoints. The trial has 2 phases. One, and the first phase was a safety and efficiency phase, and the part 2 was just the efficiency phase. So that means in the first part, we looked deeper in the coagulation process. We measured endogenous thrombine potential, also D-dimer in the patients, and we looked very, very carefully for any kind of complications regarding that study protocol. In part 2, we, in addition, looked also to the coagulation and the bleeding amounts, of course. So the inclusion criteria was quite simple. Adult patients in a normal range of weight and isolated CABG surgery, because we don't want to have that much confounders in that study. Of course, exclusion criteria was any coagulation disorders and the intake of dual platelet inhibitors and such things just before surgery, of course, also was an exclusion criteria for that patients. Our MiECT system is something between type 2 and 3. There's always an outland venous reservoir here. It's always outland. The blood comes here to a bubble stop, then to the venous bubble trap, the centrifugal pump, oxygenator back to the patient. And we are using that venous reservoir as cell-saver reservoir. And only in the case of emergency, we open that reservoir then, and then we have a open cardiopulmonary bypass system. One thing is very, very important, and I want to emphasize that extra. In the Calafiore system, in the blood cardioplegia system, and also in the coronary system, the blood will stay for at least 15, 20 minutes, sometimes more than 20 minutes. And therefore we decide to add extra heparin into the syringe, potassium syringe of the Calafiore system, and then to have a full anticoagulation in the cardioplegia system, and also, of course, in the coronary system. So if you want to use that approach with the reduced strategy, you should also consider that way to do it. We also use the hemostasis management system from Medtronic, and the most of you perhaps know that system. It's very easy. You have a cartridge with different amounts of heparin in it, and then you can exactly calculate the ECT, what you will reach. And we are doing that for both groups. And it works very good. Even the heparin dose response is a very good test. And you can use that really good to get your target ECT. The endpoint in safety was endogenous thrombine potential. That means you look very deep into the calculation, and then you will see whether you have problems with thrombine formation or not. The other secondary endpoints in safety was that we use a TAC system for the calculation or for measuring the whole calculation process, and compare that between both groups. And of course, we looked at all our systems. We are looking for thrombolyzation and embolization in that systems. This is not a picture from our clinic. It's just from the internet to show how it can see. We don't see that. So the primary endpoint bleeding, we decide to use an electronic device for a drainage device in order to have a good study situation. And after that study, we changed the whole clinic to that system, which is a very nice thing to see how the bleeding history is in that patients, and it works well. The other primary endpoint then in bleeding was the excessive bleeding or massive postoperative bleeding. And we distinguished between a surgically caused postoperative bleeding and a medically caused postoperative bleeding, because of course, is there a surgically caused bleeding? It's not because of the anticoagulation strategy. Yeah, this was our study protocol and our when we take our samples. Now we're coming to the results. The patient groups was absolutely comparable. There was no difference between. We used, and we expect to use, much less heparin, but also much less protamine in the patients, which probably also one of the reasons for the results, what you're seeing later on. And the ACTs was, of course, lower. Not that low because you have to imagine, and you know that, of course, that you always above the value. That means the 300 strategy is above 300, and the anesthetists have to tend, even in the when we start a study, have the tendency to give a little bit more heparin to be more safe. So, and that's the reason why we start with 400 ACT in the low dose group and over 600 in the full dose. But all the points was different between the groups, and yeah, then we looked for thrombi information, and it works perfectly in both groups. No difference. There is no thrombi information if you use a 300 or a 450-second strategy. The tag shows us that the red one is the low dose group. That clot formation comes earlier, faster, and also stronger. You see that the maximum amplitude here is in the red on the red side. That's the reduced group, is always stronger, and directly after the heart lung machine also significantly stronger. So that means that not only it's feasible, it seems to be better to use a reduced strategy. I mentioned it before, we have no thrombolyzation in our systems, also no thromboembolic complications in our group behind or after the cardiac surgery in the postoperative phase. And we could say, if you use a MiECT system with a hemostasis management system, it's safe, and therefore we decided to going forward with our study. And you see also Bull already said in his old paper, this 300 seconds, it's enough, and you don't see thrombolyzation in that patients. So, but what's about bleeding? Do we have also reduced bleeding amounts? And indeed, we find that we have reduced bleeding amounts during the whole period for the patients, and over the whole time, the bleeding was reduced by more than 400 milliliters if you use a reduced anticoagulation strategy. Yeah, also excessive bleeding was reduced, but in that case not significantly. Excessive bleeding was defined with more than 1% of body weight, and yeah, there was no difference, but it was reduced with the reduced anticoagulation strategy. Also, the ENR was interestingly lower in the reduced group compared to the conventional group, so that at the end we can say the safety is there. And also other studies shows that not all of them prospective randomized trials, but also big trials like the Offram trial here. It was a big cohort study with more than 6,000 patients, and they don't see any serious complications. So we can say that this approach is safe and you can go forward with it. We couldn't confirm all the findings from that studies, but we see that we have a reduced bleeding amount, which is good for our patients, of course. And therefore also the transfusion rates are lower, but not significantly. Reduced bleeding amounts, feasible, good hemostasis. So we was happy with that approach, and we could do some things better in our study. As always, when you are ready, then you think about, oh, I could do that, I could do that. But we are happy with the results, and we changed our behavior. We changed to the reduced strategy, and that means that we performed more than 1,200 patients now with that low dose heparin strategy, and don't see any complications because of that. So we are happy with that. Yeah, we need more research. If some of you interested in that approach, go forward, contact us. Perhaps we can change a little bit our experiences also with that study. You're always welcome also to visit our clinic, to come to see the MiECT procedures in our clinic. You're always welcome. And yeah, thank you very much. I hope you have a good time in at your congress, and thank you for listening to me.
Very nice. Thank you so much.
So I stopped. Yeah.
There you go.
Okay.
Excellent presentation, Adrian.
Thank you.
Thank you very much for that. Let's have a few questions. So one is the ACT measurement device. So obviously you use the HepCon system to measure your ACTs,
yes.
Correct?
Yes.
I think, I mean, one thing that a study that we did, well, about a couple of years ago now, we compared a bunch of ACT machines with all ACT machines out there. And you know that the ACT is not necessarily equal, depending on what ACT machine you use. So I kind of feel like we have to be very careful when we're saying, you know, what ACT what our target ACT is, especially without mentioning what the actual device is. So, you know, do you use other devices? And if so, do you change your protocol, like to measure ACTs?
First of all, I would absolutely agree what you say. Even if you use a citrate or choline ACT measurement, of course. And we have a different device, yes, it's also for Medtronic, regulatory ACT machine. That's the reason why we a little bit above that what's possible. If you come closer to the I would say the red zone, then the risk is higher, and therefore we are performing it with 300. It's also possible with 250, perhaps also with 220. But then you come in an area what could be dangerous for your patients, and that's the reason why we're doing it with 300, and then we have a little bit left on security.
Right. Also, were they just cardiopulmonary, just CABG patients, or also open heart patients?
We are also doing open heart patients, aortic valve, also with that strategy. Yeah.
Oh, okay. So it doesn't matter the air blood interface doesn't seem to matter.
Yes, we are using a pulmonary vent, and then it's closed, and the other blood goes to the cell saver, so it's still with no blood air contact within the cardiopulmonary bypass.
Okay. And one last question: you used heparin. Did you use heparin bonded circuits?
Yes.
And would you use other circuits besides heparin bonded circuits, other like a phospholipid coating or a
polymer coating like that? Yeah. Yeah. We also use a polymer coating with that's the diffusio coating and the X coating from using by Terumo and Livanova. And but we have the same anticoagulation strategy because for that time, 1 or 2 hours on cardiopulmonary bypass, we don't expect additional risk, and we don't see it, to be honest.
So it doesn't matter what kind of polymer.
Yes. Yes.
As long as you use something.
Yes, absolutely. I don't want to do that strategy with an open system without any coding. That's not good. But if you have a MiECT system with a heparin bounded surface coating or a polymer coating, it will work.
Excellent. Thanks very much.
You're welcome.
Adrian, again, thank you very much for a very provocative presentation, I think. Perhaps part of the intent of this whole session is to be a little bit provocative. I would suggest that, in fact, one of the main benefits of the low heparin, lower ACT approach is a reduction in protamine. I think that one of the real issues, and perhaps this would be a good topic for debate at some point, I think one of the clinical realities is people give far too little heparin and far too much protamine for the amount of heparin that's been given. And everybody seems to neglect the fact that the heparin is actually being actively metabolized. And I can actually point to a whole number of benefits, particularly when it relates to microgaseous emboli, and actually even platelet activation associated with full heparin anticoagulation. And we can debate what is full. Interesting, I don't think people have discriminated enough between the beneficial effects of that type of a low heparin approach from what I believe is the underlying primary mechanism, which is the reduction in protamine that's usually associated. So again, just to be provocative, we get people thinking about this. Again, thank you very much. Very interesting presentation. And I really liked your last slide. I was trying to make one like that, showing the hotel. So good for you. Maybe next time we can actually get you on site here. But thanks so very much, Adrian. That was very good.
Yeah, thank you. Bye-bye.
Now, do we have Pascal? Okay, so it's coming? Yeah, okay. Yeah, so we'll be having I think a video presentation from, unfortunately, Pascal Stanier was unable to join us at the last minute, I think clinical exigencies. So I think we have his video pending. Anybody want to enter the protamine debate about? There we go. Sound would probably help.
Good morning. Good morning to you all. I hope you enjoyed the videos. It shows you just how we started perfusion at Jessa Hospital. No, just kidding. I would like to show you the video because from the early beginnings, from the beginning of the artificial circulation up until now, so over time, I think things evolved and get sometimes more complex. So I thought it was an interesting video to show you from where we come from and where we can go to. And also interesting by the fact that they were amazed if you clamp the pulmonary artery that there was no bleeding. Also, that is of importance if you look at certain types of MiECT, but I will clarify that during this presentation. So I come from Jessa Hospital. It's a small private hospital in Belgium. We have approximately around 9 beds and we do 700 cardiac cases a year, which is not a lot. But the thing is that we do over 99% minimally invasive cardiac procedures. So our journey started in 2013 when Dr. Aladdin Yilmaz joined the team. And he was performing MIECTS and he asked also for a minimal invasive extracorporeal circulation. So we sat down, we set up a program, and from there on, we started using MiECT and MIECT, so the combination. What's in the name? Just to mention that there were a lot of names called back at the day for, let's say, mini bypass system, perfusion, minimized perfusion circuit, and so on. For this presentation, I will use the minimal invasive extracorporeal circulation. So the most appropriate name for it's MiECT. So just to start. We all know the drawbacks of the standard cardiopulmonary bypass. We talk about large foreign surface, high volume cardioplegia, roller pump, cardiotomy suction, hemodilution. Those particular things are not, let's say, new to us. So also in 2013, we had 2 options. Or we would leave the detrimental effects behind and go for off pump, or we try to minimize the drawbacks and we went for a minimal invasive extracorporeal circulation. To be honest, when our surgeon joined us in 2013, he was performing everything, let's say, anterior wall Lima LED off pump. Then he experienced some difficulties. And what we did then is he asked for us, as mentioned also before, we sat together and said, what can we do so that also the patient with those difficulties could have a minimal invasive approach. So if we look at what were the surgical difficulties, or still are in some patients, sometimes you experience some small calcified vessels. You have an intramural LED, difficult landing zones. We also insufflate carbon dioxide, so you create an iatrogenic pneumothorax, which in particular patients with low ejection fraction, you can create hemodynamic instability. Also, patients with severe lung disease who can't bear single lung ventilation, you have morbid obesity patients and target vessels more than just a single LED. So what we achieve of the objective is full revascularization. So we wanted a technique, surgical, that worked for every patient, single vessel, multi-vessel. So for every patient, the same technique. So that's why we switched from off-pump surgery, which also I think if you're in the learning curve of minimal invasive cardiac surgery, is sometimes difficult to operate on a beating heart and then also through a small incision. We went from off pump to empty beating. So no touch aorta and empty beating for a single vessel LED. If we talk about multi-vessel LED, we arrest the heart with the same circuit. So this is where we started from. It was let's say our first MiECT on an SAP console, on an ECMO console. Why was that? Because we also had some Russian friends, and also the perfusion sometimes is also the anesthesiologist there. So they search for a system that they can put on head side, which was small and compact. So we, let's say, introduced our first MiECT. The thing is, at the time, the VART, the venous removal device, it's quite important safety, because also, and we all know that if we talk about MiECT, about mini systems, everybody has safety concerns concerns regarding air. So with the FART it was perfectly possible. It's now off market, I think. So, but you can do this with, let's say, with the Stockholm machine with an air purge control. You can do it with a purge flow on a quantum console. So it's perfectly possible with other heart-lung machines. So what is minimal invasive extracorporeal circulation? There is no reservoir in your AV. Your patient is your reservoir. It's a closed system. You have no deformers, no blood-air contact, and a low priming volume. There was a very important article that was published in Perfusion in 2015 by Professor Anastasiadis van der Hyperclinics. He described the 4 types of MiECT, and I will also go through those 4 types and which procedure we attach to in our center. So an overview, type 1, 2, 3, and 4. So type 1, we all know centrifugal pump, oxygenator, this is an ECMO. We only use this on ICU, so ECMO consoles on intensive care. If you want to go from type 1 to type 2, you have air handling. You have 2 air handling components. You have a drip chamber here. You have a venous bubble trap. So if you add those 2 components to a type 1, you have a type 2. Type 2 we use for our CABG cases. So you saw CABG, endoscopic coronary artery bypass grafting. It's a closed heart. You have air handling components, so you can safe run your pump. For the procedure, first you start by taking out the right mammary artery, as you saw. It's all been harvested thoracoscopically. At the right, you see then at the back you see the right mammary artery. In front, you see the left. You use the right mammary artery as a free graft onto the lima. So you create the Y anastomosis. You see the 3 working ports, the small incision, thoracotomy. With a soft tissue retractor, you prepare the mammary artery. This is the anastomosis for the Y graft or T graft for multivessel disease. In this case, we arrest the heart. So we give a cardiplegia, a mixed blood and crystalloid. There are 3 parts of blood, 1 part of crystalloid. Single shot, you dilute the patient with around 300 mL of crystalloid cardiplegia. And you have up to 2 hours. Also very important, because if you use, let's say, custodial, high volume, difficult to handle with the MiECT system, our own cardiplegia works perfectly, used for CABG, for valve, for every case. This is the end result. So as I mentioned, the objective is fully revascularization. So MiECT type 2 with the 2 components, as mentioned here, drip chamber, you can connect an aortic root vent on that. You have all the safety issues here. If it pops out, it will be detected by the bubble here, and it will trigger the clamp. So you put the clamp here, and there is no air in your circulation, so you can maintain circulation. This is then with endo-CABG. So type 2, closed heart, air handling components with CABG, perfectly doable. You see here, this is then the full picture of a type 2. Everything is connected to the cell saver, also for separate suction we use it, and for the airing. Then if you add a volume bag to type 2, you have a type 3. So volume management. I also mentioned then the patient is your reservoir, but sometimes it's insufficient. You can lower the legs, but if it's insufficient, you need a backup mechanism. So that we use the bag for. So you can store blood there if necessary, but it's mainly you can deal with the lowering the limbs. It's normally sufficient, but if not, you have a backup mechanism. So if you add the bag to type 2, you have a type 3. And a type 3 we use in our AVR setting. So aortic valve replacement by partial sternotomy. So as mentioned in the CABG case, you can connect your aortic root venting here, but also your pulmonary artery venting. So it goes through a drip chamber straight into your venous line. So aortic valve replacement in our center, we started doing partial sternotomy. You see here a 4 centimeter incision. We make an J sternotomy until the 3rd intercostal space. Voila, you see there's not a lot of room. So you only see the aorta. This is fem-fem cannulation. If the aorta allows it, it's not too calcified. Otherwise, you can switch to auxiliary or something else. This is the venous going in. This is a biomedicus multi-stage we use every time. And then also for the arterial one, we use the biomedicus. See a small cut down, air-free connection, and go on bypass. We do also retrograde autologous priming. This is very important. What you saw was a pulmonary artery venting. This is a normal cardioplegia catheter. You can put the clamp. We deliver cardioplegia the same as in our cabbage cases. 3 parts of blood, 1 part of crystalloid, single shot up to 2 hours. So getting the diseased valve out, like here, measuring the valve. So you see everything very small. You only see the aorta. So also monitoring on your bypass machine and so on is very important. The remains also important during this type of surgery. You can perform with stented valves, sutureless valves. Basically, doesn't matter. Technique stays the same. We use, of the surgeon use also an automated knotting device to win some time. You're under arrest. And if everything goes well, you will close the aorta double layer. We give a hot shot before releasing the clamp on ECG guidance, and this is then the end result. So aortic valve replacement by a partial sternotomy, you can use type 3. This is the placement of a pulmonary artery vent, which is very important because otherwise now you use a type 3, there is no air. If you cannulate a pulmonary artery, you can connect it straight to your venous line. We put a flow meter on it, so we know how much comes from, and we know if the patient's empty or not. This is the pediatric cannula of 12 French. The distal tip, you can slide it over the guide, and if it's in place, it drains perfectly. So with a type 3 and a pulmonary artery vent, they match, no problem for that. So same type 3, everything. This is your end handling components. This is your volume management. That makes type 3 for an aortic valve replacement by partial sternotomy. Then if we go further to a type 4 or an alternative hybrid system, it's different. Now we combine, let's say, conventional and mini MiECT systems. The thing is, we switched from a pulmonary artery vent, which you saw in the previous video with the aortic valve replacement, to a pulmonary vein vent. So pulmonary vein vent, we run through a pump, so you get air and blood towards the system. So what we did then is, if you put a clamp here, so you exclude the reservoir. You just go to your venous bubble trap, centrifugal pump, oxygenator, and back. So it's quite a mini system. Only the vent runs through a pump, and this is a dual chamber, so you can separate the front and the back. So at the back, you have activated blood from the stump or so on. You can store it there. In front, you have, let's say, clean, within brackets, you have clean blood from the vent. So by those 2 small tubes in front of the reservoir, they go down and you can give it back. The thing is, you have a small blood-air contact here. So not all, let's say, the full deformers and so on. So small blood-air contact there. And if you draw blood, or if you get blood from your vent, you need to give it back to have your steady state. So that's why we put an EVO, an electronic venous occluder there. So just what comes in, you will give back. So you can put it on, mainly it's around 5 to 8%, depending on, but what comes in goes out and you have a steady state, which is very, very easy to use. This is on a Stockard. If you use, let's say, quantum, you have safe flow, you have purge flow. You can also, let's say, generate or link a pump for negative pressures. And then if the pressure becomes excessive negative, then a pump will run and add volume to the system. So that's also possible if you use, let's say, a quantum console. So it is possible with both consoles. So we use this for our mitral cases and endoscopic aortic valves, so in use of a pulmonary vein vent. So this is the mitral case. You see it's endoscopic. You see 3 working parts, opening the pericardium. Basically, everything stays the same. For a cannulation video, also a jugular cannula and a femoral cannula. This is opening the atrium. You look at the valve. You see here 2 stay sutures in the commissure, so no usage of atrial retractor. Working ports. First, he will put a suture, then he put the ring in, and then afterwards, if necessary, he will make some neocords. See, this is the ring, the flexible ring. You can get it through the ports. Also here, this is the sump. So the sump goes through the reservoir, down the small tubes, and then back into the system through an EVO. So you can really drain the patient well. And then checking the valve, making neocords as mentioned if necessary. And if everything is okay, then you will close atrium, and this is then the end result. So also in an alternative hybrid or a type 4 system, you can use a mitral. You can use a MiECT type 4. This is our, we call it yield AVR in our center. It's an endoscopic AVR. Just you see the aortic needle is smaller because you puncture through the thorax. We give the same cardiplegia for every case. Voila, you see, just gets in. What's here very important, this is a pulmonary vein vent again, through an EVO, because here is the right atrium on this side. So if you can't drain well, it will block the surgeon's view and it still pops up, which is very annoying and it's not ideal. So you need a good drainage and a steady state, and that's what we try to achieve, and that's why we put the EVO below the reservoir, so we can have really that good drainage, steady state, and nobody gets annoyed by the right atrium. See, it's still the automated knotting device. And if the valve is in place, you will close double here the aorta. You see good drainage. Voila. Released clamp, and this is the end result. So, as mentioned, this is the hybrid system. This is the mitral case. Here, through the mini system, the pulmonary vein vent goes through a pump, smaller tubes down through the reservoir, and then you can give it back by opening or closing the EVO, the electronic venous occluder. If there is a problem, say, particularly there is a PFO, you open it and you have air. Then it's quite simple. If you use this hybrid system, you see the clamp here, you release the clamp, replace it and put it here, and then you're in a conventional circuit. Up. And you open 100% the EVO and you're just in a conventional system. This is also ideal for if you're learning, let's say, MiECT, and in 99% of the cases, you know everything goes well. And then particular 1% of the cases, you need something and you have a problem. So this is quite easy just to convert to a conventional system. We put the vacuum controller on. It's not ideal, but because we do groin cannulation, gravity is not enough. What you also can do is put an additional centrifugal pump in your venous line. That's also perfectly possible, but we use it that rarely. That's why we just, if necessary, I think is also in 1% of the cases. So with mitral cases, endoscopic, you can do it, and also in endoscopic AVR cases, use hybrid system. There are some ground rules to attend. You have your pre-op screening, fluid management, It's very important. If your anesthesiologist gives, let's say, 1 liter in advance, you lose your advantage, but still you give the patient what he needs. TE is very important for cannulation part to detect in intra-atrial communication. For that, communication by the surgeon and anesthesiologist is also very important. If there is a problem, you have to deal with it right away. So everybody needs to take care of that. And the Montgomery classification. If you have, let's say, a sick aorta, don't go retrograde, don't cannulate the calcified vessels in the groin, just go axillary off direct into the aorta. So cannulation is very important also for outcome, but also during the case, the drainage is of big importance if you look at an endoscopic AVR, otherwise it will block the view. So to overall conclusion is, it is a team approach. Everybody needs to be, let's say, work together. If the anesthesiologist gives, as mentioned, a lot of volume in front, the perfusionist is diluting the patient, there's a lot of bleeding going on, that's not the way to go. You need to give the patient what he needs inside of volume. If there is a bleeding, in our part endoscopically, it's very sometimes it's very easy. Everybody looks at the screen. If there is a bleeding, you can attend the surgeon, and then he can solve the problem. Patient-tailored approach. In our case, we have 2 custom packs on the shelf, one for endocavities and also the hybrid system, the alternative hybrid system for, let's say, mitrals and AVRs, endoscopic part. Is it possible to have only 1 custom pack on the shelf, let's say hybrid system? Yes, it is. So you can choose whether you use MiECT or not, or conventional. So that's also possible. Hybrid approach, meaning that our cardiologists work together with our cardiac surgeon. As mentioned in the beginning, the objective is fully revascularization. So sometimes we do left, they do a stand at the right. So let's say the collaboration between the two is also of that importance. MiECT strategy, we talked about a circuit, but still it's not the circuit that is important. It is the strategy, so the team approach. And in my opinion, I think if you are using MiECT, you are forced using a certain strategy. And I think the strategy can work, not only the system, but still, you know, in the OR, it's a team approach. And then minimal invasive, it's not only small incision. In our center, we want to work towards a minimal invasive 360-degree. Was that the goal when we started in 2013 to do everything minimal invasive 360? No. The thing is, patient safety is the most important thing. So we start doing endocavities, then we went to aortic partial sternotomy, AVRs, and then our surgeon went from, let's say, a partial sternotomy AVR to endoscopic AVR. So we also made adjustments for our circuit, but still the key was patient safety. So it was not the objective, but yeah, bits by bits, we made steps to where we are today. So I hope you enjoyed this presentation, and I would like to thank you for your attention. Thank you very much.
Pascal, is there any questions or comments? Cyril, you're gonna?
No, I don't have.
I thought you were walking to the mic.
Moving around.
They're moving around. You go to the last one? Yeah. Listen, Pascal, thank you so very much. I think we're going to now carry on with the last presentation, which will be by Christy Smith from the Trillium Health Center, complex cardiac surgery procedures using MiECT. And take it away, Christy.
Can everyone hear me? So I will try not to take too long. I know I'm one of the last things keeping you between now and sunshine outside. For those of you that don't know me, I'm Christy Smith. I'm a perfusionist at Trillium Health Partners, which is located just outside of Toronto. And today I'm going to be talking about complex cardiac surgical procedures that we do at Trillium using our MIECT circuit. So we are located in Mississauga. They have at Trillium 8 full-time perfusionists. We opened our program just over 20 years ago. And annually we do about 1,400 cardiac cases. But over the years, our center has essentially specialized in 2 specific types of cardiac surgery. So the first being off-cab procedures. Our surgeons decided when they opened the program that they wanted to become the specialists in not only Ontario, but in Canada with off-cab. And throughout the years, they've still continued to do so. And then for all of their on-pump cases, we decided to embrace MIECT. So in 2005, we introduced our MIECT circuit. And at the time, we were just using it for ACB or cabbage cases. And then throughout the next few years, they started introducing AVRs and then, of course, your right-sided heart procedures. And actually, by 2009, we transitioned into performing all of our cases with MIECT, and we just had a conventional separate circuit as a backup. And if we fast forward to today, we actually don't even have a conventional circuit at our center. We just have our MIECT circuit, and I'll talk a little bit more about the specifics of that circuit as we get going. But before we do that, I just kind of wanted to address how many cases we do. So some of the data that I was able to access more easily is the last 5 years. So we've done 900 on-pump ACB cases, about 860 valve cases, and then a little over 700 combined cases or other cases. So that would be like a valve and a cabbage or a deep circ arrest case and a Bentall, something like that. So in the last 5 years alone, we've done about 2,500 cases, which is something I think we're really proud of because we are one of only 2 centers in Canada that is commonly using the MIECT circuit. And if we do a bit of an annual breakdown of our cases, you can see this one. In the green, we have our off-pump numbers. In the dark blue, we have our on-pump. And then, of course, we have TAVIs. So if we eliminate our TAVIs, we do about 55% of our cases off-pump, but then the other 45% are on-pump. So 22% of our overall cases are ACBs, 11 would be just straight valves, and then 12% would be those combined cases that I mentioned. So if we look at, this is the circuit we had in 2005 when they first started. They were using the S3. And if we have a little bit of a zoom in there, you can see we had the oxygenator, our sort of air purge control or venous bubble trap device, a centrifugal pump. And one of the things that they had at that time was the bag reservoir, and it was connected to this external suction source, which was a cell saver. And so for air removal, they would open, I think you can see right there, a stopcock, and then that would allow the blood and air to be suctioned, removed into the cell saver. So over time, we've actually progressed. This is our current circuit. So we have transitioned to the hard shell reservoir. And you guys have seen this so many times today. I'm sure everyone's very familiar with this. But of course, if we look at the paper produced by MIECTS, the different classifications. So I thought I would sort of break down our Trillium circuit just because I know you guys are so familiar with this. So of course, we have our, we call it an air purge control, but that's essentially the venous bubble trap going into our pump. We have our oxygenator. Of course, we have capacity for cardioplegia and vent. And then we have our hard shell reservoir, which is taking volume and air. And we can either return it back into the system or leave it in the reservoir. And then, of course, we have our recirculation line going into the hard shell reservoir as well. So putting us solidly in a type 4 category for our pump. So I know everyone sort of touched on other aspects of MIECTS today. My goal was just to share some of the specific, like very niche perfusion-oriented tips and tricks for operating these complex cases. So I apologize for any non-perfusionists. This is very detail-oriented, the next few slides. So we do have the physio-coded circuits. We use S5 console with the Sorin Revolution pump, the Inspire oxygenator. Our prime volume is about 850. Of course, that doesn't account for wrapping. If we aggressively wrap, we can get our prime down to as low as like 400, or at least that's, I would say, what's fairly typical. Just going over our circuit, I know it looks like spaghetti for a lot of people, so I kind of wanted to orient everyone. Of course, we have our venous line coming into our venous bubble removal. It comes down into centrifugal pump, oxygenator, and our arterial line here. So your typical AV loop, both 3/8 inch, of course. Then we have our air purge control system, right? So we have our bubble detector, the actual filter itself, and then it's connected. I think you can see this line that goes back here to our roller pump, which obviously takes it to our reservoir. Then we have our safety devices. So of course, we've all talked about the bubble trap, an arterial clamp. I think something that's really important to talk about and something that guides my practice absolutely every single day is your venous line pressure. And specifically in terms of safety feature, your excessive negative pressure. So that's one of the things that once you start moving away from your just straightforward CABG cases, but into your more complex cases, you're really going to have issues with your venous line pressure becoming excessively negative, and not only just dealing with that, but figuring out ways to resolve it. So we'll talk a little bit more about that as we go, and some of the safety features we have regarding that. Before we even get on bypass, though, we have to cannulate. We've already discussed this a little bit today. Of course, MIECTS is much more similar to kinetic assisted venous drainage, which means that we can use smaller default cannulas. The center that I was at that used conventional pump before, our default was 3646, and we reserved a 3240 cannula for just small patients. And actually, yeah, again, at our center, we pretty much exclusively, use the 2929 cannula for most cases, and the 3240, I would say, typically, unless the patient's BSA is greater than like 2.1, 2.2, I don't even reach for the 3240. So that's pretty fantastic. And yeah, after speaking with some of the surgeons before I came here, they all agreed that definitely it provides better visualization for them just having smaller cannulas. Of course, talking about wrapping, we do know it's a class 1 guideline. And of course, we've already addressed that today, so I won't get into too much aside from we definitely encourage everyone trying to wrap. Of course, the worst comes to worst, you just give the volume back. But I would also recommend just using caution in terms of those that are new to the mini pump, because your flows can be so volume dependent. Truly, an aggressive wrap can make the first few minutes of going on bypass a little bit volatile, and that's okay. It will pass with time, but like they said, don't panic, don't overtreat, because then you're just going to be dealing with other issues on top of that. So pressure monitoring. This is something I don't think a lot of people have talked about today, and there's 2 values I find myself looking at throughout my entire case. So my first being my CVP, right? We're trying to leave as much volume in the patient as possible, trying to prevent bringing it into our circuit. So your CVP is really going to be your best guide for, have I left too much volume in the patient? Like, is my surgeon legitimate when they're telling me right now they can't see anything, right? If is the CVP 15, I do probably need to drain, and that's when our reservoir obviously comes in very heavy. But the biggest one is probably the, again, venous line pressure. And we talk at our center about finding your steady state. So right when you go on bypass, you're going to have like a minute, maybe 2 minutes before you put on your cross clamp. And that's just enough time to find that steady state that's unique for every patient, where you can attain a flow that's as close to your full flow as possible without reaching a negative pressure that suddenly becomes so excessive, it will clamp out. So for example, this patient, I popped into my colleague's room one day. She was just below her full flow target. I think her cardiac index there is 2.3, right? Had a great flow, patient's doing really well, and her negative venous line pressure is hovering at -31. And she's happy she can have good flows. And then you'll typically find with these patients, say you're draining a little bit more than you're giving back, you have your vent on and you increased your vent and you didn't realize it, you might go a little bit more negative. Okay, you're -31, you're -35. And then you'll reach that point, that threshold, where it's different for every patient. But for this one, I remember very clearly, the second she got below -45, it would suddenly go down to -100 and clamp out. So if you find that steady state early on and hover near that, then that's a good strategy for preventing having those really volatile, like your circuit clamps you out because you've gone so negative and you have to try and get back on. So a simple thing, but really, really helpful for making it a little bit more streamlined. Air handling. So again, probably the biggest safety concern for everyone when you tell them about using a MiECT circuit. So for us, we have our bubble detector here. Any bubbles coming in will trigger my 1/4-inch roller pump that will remove both air and volume to your reservoir. It'll run for 7 seconds and will auto turn off. That's important to note as well, though, if for us anyways, if it's not detecting any bubbles here, but you do still have a large like wallop of air in your venous bubble trap, you would have to actually manually turn on that air removal device to try and get that last bit of air out. But very, very doable, very manageable. What becomes an issue is when you have continual air. I just did a mitral valve the other day where I had continual bits of air down my venous line the whole time. And the surgeon, to his credit, had tried absolutely everything. And he couldn't fix it anymore. It was to the point where he was like, well, we just kind of have to get on with the surgery. And that's totally fine. And there are ways of actually getting through the surgery safely. So for us, what you can see here, this is our fluid delivery line. So it comes from the reservoir into the venous just before the point of the bubble here. And you can see we have a partial clamp. So I know TGH has their occluder system where it will automatically return volume for you that you're removing. We actually just do it manually. We use 2 clamps, and sometimes it's just the difference of like a millimeter, clamping a little bit more, a little bit less, and returning your fluid. And so you can actually totally manage continual air down your venous line by just giving it back. Not ideal, but definitely doable and definitely safe. And then you still, of course, have another bubble detector here in case your venous bubble trap were to become overwhelmed with air as sort of a bailout. So again, this brings us to venting, which people have addressed again today, but so important because we are truly always leaving some volume behind. When I was speaking to one of the surgeons before I came, just asking him about his procedure, like how he's had to alter how he operates since using a MiECTS circuit. He said at his previous centers, he wouldn't even vent for an AVR. And that's just truly not possible for a minimally invasive circuit. And again, we've got the venous line there, so, or your venous, sorry, pardon me, your fluid delivery line there that you can use to return your volume. And yeah, that's when it comes back to your venous line pressure and sort of that balance of, am I draining more from the patient? Sorry about that. Am I draining more from the patient? Do I need to return back what I'm draining? Or is the patient actually just dry? Do we need to give volume? And your venous line pressure is going to be really indicative of that along with your CVP. One of the complications, of course, is cardioplegia delivery. So something like hemoconcentrating, that's based on your RPMs, right? It's passive. Something like your cardioplegia, which we use the Quest MPS system, is an active negative draw. So if say you have a large patient, you're flowing at 5.5 liters, your venous line pressure is hovering around -40 the whole case. You go to turn your plegia on, your surgeon says, like, crank it up, let's slam that root shut. Now you're actively pulling away from that. So you're adding more negative pressure, which means if you don't do anything preemptively to combat that, your venous line pressure is probably going to shoot down to -100 and your safety is going to come and it's going to clamp you out. So what a lot of us do is we'll actually temporarily just decrease your systemic flows the littlest bit, right? So say I was on an RPM of 2,400, I might preemptively drop my RPMs to 2,100, tolerate a slightly lower flow while I give my plege, and you'll actually find it's less volatile for the patient. Your NIRS will not be nearly as altered. Your SVO2 is not as altered. If you try and maintain your flow full and turn your plege on, you're going to clamp out and you're going to have quite a bit of volatility that's going to make it much more difficult to come back from. And then the one we probably get the most questions about are the deep hypothermic cases that we do. So I kind of was going to go through how we actually go about the process of draining a patient and providing antegrade cerebral perfusion. So we would clamp our arterial line, drop our RPMs to maybe around 1,000. That's pretty standard. Open your recirculation line, and now you're just actively pumping from the patient into your reservoir. This obviously wasn't a deep circ arrest case, so there'd be more blood in there. And then one of the other methods you can actually do is use your ACP device, right? You can turn it on low and slow and use that to assist your drainage. And then the whole time, of course, you're going to want to watch your pressures and your reservoir volume. Because our reservoir is located so high, you might have to increase your RPMs as well to generate enough of a pressure head to continue filling the reservoir as you get 3 or 4 liters in there. And then the last thing is just to let your surgeon know it's going to take a little bit longer. It takes like a full minute to truly drain these patients, which is excruciating when they're standing there staring at you being like, are you good? Can we go? But at the end of the day, it's only about 60 seconds to truly drain the patient. So once you've initiated your arrest, your patient has been drained, you've clamped your venous line, your reservoir's got a bunch of blood in it, you want to do antegrade cerebral perfusion. So very straightforward. You're essentially using the volume from your reservoir to provide to the patient. So you come down here, your venous is clamped, very straightforward. When it starts to get complicated, though, is when you're monitoring your CVP and you're watching your CVP rise, right? Because your venous line is clamped. You're on circulatory arrest. So as your CVP starts to rise and your venous line pressure is, I guess, not altered at that point because you're clamped, but your reservoir is starting to get empty, you're essentially just going to need to switch over so that you're no longer providing the blood from the reservoir, but you're draining from the patient while you give antegrade cerebral perfusion. So again, you're first giving volume from the reservoir, your CVP is rising, you're losing volume. Now, all you would have to do is clamp that fluid delivery line, open your venous line, adjust your RPMs accordingly. You do need to generally go up or down by about 300 or 400 RPMs. And now you'll be delivering volume from the patient back to the patient. Again, this is when paying attention to your venous line becomes really important because you're going to reach a point where you've drained the patient fully and your venous line pressure will go from -20 to -100 right away. And if you let that happen, you could potentially entrain air around the venous cannula site and cause an airlock, which you have to deal with later. So using that venous line pressure is one of your most helpful indicators when you're doing a case like this. That's pretty much all I have. I mean, going forward, one of the things you can see from our circuit, we don't actually currently sequester our vent and sucker blood. Our surgeons were very insistent that they wanted to use that blood at all times. So it's something we're looking at moving toward going forward. And then, of course, potentially adding in another bubble detector after the oxygenator, because currently we have 2, but we don't have one very downstream. And then, yeah, we're hoping to publish some of the data that we have been collecting for many, many years now, but have not gotten around to. So stay tuned for that. And that's everything.
Good. Thank you very much. Well, excellent, Christine. Thank you so much. I think just to close out the session, we were going to invite some of our resident experts to just come perfusion surgery and just have a general discussion perhaps about how we see the benefits of not only MiECT, but actually starting a program, what the impact is. If we wish to carry on with the program. Oh, that's good. We're well on time. Oh, sorry. Did I miss your opponent? No, where am I?
Cyril, you need to replace Pascal.
I'll bring a chair.
Oh, it's Christy. Yeah, oh, shit, all right. I shall finish my. Yeah, yeah, good stuff. A rose.
All right.
There we go. Yeah. All right. Now it's all you students have been filled up with all of this very stimulating information, and hopefully we have some questions and discussion points. Oh, here we go. We have a volunteer. Oh, here we go. We'll give you a mic.
So I'm Amanda from TGH, by the way. We started about 4 years ago, our program. And one of the things that I'm struggling with, I'm actually the educator at TGH, perfusion educator, is maintaining our clinical competency level because we don't do a high volume of cases. And it's not just for perfusion, it's the interdisciplinary team. So we do our cases sporadically, and every time I find that we have to remind, the key points for the whole team. So do you have any advice on what we could do to improve that? Or do more cases?
No.
Yes, we would like to do more cases, but our limiting factor is we only have 1.5 surgeon that's performing these cases.
So this is more than enough. If we have 1.5, it's good. The problem would be we have half. But let me ask, why do you do MiECT at your institution? Is it about the results you are about to have, or it is about the philosophy you get from using mini systems? What's your concept?
Both.
All right.
Definitely the philosophy, because it incorporates many of the concepts of best practice that we're looking for, and results, but we haven't done enough cases yet.
All right.
To really have some concrete data.
So if this is the case and you are seeking for both, not just the results, but also the more physiologic perfusion or surgery that you are getting with MiECT, then you don't mind using it into an ordinary case. That means a case that, irrespectively of the way that you will operate on, you'll have a good result. If we operate on me, that I have no comorbidities, I'm young, I have normal LV function, and you are doing a Lima LAD, you can perform either way, on or off pump, doing conventional, optimized circuit or completely closed, even type 2 circuit, no problem. But if you are an advocate of the more physiologic cardiac surgery, then you do it in every case. For example, what I've told you is that the maximum benefit or the benefit that you are seeking from such a technology, which is demanding actually, is to the high-risk cases. That means octogenarians that Dr. Elazawi is operating, or very demanding cases that we are normally doing in my institution, that are cases that have been dropped down from other surgeries and they are coming to us. But okay, fine. This is one way to do it. But as you said, when you are not having regular cases, how you will be able to cope with this type of surgery if you are just keeping MiECT for the high-risk cases? So for me, if you want to have the benefit to all your patients, you need to do it consecutively. Every patient that comes in your institution should come for MiECT. Otherwise, there's no issue of trying to find, the personnel, the team, or the case mix that suits you. So there is 100% suitable patient case mix for MiECT, and I believe that you should do consecutively. And also, same system. Don't interchange between the cases, and use the same team. 1.5 is more than enough. That means at least you have one, maybe two surgeons that follow. Find at least one, maybe two perfusionists, and one anesthesiologist, more than enough to make, the nucleus of starting these cases. But do it consecutively, every day, same technique, and then you will find results, definitely.
But I gather the problem is that you've only, out of how many surgeons you have at your?
2. Well, 1.5 means.
But do me actually, no, but I'm just saying that are all your surgeons using MiECT, or is it just the 2?
One?
Just the 2.
Yeah, that's the problem, isn't it?
Yeah, out of 8.
Exactly.
What's the problem?
Well, there's only 1/2 surgeons out of 8, so we've only got 2 surgeons every other day.
If they're doing every day, in a couple of years, they will find that their results are better from the other 6.5.
Napoleon would like to speak.
Yeah.
Okay, so the point is, if you have 1.5 surgeons, you shouldn't have 8 anesthesiologists doing it and 8 perfusionists doing it. So stick to 1 or 2 perfusionists and 1 or 2 anesthesiologists in order to have a mini team that gets some experience and then diffuse that experience to the others. But if you say 2 surgeons, but 10 anesthesiologists and 10 perfusionists, then those 10 will never get enough experience. And I think that might be a key issue. Otherwise, the other point would be you most probably do team timeouts, and this is the right time if you're doing something very rarely to discuss such issues.
Ideally, we would love to do it that way. And our perfusion group, we definitely can, and we've kept it to a smaller group, and we try to work together to accommodate the scheduling. But we find that the other disciplines don't stick to that plan. And so we expect to see 1 anesthetist in the OR, but it's not that person that was scheduled for the day, it's someone else. And that's sort of a workflow issue that I'm sure all centers deal with. But again, that probably also stems from having that champion really advocating for the cases. And really, I think that's what it comes down to. Thanks for your answers.
Maybe a bit more nasty to this. How many years? You said 4 years that you are using it. So why don't you make a registry and see these 4 years results comparing to the other guys, and do your internal data comparison? And if you are doing better, why don't you give it higher? I mean, to your director or to your CEO of the hospital. So what I'm saying is, try to see. What I've told you is our nursing staff knows when the patient is not a mini system patient, knows by feeling. So obviously it's easy if you go to your data bank and ask for data about the blood users, see the results from your 1.5 plus the team comparing to the rest, and then it's easy to convince some people to follow.
Yeah,
Right. So no. Let's ask the question: why the hesitancy? So this is exactly what we are discussing now. So what I said in my presentation, there are 2 issues about this question. One is ignorance, and the other one is difficulty. So going with the first, ignorance means 2 things: either non-exposure, that someone does not know. For example, some of these anesthesiologists that we are discussing, maybe they don't even heard of the word MiECT, and even if they are using it next door, they say, okay, I don't mind. It's low ACT case, nothing else. Second is data. Some of the perfusionists or anesthesiologists, surgeons, they believe that data is not enough, even though they are very easy believers in other topics. When it comes to something that is not in their interest or maybe in their radar, they leave it. So they say, no, data is not enough. So this is ignorance, and we need to explore why this happens. The second is difficulty, and difficulty comes with 2 issues again. One is complexity. Is it just demand that gives you the difficulty, or the second is discomfort? Because if it is about losing my easy day, then I would say, okay, don't follow that. And that comes with age advancement. The more you grow, the more you want to, do a lazy work. But about complexity, I would say is it really complexity, this thing? What you have said is what I have heard anecdotally from James Ferguson, you know, from Phoenix, Arizona, where he was having a school like this. He was running a school, and he said in one series, one full year of the perfusion trainees, they had as conventional the mini system, nothing else. So conventional for them meant MiECT. They have never seen what is the conventional configuration. So to them, conventional meant something different to what it means to Cyril. So it is always a matter of two sides. What is complex and what is not complex? For example, if you would go to a very elderly driver and give him a car with the full let's say facility that we have, not just the digital, but also automatic gear and everything, will say, what's this? This is not a car. But for us, this is the right car, isn't it? So I don't know what is complexity for a perfusionist, but for me as a surgeon, I would say, no, it's not complex. It's just meticulous. So anyway, these two words needs to be explored, ignorance and difficulty, and I will leave it to you as panel of experts. Why there is hesitancy in Canada then? Oh, you can.
Yeah, I would say definitely probably ignorance, to be very honest. I mean, I moved to Trillium because it was a great job opportunity and I liked the team. And it was sort of afterward, after I'd already agreed to go there, that I was like, oh yeah, they do this weird thing called Mini. And really, I've since realized that should be a selling point for that should be something that they're selling in the interview, that they're selling in the job description. So I think it's something that not enough people necessarily are out there advocating for it in terms of Canada specifically. So I mean, that's just my experience, right? It took me showing up to the center before I even realized what kind of a rare gem it was. So, Cyril.
Yeah, I just to add to that, I think, well, basically we started the program at Trillium Health Center in 2004. Actually, it was in 2005. That was 2004. 1 year. No, but and I've been trying to advocate ever since, right? Always going to Canadian Society meetings and that, but I think the problem becomes when it's just, it's very hard for one center. Well, that's just something that Trillium does, right? It's not, and I think we need forums like this, like what's totally envious in Europe is you have, there's a society and you have a Congress that everything, 25% of your cases are done on MiECT. I mean, that's phenomenal, right? So that's a lot of cases. So you have a lot of centers that are actually doing it. And it's a lot easier to convince other centers when you're, when there's, 25, let's say 25% of the centers are actually doing it as opposed to, one center out of 35, right? So it's just momentum. And I think we need something like this and continue with something like this to, to make sure that, we just get that momentum, because ignorance, you're absolutely right. It is ignorance. It has nothing to do with complexity. People think it's complex, but really it's still cardiopulmonary bypass. I always say that it's still cardiopulmonary bypass. You're still trained to do this. You just got to think a little different at times. But and as far as our center is concerned, the unfortunate thing for us is, we have a lot of, we have how many anesthetists? 30 anesthetists, 40 anesthetists, and it's very, very difficult for us to because we had, like, first when we started, we had 4 anesthetists picked for this, and everybody, we all went to Trillium, got everybody to Trillium and everything, and that's fine. And then when it's time to go, it's like, well, okay, yeah, but, oh, I'm post-call, I'm doing my research day to day, like, everybody, you really need that commitment, put it that way. And unfortunately, we didn't really get that commitment from anesthesia. We had the commitment from the perfusion. We have commitment from cardiac surgery. We still have commitment from anesthesia, but it's kind of like, yeah, it's waffly for sure.
So since I moderate, let's bring it to the anesthesiologist part then.
Yeah, well, I
because-
was just going to say, should we, is this something that we can do without anesthesia?
Look, what's the paradox here? Anesthesia.
And I'm sure a number of my colleagues would be more than happy to let you try that because I don't have to be on call.
So my question is, anesthesiologists are doing very well with perfusionists. Your fora are, let's say, more or less joined. I mean, you are having as an audience, either as a cardiac anesthesiologist, either anesthesiologist or perfusionist. The same is to us. As cardiac surgeons, we have either cardiac surgeons or perfusionists. A lot of societies, they do have. But between us, there's nothing. So actually, we are, let's say, connected through the anesthesia, through the perfusionist, nothing else. So why does this happen? I mean, is it because the surgeons are bullying the anesthesiologist? Is this because you feel, let's say, neglected by the team, or what's the reason of not coming to the team? I mean,
Yes. And
yeah.
what was the third one?
Right. So because this is
Yeah.
the problem. I mean,
It's a huge problem.
even in our society, if you see the numbers, the lowest number is
And
anesthesiologists, less than 20%. So why is that? Even industry is more. And I would say, why cardiac anesthesiologists are not coming on board? What's the reason for your low penetration to this technology?
Well, how do I address all of these? Firstly, anesthesia by itself, this is a personal insight you're all going to be sharing here. Anesthesiologists by themselves can't start a MiECT program. I put that right up there. We tried for years. And so it really.
No, they did start.
I have
I've
to make-
indicated that the very first publication was by anesthesiologists. They have started. I know the guys, Alois Philip, and
It's a key answer because what you've done, that is one of the major problems. Been there, done that, had a majority of problems, don't want to know about it. And that's exactly right. Our center was one of the first ones using the resting heart, I believe.
Exactly.
And I was involved in those cases. And what happened was air handling and excessive bleeding at the time were not, it was very problematic trying to deal with these issues. And that's one of the first things I said to you at the meeting in Thessaloniki is the modular concept has really changed the whole approach. You can cut in a reservoir, you have all of these options now. But I think for many people, they have had some brief experience more than a decade ago, going on 2 decades ago with quote, a MiECT circuit. It was nothing but problems and they've moved on, they think. And I think it's trying to get people re-educated. As you said, ignorance. The whole technology has changed so dramatically. We've dealt with all of these complications. And so, as you say, for perfusion students, if this is what they learn, it's just straightforward. It has a different set of issues, but once you know those issues, you can deal with it. I'm sure it's the same with surgeons and everybody else, but if one is well established in practice, and if you've already been exposed or heard about other members of your team or other people, 2 decades ago, that I think is a huge impediment. And as you say, it's getting people to realize that it has changed fundamentally. The safety, the modular concept, the safety, and now increasingly all of the benefits that are seen, admittedly in small trials so far, are all directionally pointing the same way. These patients do better. they do better for a whole multitude of reasons. But you know, getting that information across to people, and hopefully the comics trial and some of these upcoming studies will help convince people that, this truly is, you know, a revolutionary approach, a much more physiologic approach to bypass, but getting there.
Okay, so this is half. Means that you need first data to employ, I mean, to come on board. What I would say to you is that you as anesthesiologists are the leaders in the field of physiologic management, of exploring physiology into the bodies interruptively. So I'm really surprised how you as anesthesiologists, not yourself, I mean, the community does not take the opportunity of having a new technology and explore that through research. And what I would say is in our landmark paper 10 years ago, when we initiated the term physiologic perfusion, you remember we had two senior anesthesiologists, John Merkin, who studied the brain as an index organ of challenging perfusion, and Marco Ranucci, who studied goal-directed perfusion into the body. So if yourselves are advocating of MiECT as a means of more physiologic perfusion, why as a community, as a society, why you don't take the initiative utilizing this technology and doing research before having data? You get your own data and explore your physiologically need for having anesthesia. Why don't you do that then? Do you have other options to do research nowadays? You have explored everything, nearly everything. I mean, what's the point?
Well, the short answer is I would love to do these type of studies. But the simple fact is that I can't come into the operating room and tell the surgeons and the perfusionists, by the way, I got a study on tomorrow, so tomorrow we're using the MiECT circuit. I just don't think that's going to get me very far, or maybe a lot farther than I wanted, but it won't get us into the operating room. And that's the challenge. And that's what we're hearing. 1.5 out of 8 surgeons that are doing this. The other complicating factor is in most centers, certainly in Canada, North America, we've got 3 rotating teams. You know, you got a perfusion cycle of who's on call, who's not on call. We've got the surgeons, you know, scrambling to get time. We've got anesthesia rotations. And so it's very difficult. As you say, you train up some people that are, you know, well-versed and motivated, but, you know, they're post-call, so it's a problem. You have to have a dedicated team, and getting to that stage is very challenging. And that's why we're still talking about this.
Do you think, playing devil's advocate, I guess, do you think having a dedicated team, even if you did conventional bypass, having a dedicated team, you'd have a lot better results?
Absolutely. We all know that. You know, we can't even, you know, getting dedicated scrub nurses now. You know, so everybody, if everybody's familiar with everyone, the more familiar you are with your group and the expectations and the communications, it can't help but enhance the outcomes.
So let me bring the Germans into the match. Wait, we have the German type on. Yeah, we need him on the pitch. So I will revert the question, and I would say why Germany has this success story with MiECT, because 25% is cumulative in Europe. In Germany is 40%. That means really half of their cases are done on MiECT, and not the whole of the country.
But is that 40%? Would that be like, would all centers be doing MiECT?
No, exactly. No. So that means if you calculate that, there are some centers like, you know, Braunschweig, where Ashraf was prior to his post, now he's in Göttingen, that they're doing 100% as we are doing. That means there is something behind the, let's say, the motive in these centers in Germany that makes them leaders in the field. So why you have this kind of success and the rest cannot lead? Is it personal, or it is something, let's say, genetic or industrial based, or I don't know, something else that I'm missing?
Stubbornness.
Quite a difficult question, but obviously money plays a role. When you hear Cedar Gunaiding telling you that for a mini circuit, they pay 3 times as much as for a conventional system, and he cannot afford doing something like that in Turkey, that definitely plays a role. I remember at that time, that was more than a decade ago, when he told me that we were actually paying for our minimally invasive circuits lesser than for our conventional circuits, but we were the #1 center utilizing the mini circuits of Terumo, and one of our perfusionists has had a key role in introducing the RockSafe system. Actually, one of the reasons why it's called RockSafe is because he's called Schönrock, and they tried to dedicate that name to him. So that made it quite easy, because he was so dedicated. It was quite easy to convince the perfusionists of taking a significant role in establishing the program. At the same time, we had a fantastic chief of staff who was a very capable cardiac surgeon, and he was very communicative. So there was already an established harmonic atmosphere in the OR. We like our comfort zone, and if you once you leave your comfort zone, you have to be if you're in a hostile environment and Napoleon is shouting to you all the time, and you get a problem, and you know, regardless of how much knowledge you have, how much you are capable, there will come a time that you will face a problem. And if you're already afraid of what will happen when this comes, and it will inevitably come, and you know that that would be the end of it, then why put any effort into it from the start? Now switching from Braunschweig to Göttingen, I became confronted with the fact that there was a chief of perfusion who was formerly in Coswig, so he had quite an experience with MiECT, but the perfusionists, the anesthesiologists, they didn't have any experience with the system, and it was not a big issue convincing the anesthesiologists that this is a better concept. But I didn't go there from the first day and said, now we're going to wrap, which they didn't do before, and we're going to do a mini system, and we're not going to do I don't need cardiotomy suction, and so on. It took step by step. After establishing 6 months, just showing them I'm a capable surgeon and I can communicate, maybe we should start wrapping and see how it goes. And the one issue is you're talking to a physiologist. The anesthesiologist, we saw our lectures today, the most physiologically oriented lecture was that of Mark Bennett, which was terrific. So convincing someone like that this is the better concept is quite easy, but you have to show him and not dictate. And once one of the other advantages is when you're communicating from a surgeon to the perfusionist, or the other way around, the communication is mostly very time sensitive. We need to solve a problem and we need to solve it now. But if you communicate with an anesthesiologist, by the way, we will try to wrap today. Do you know what wrapping is? We'll explain what wrapping is. And we have our nurse, so there's no reason to panic, and we can stop the wrapping instantaneously and go on bypass. I have the cannulas in, and I have no problem in going to bypass immediately, instantaneously. If you get nervous, and maybe the first time you get nervous after, even the perfusionists, some of them didn't wrap before. And I get the feedback, we wrapped, I want to go on bypass. Okay, by the end of the operation, I told them that was quite quick. How much did you wrap? Yeah, 200 milliliters. Okay, let's try 400 the next time. Not this is ridiculous, that's not wrapping. No, you tell them next time, I think we could go for more. By the way, in Braunschweig, we wrapped around 800. And then you go back to the anesthesiologist and tell him, okay, just like Mark said today, it makes no sense when you see the drop in wrapping to give the noradrenaline. If you start wrapping from a low pressure, give the noradrenaline before. And this is something that has to be gain your own experience. And if you're communicating and then I'm proving that I'm right, next time you will believe me in something else. And so you have to take it step by step. And I don't see a great problem in that. Because at the same time, when we're going off bypass, again, the perfusionist, we are in a stable condition. The perfusionist goes to the anesthesiologist, tells him, well, going off bypass with a mini circuit is a bit different than the conventional one. And then when you try to convince them, the one thing that they always see at the beginning is how, and I always ask, I don't ask because I want to know. I just ask because I want everyone in the OR to notice what was our hemoglobin level prior to going on heart-lung machine. Okay, now we're on a heart-lung machine and we wrapped and we did everything. What is our hemoglobin now? We went on bypass and we didn't lose, went on bypass. Prior to bypass, we had a hemoglobin of 12.5 and now we have one of 12. This is ridiculous. Yeah. We didn't see that before. Maybe we should do that more often. Yeah, I don't have a problem. I don't have a problem doing it more often. We can do so. But now it's not me suggesting we should do that more often. When a perfusionist, the first thing I do when I see that during perfusion, the perfusionists switched, the first thing I ask is cardioplegia time. I don't care for the cardioplegia time. I know what the cardioplegia time is from my gut feeling, but I want to know, you know what the cardioplegia time is at the moment, but I don't tell. Okay, so there are a few tricks that you can use. When I teach someone in training, and he's doing his 20th CAPH or something, and I tell them, well, we'll do it with a mini bypass system. Don't be afraid. Just take it a bit slower than usual, and let me guide you. During the operation, I'm starting to tell to explain things that I know that he already knows. But because I have an anesthesiologist, I want to hear that too. But at the moment, I'm not teaching the anesthesiologist, I'm teaching. It's not so difficult. But if you want to be team leader, these are things that you have to take into account.
So from what I realized, you have a lot of Steve Jobses at your country and probably a lot of philosophers that, yeah. That's why
because I cannot.
I return it.
Yeah, maybe because we don't have financial issues as many other people have.
Good. So let me take me that. Yeah, and I'll ask Polychronis about that because he knows this very well. Just before having the TAVIs, the PubMed paper load in the literature was less than 1/3 from the time that TAVI was initiated. That means when the transcatheter with all the peripherals came from industry and they had 20 times more financial incentive, then all the research and all the paperwork exploded, and then we had a lot of guidelines and so on. And Polychronis knows that because he's teaching this. The same applies to when we have Lima to LAD with full sternotomy. That means zero money. I mean, it's just the stitching and maybe the custom pack for the CPP, no money. But if you do it robotically or the way that Pascal indicated with all these, devices that are having a lot of expensive consumables, then it's very easy for the industry to support. So I would go back to the question that was halfly answered by Ashraf. Is it financial incentive? That means companies that they don't have that much incentive with MiECT because it costs a little bit more and that's it. I mean, we don't have any more to offer. And that means they do not support. And then I will go to a second question relevant to this. Is this right?
Yes, I think that it definitely plays some role. Okay, because when the companies see that there's a whole new machine, that they can sell like other machines, maybe this drives them to promote it more. I mean, this is this clearly plays a role. It definitely is a question of publication and advertising as well. So we surely need to promote research, but this should appear, let's say, in every issue of a journal. The surgeons and the anesthesiologists need to hear about that all the time. Actually, the same applies to, I mean, when you see that the postgraduate courses of the anesthesiologists from the Anesthesiologic Society, they focus on transesophageal echo, which is not something new, So there are two training courses, the transesophageal echo training course, and the other course is blood management and coagulation, which is also something, but it's there. If I Google in Springer, I could find, let's say, 50 books on transesophageal echo and 100 books from hematologists, surgeons, and physiologists about coagulation. But this is still the postgraduate course. So it's something that they hear a lot and then they try to promote it. So if we try and publish the results, of course, we need the big trials. We definitely need big trials. We need to have data on a huge number of patients, randomized patients published in order, let's say, to make the societies, raise awareness and make the societies think that, okay, let's try to take this and create a structured program that could follow. And then if this is advertised.
Good. So let me bring it back to you, since you think this is, the ultimate. Why do you think ELSO is bigger than MiECTS? ELSO is having 175,000 registered cases so far in 40 years. It has more than 800 registered centers, and they are having about 65,000 ECMO cases per year selected, because you put your own cases there. I mean, it's not cumulative. You never know how many cases, are getting into the registry. Do they have a big multi-center analysis, or it is just CESAR trial? Do you have anything else? How many of their guidelines are evidence-based? Is the low anticoagulation evidence-based? Is any of the things that we were discussing last day with Ashraf? What about testing roller pump versus centrifugal pump into the long term? What about pulsatility? What about everything? Do they have any kind of results? No. So why do they have such a popularity? Is it because it costs 4 times more and it's just a fem approach or a fem jugular VV approach and nothing else? I mean, plug and play and then leave it. Why then a society that's having several multi-center studies, small ones, okay, fine, but we do have also a lot of meta-analysis, huge network meta-analysis, 27,000 cases, all of them indicate the same issue, and we don't have a single percentage of the penetration of ECMO. And also, I'm not jealous, we're doing ECMO ourselves, but what I'm saying is it right that we don't have justified data, or we don't have this financial incentive, or it's something else?
Yes, but in the case of ECMO, you either put this device in place or you keep your patient in the ICU without doing that. So there is still one, let's say, consumables and pumps and everything that you can use. Otherwise, you still keep the patient on the ventilator, on inotropes. So you actually increase your workload by doing ECMO. So if a perfusion is having 10 patients on ECMO, then he's having 10 machines running more for, let's say, 7 days per each. So it's, let's say, 50.
What if all these patient dies? All of them. What would you say? You treat them just because you have nothing to do? Is that, I mean, a valid therapy? So it's something else. What I'm saying is data are here. We do have, centers, we do have technology, we have physiology based, but again, something is missing and we know what is missing. We said it's ignorance. That is missing because people, they don't want to be involved and we don't communicate. I mean, if you ask anesthesiologists if they know about MiECT, do you know about MiECT? I mean, as a society here, Canadian Anesthesiology Society?
Not particularly.
No.
We've been overtaken by the echo faction.
No. Okay. So,
Yeah.
all right. So let me bring it back to you. You as anesthesiologists have produced huge initiative about patient blood management. I mean, what is patient blood management? It's relative to what I said to polychronis, to ELSO.
No.
It's just a diminutive to what we are doing with MiECT interruptively. So trying to do all these techniques, well, they brought even the managers and, teamwork with a lot of people into the hospital to allocate them.
Give you an example, the discussion about the proteining and the transamin. Yes.
So why don't you use MiECT in cardiac surgery and have all the results from PBM instead of doing all that and utilize all these resources to save blood, Okay, fine. Which is the best way to save blood? I mean, this is unanimous and you know that. So why don't you teach, not you, but the anesthesiologist, why don't you teach MiECT as a PBM?
Well, again, chicken and the egg. If none of the surgeons are doing it, it becomes a skill that you have that doesn't have any particular application. So we go round and around. And if the surgeon wants to do it and the anesthesiologist wants to do it and the perfusion department is just trying to make ends meet because they got so many other things to do. So they have no motivation, incentive, resources to learn anything. It's the same, it's always a chicken and the egg argument. And so as Ashraf was saying, as we all know, you need a champion, and pretty much invariably that ultimately has to be the surgeon, because the surgeon's going to decide what operation is going to be done and how it's going to be done. And it's going to be a beating heart or it's going to be on bypass. It's going to be on bypass or it's going to be on MiECT. So at every level, it really ultimately is decided by the patient, the nature of the operation, and the surgical approach to that operation, and everything else should follow suit. So if the surgeon becomes enamored, I was interested to hear the comments earlier about epi-aortic scanning. We've been talking about that for 25 years now. It's catching on, quote unquote. Until people want to change their approach, until there's no point offering a solution if you don't recognize a problem. So if there's no problem with the conventional bypass and what we're doing, then why should I change? And that's what we're trying to do now. We're trying to say, well, here's the problems you may not be aware of. You have a greater potential to transfuse your patient. They have a greater inflammatory response. Go down the list. And so, again, ignorance / information data is crucial in all of this. But ultimately, I think it really does have to come down to the surgeons. Anesthesia, when we introduce beating heart surgery, not a problem. You tell me what you're going to do and I'll try to help you get there. You want to put the blood pressure down, you want to wrap the patient, aortic wrapping, venous, whatever. You let me know what's going to happen and I can do my bit, understanding physiology to support you, But so it would be nice to raise the awareness. But again, if we start talking about MiECT at the SCA meeting, the anesthesia cardiac meeting, and it's going to be a sea of blank faces. Well, my guys don't do this. It's so chicken and the egg. How do we get there?
Can I ask you a question?
Not John. Kyriakis.
But I'm asking the
Yeah, I know you're not. Yeah, okay. Now I'm going to turn around on you. So it's all right to say, you know, well, cardiac surgery doesn't talk to anesthesia, perfusion, whatever. But what percentage? Like, if you look at cardiac surgery, programs, not cardiac surgery programs, meetings, right? So you look at EX, if you look at STS, AATS, if you look at these, say, 3 major meetings, what percentage of those meetings are there talks on MiECT? So how many surgeons, how many cardiac surgeons are out there showing other cardiac surgeons the benefits of MiECT?
Minimal. In United States, 0. In
Yeah,
Europe,
so
we
what's in
normally
Europe?
have every year one session, but it is perfusionist initiative. EBCP always invite us, and we always go every year. But again, it's
the same
perfusion
people.
initiative, and it's not cardiac surgical initiative.
Right.
So
I mean,
You're right.
maybe to John's point, maybe that's where we really have to focus is at the STS, the AATS, and all these, like, just get people to talk. And maybe that's why in Germany, 40%, because maybe there's more meetings talking about minimally invasive surgery.
There is a competition between the surgeons.
Yeah.
Who is leading this program in Germany? So there is a competition. That's why you will always find enough surgeons to speak. But let's be honest. If we get a financial incentive to do more MiECT, we can stop this discussion totally, because there is no doubt if we get a financial incentive, then everybody's gonna jump on this train.
So the only worry I have right now with this is, you know, Denise and Mike are going to increase from Medtronic are going to increase the cost of our MiECT packs by 400%. That's the only.
That's exactly what I just heard today.
Yeah.
So
I'll let you have it.
Let's hear Mike Medtronic.
Well, look, I'm going to represent industry, not just Medtronic on this one, but I think you guys touched on an important thing. You know, aside from the U.S. market, because let's keep that separate. That's a whole different nut to crack, and we'll get there eventually. But, you know, one of the things that you guys were talking about was the penetration of this therapy in Europe, let's say outside the United States, right? To say that we're at 20-25%, I mean, I can confirm that when I look at our custom packs in terms of are they like, are they circuits in class 1, 2, 3, or 4? We do that every year. I ask Laura, go back and check and tell me how many of these circuits in that configuration. We're at about 26%. Right. So the numbers that you guys are saying internally are with the group about saying, like, you know, how much of the market in Europe, Middle East, Africa is really covered by mini bypass. It's sizable. And, you know, so when you and I started here in Canada in 2004, right, we thought this is going to be something that would just take up automatically and pick up right away. And quite frankly, what we ran into was the biggest hurdle that you guys talked about as well today. Wasn't necessarily the cost, although that was a hurdle in the beginning. The technology was a bit of a hurdle, right? It took us and in LivaNova a number of years to kind of come up with systems, and you know, Terumo came up with the RockSafe. There was you know, McKay put some innovation into it when they first started, and then kind of backed off a little bit. But there was a long cycle there of innovation that really, I don't think we really got to a point where you could effectively do class 1, 2, 3, or 4 safely. Until probably about 2010, to be honest, with the configurations that were out there. And that's, you know, Professor Anastassiadis, that's when a lot of your publications started coming out. So the fact that we were at that point where we were at like a point where we thought, okay, this is just going to be like what happened with the bubble oxygenators going to the membrane oxys. That's kind of how we all thought about it in the early 2000s, and then realized that the biggest hurdle, to be honest, is communication within the hospital. I have a very, very specific criteria by which my guys will go in and do a site survey. And and there have been some big centers that we've gone in, like Bad Neustadt is a great example. You know, they wanted to do mini bypass. We walked in there and said, Jesus, no way. only because they don't talk to each other. And if the perfusion tries to say something, like even makes a squeak, the surgeon would turn around and yell at him. You know, that's just not the right center to be able to do this. Yes, they have the numbers. I mean, we're talking about a hospital that does 3,000 cases a year, but that's not the right center to try and do something that is so dependent on communication. And the other thing is that I would ask at the panel, which is the real reason I came up here. One thing that really helps, like, keep COVID out of it, because I feel like we've just all lost collectively the last 24, 30 months in terms of where we were before COVID, where we're now trying to pick up with closing the MIECT study, doing the next one that we're going to be jumping on. What we need, we're at a point now where once we get past MDR, right? Once we get past all these regulation changes, and by the way, the FDA is going to be changing their regulations too. So that's going to start having an effect in the United States. The FDA is not stupid. They saw what happened with the European Union, and now they're going to do something similar. Once we get past these regulations, we're going to be at a point where we're all going to be kind of looking around. We get past all this regulation stuff to keep what we have on the market and the investments that are going to be required to be able to do that. We're going to be looking to you guys to tell us, what do we need to take this to another level? We're at 25% penetration. I feel like we've got enough clinical evidence to start finding centers in the US to do mini bypass for sure. And we will do that. You know, Professor Anastasis, I gave you my word, we will do that. And we're going to revisit that now that I'm starting to spend a lot more time here in North America. But the point is that you guys have got to tell us what are you missing? What more do you need? Right? How can we continue to make this safer? How can we continue to make it safer for all pathologies? How do we make that learning curve less of a exponential curve and more of a linear curve? So instead of having to do 30 cases on cabbage to train a center to get them to feel comfortable, how do we make that faster? How do we make it better? So what I would ask you guys is that, and one thing I count on the MIECTS to do is to provide during those November sessions the feedback that we need to understand what we need to make you guys collectively more at ease, but also to make it easier to adopt this technology in hospitals that have never even seen it. The other part of it is that we will continue. When you look at, somebody asked, why is this so much easier to grow as a therapy in Europe compared to the United States? Well, in Europe, we've just got a whole bunch of different countries. And when you go and look, when you go to BELSECT or ScanSect, there are surgeons presenting on mini bypass. There are, and it's much more common to see that. It's not frequent, but it is more common than you'd see in Canada or North America. And it's not always Professor Anastasis that's doing the presentations either. There are surgeons that are out there that are talking about it. Yeah, it's absolutely. It's also Professor. Yeah, that's right. It's also Professor Al-Sawi. That's for sure. But there are surgeons now that are stepping into it, wanting to do it more. In Aris, a couple of hospitals in France, hospitals in Italy, they're starting to want to be able to present that more. So we are seeing surgeons get more engaged. And that's a real turning point, because when the surgeons are talking peer-to-peer about this kind of technology, it's harder for the perfusionists for sure, because it does represent a paradigm shift. But when the surgeons actually see the clinical evidence that's out there and say, oh, holy cow, I didn't realize that this is actually considered it's class 1A now, right? With the EBCP standard for the European Union, is that right? For the European
2A.
Society, it's
2A.
It's 2A. All right. Well, look, 5 years from now, it'll be 1A, right?
It was 1A and then it went down to 2A. I don't know how that worked, but.
No, it's Europe.
Well, the
One step backward,
the
two steps
difference
forward.
is they don't recognize the meta-analysis as one. So we would need comics or MIECTS to give the one. That means, yeah, we're very close, as Mike said. So
Yeah, well, look, my encouragement from speaking from industries, we need to keep this meeting going, right? This is very important. It is, look, ELSO is a whole different thing because ECMO is a whole different animal. I mean, that's powered by a lot of different things, a lot of dynamics, and quite frankly, industry puts a lot of money behind it because there isn't a lot of money in it. It is, that's the reality. But mini bypass or MIECT as a part of regular cardiac surgery, we just need to keep doing what we're doing and just keep plugging away and keep forcing it. And we do need to be able to get a couple of centers in the US up and running so that we have more advocates happening within AMSEC and within the STS, right? So I just need you guys to think about, what do we need next time? Like, what do we need to get to advance this a little bit further? So thanks. I'll get off my.
So
podium
thanks,
now.
Mike. What we would do now, there's no other question. We will have a statement. You will
I think
you will
what we
speak late.
need is a
You will speak
drink.
at the end because you are the president. So let's start with Christy.
You can't give a microphone.
No, a statement before we close. Yeah, no more questions. We need to be on time.
I don't have one prepared, but
No
thank you.
statement. Any message to take home? Nothing? No. All right, Ashraf.
It's not as scary as it looks. I'll say that much.
It's not as scary as it looks. Yeah, fine. Good.
We'll definitely reach a 1A recommendation. And I'm very excited to see if this will change anything. Because I'm not sure that will.
Okay, John.
Well, one of the things I'll say, just put in a plug for tomorrow, in that one of the things that will hopefully help somewhat swing the pendulum is going to be the results of the comics trial that we hope will be presented tomorrow. So we have some preliminary evidence comparing conventional versus MiECT. And we've also now commenced effectively the MiECTS-2 trial with a very solid clinical endpoints. So data will be coming, and I think that's ultimately what we need to persuade the great majority.
Yes, I believe in accordance with Mike Mandrill that actually there is a win for MiECT, even the optimized extracorporeal circulation. So we do not talk about the conventional, the old-time extracorporeal circulation, but there is a incorporation of certain certain parts in it, and all the machines there, you know, going for an upgrade for an advanced pulmonary bypass. And I think, I mean, it's a lot easier, you know, to swim if you know how to do it in an optimized fashion, to move then to MiECT rather than to move from the conventional old-fashioned cardiopulmonary bypass to this. And I strongly believe that the input from the industry and the input from the doctors, it's very, very important to have large-scale studies because they give you this 1A evidence. And also consider that we had European guidelines for the first time for cardiopulmonary bypass in 2019. So there was not guidelines. Guidelines are read by all, they are read by students, they are reproduced, and having that in the guidelines and having the industry pushing towards this, maybe a small change, you know, can actually explode, lead to an explosion in MiECT.
All right, the gold medal holder, Mr. President, will close it with the take-home message.
Wow.
Yes, exactly. Key message. No, this is your part later on. Okay. So,
The key message. No, I think, you know, I've been saying this for 20 years. Damn it. Been saying this for 20 years, but I think, you know, MiECT is here to stay. And I think it is the future of cardiopulmonary bypass, cardiac surgery. And I know we're not going to be able to solve this today at this meeting. I think we do need more penetration into the cardiac surgery realm. I think, you know, like I said, STS, ATS, even EACS from the cardiac surgery side. And as much as as a perfusionist, I kind of get jealous, or not jealous, or I don't know what it is, jealous or mad, or when cardiac surgeons get up there and talk about perfusion stuff. But I think we truly need that, right? I think we need cardiac surgeons talking more about MiECT. Yeah, and like I said, we're not gonna solve this today, but I do believe that we'll get a lot closer if we have a few more drinks tonight.
Thank you. So the moderator will close, reviewing the day and closing the session.
Thank you so much.
What's that?
So listen.
Oh, everybody, don't forget, you got to sign in too, to get points.
We haven't closed yet.
And lastly, I'd like to again thank everybody, including our AV team and the group in Europe with Live Media for coordinating all of this. From my standpoint, I think it's gone very well, very interactive. I appreciate all the questions and comments from the audience. And 7 a.m. tomorrow, be there, or you don't get your points.
Yeah.
Thank you.
Thanks for coming out, everybody.
How's that? Good.
One time.
Easy.